shared purpose, and it gives me immense pleasure to welcome you all to the workshop in CME on AV Fistula, hosted by Department of Burns and Plastic Surgery, AIIMS Bhubaneswar. I would like to invite Dr. Sanjay Giri sir, Organizing Chairman and HOD, Department of Burns and Plastic, AIIMS Bhubaneswar, to deliver the welcome address.
Respected President Apraso, Vibhuti sir, and our very dear guest faculty, Parag sir, who has come from a long way from the Mumbai, and all the delegates, offline and online. Welcome to this unique AV Fistula workshop, and also I forgot Dr. Saeed, who has just reached, even if he has this Eid, but he is so this for this AV Fistula, he told I will go. Okay, so welcome to all of you. AV Fistula is one of the important part, and it's an important domain of plastic surgery. And I think in these 2 days with live as well as hands-on demo in the tomorrow, I think everybody will clear all the basics and whatever advanced part required in the AV Fistula. It should be in the plastic surgery domain, and it will remain. That is why we are not allowed in this conference to any of the other like urologist and cardiothoracic. Even though they have asked for to attend it, we have not allowed. It is only for plastic surgeons. So I'll just briefly tell why AV Fistula should be done by the plastic surgeons and what is AV fistulas in just 5 to 7 minutes. After that, all our experts will tell all those things, and we can clear all our doubts and everything. So this is change हो रहा है ना? So AV fistula is a as you know, it is a stakes, reality, and the philosophy. And arteriovenous fistula is surgically created communications between an artery and a vein. So it is primarily used for the hemodialysis access, as everybody knows then. And high arterial flow causes the vein to dilate and mature, making it suitable for the repeated circulation. So the surgeon acts as a structural engineer. So we have the stakes, reality, and the philosophy has to be known, which will be told by our experts. So this is the standardized structural pathways like central venous catheter. AV fistula is the gold standard for those persons which is required. And why it is a permanent, and it is required arterialization of a native vein. And AV shunt is like a permanent AV prosthetic interposition graft. So what is the importance? First of all, you must know what is the definition of AV fistula before going to this CME. And AV fistula is surgically created communications between an artery and a vein. So primarily used for hemodialysis, whatever we have shown in this second picture. It appears simple, but the success mostly depends upon heavily on the surgical technique. As you know, radiocephalic end to side, brachiocephalic end to end, and end to side. A lot of procedures, anterior transposition of brachiocephalic. A lot of procedures are there which will be shown in the workshops. We have 8 cases. What is the importance of AV fistula? Because it is considered as the gold standard for the dialysis. As now next talk will be by our nephrologist, how the burden of CKD in India and how it is important for them this dialysis to have a better long-term patency, and also for the lower infection rates, and also for the lower thrombosis rates. So this is a permanent access. Now the site survey, all those things will be later told by our expert in this field. So for site survey like clinical history, physical examination, and advanced imaging, these 3 things are very important, which has to be looked after. And types of vascular access, as I have told already, AV fistulas, and a lot of things are there. So first of all, you must check for the edema, lightly tap veins and central compressions, palpate the bilateral radial, ulnar, and brachial arteries, and imaging color Doppler, as well as if you have facility, you can also go for the angiography. And the decision matrix, like which will be told by where to do, what to do, and what type of things should be done at what times, like rule of access selections and urgency and bridging, which are the sites at what time, what fistula you will do. That will be also told in the next lecturers. Site preparation, you must know how to do the site preparations, operative environment like small operative, superficial location. So frequently for the, as you know, CKDs are immunocompromised, so you have to be little bit of careful while taking your decisions. These are some anesthesia, like which mostly we do the local anesthesia, but still then we can use, like we have today 8 cases, out of which where we are using in 2 cases axillary blocks as well as brachial blocks, because we have to do in the anterior transposition of the brachial cephalic. But mostly we do in the local anesthesia. This is also like these are the different methods which will be told, also lateral, and this is not the right method. This is the last one is the right method. And this is the lateral terminal gold standard. We must know the anatomical angle where and how these things helps in maintaining this maturation of this AV fistulas. And the physiology of the thrills, which we usually do after the post-op, you must see the thrill, know your maturation is there or not, the AV fistula is acting or not, like the trigger and the hemodynamic forces and the morphological alterations, after which this has matured and you can feel the thrills. So all these things will be told by sir also. So I have just given you some idea so that you can see, and you can this live demo whenever we are going to start it in 11 o'clock, you can know that one. And post-operative care also will be, you have to be very gentle, strict use of loosely fitting pads, no restrictive bandages that could compress the superficial. All these are superficial veins, so you have to be very much careful. And immobilization, like temporary, partial, post-operative immobilization of the arm, which is highly advantageous to protect the fresh anastomosis. So the perfect access is moving a target, so we must know how to do, at what time do, which will be told by Parag sir and also Vibhuti sir. So with this, I will just end my talk, and we will proceed the whole of the things in a gradual way. We'll start with, I think Dr. Sandeep's talk is there, and after that we can, yes, Sandeep.
Thank you, sir. Next, I would like to call.
Respected teachers, senior faculty members, surgeons. At the outset, I would like to thank Sanjay sir and the entire burns and plastic surgery team first to organize such conference or workshop and inviting me here to stand before you. I welcome everyone to AIIMS Bhubaneswar again. So the topic given to me is CKD burn. Before doing fistula and all these things, we know how badly CKD has affected the globe and our country also. So that is the introduction. Okay. So before starting, I just want to tell initially when we started our department, because it's a new institute, new department, we literally struggled to get the fistulas done. Who will do fistula? We literally requested everyone, general surgeon, urology, plastic surgeon, everyone. Now after a few years, probably things are better. We are getting support, and plastic surgery, I can tell they are supportive. And I know that there are multiple departments they are doing, but still those who are into it, they should be given an opportunity. So coming to the topic, so before going to the burden, we want to know what is CKD. I am sure everybody knows that any kidney problem stays for more than 3 months. It is structural or functional problem. So kidney renal dysfunction and CKD little bit different. Somebody is having maybe AKI that recovers, but if the disease stays for more than 3 months, it is known as CKD. And one more term is ESKD. It is used very frequently. ESRD or ESKD or end-stage renal disease. CKD stage 5. That means here the accumulation of toxins, fluid, electrolytes. So we don't start dialysis. The survival is not possible. So this is the KDIGO classification of CKD. We all follow this one, definition and classification. So it is classified as per GFR and albuminuria. GFR is calculated by different formulas from creatinine. So once CKD stage 5, we tell that kidney failure or ESKD. And this is the point when we need to have patient needs support, external support, either dialysis or transplant, either hemodialysis, peritoneal dialysis or transplant. What are the common etiology? We all know that diabetes is the most common etiology all over the world. When we were undergraduates at that time in India, we are taught that we usually see CKD most common is glomerular disease, infective causes. But now the paradigm has shifted, and now the most common cause is diabetic everywhere, starting from US to Africa, and so also in India. So most common. Second, sometimes people tell hypertension is the second most common cause. That also varies from place to place. Yes, of course, diabetes and hypertension, they are most common causes, followed by glomerulonephritis, ADPKD. And one more thing I want to bring your attention is CKDU. So there are not only in our country, everywhere in the globe, in different pockets, different geographical areas, young patients are suffering from kidney problem. By the time they realize, by the time it is diagnosed, it is already late, advanced kidney problem. And we don't know they are non-diabetic, non-hypertensive, we don't know the exact cause, and that is known as CKDU. So that definition was not even, till now it is not uniform, but some consensus definitions were come, by that diagnosis is made, but still long way to go to diagnose the CKDU and find out the cause and manage them. And other ADPKD and genetic disease, these are all adults, whatever I showed you. In children, we all know that below 5 years, mostly congenital dysplastic disease, above 5 years, FSGS, lupus and other familial disease. Common risk factors. So what we can do for these CKDs, we have to find out risk factors and we can prevent them. Once we know that once there is CKD, there is no treatment. We don't have medicines, we don't have nothing we have, if it is a medical cause. So we have to prevent them. Like most common risk factors, non-communicable, communicable, we all know this, but nowadays what is more worried is everybody have diabetes. Everybody is now everywhere, childhood obesity, including our country, including poor resource restrained countries also, there is obesity is increasing. Then pollutions and use of canned and packet food, then smoking, all these things that are preventable, we have to be careful. So a lot of awareness program, everything is going on. So these are the risk factors we should understand. And any AKI, anytime you have acute kidney injury, there is a risk of CKD. So simple advice to tell them to follow creatine and urine routine, so we can act early to delay, if not completely prevent, at least delay the progression we can do. Coming to epidemiology, now I'll start from globally, then come to India. Globally, almost 800 million people. This is adult. Children are many more. It is not included. There is no proper study to include everybody. But mostly we are talking of adults. It is around 800 million people in the world, they are suffering. And this data comes from some countries where there is a proper registry, where there are studies are going on, not from many Asian and African countries where there is no registry, no proper data capture. So we are sure that the number is much more. And the way it is increasing. In 1990 it was 378 million, now 800, almost doubled in this span. And India is not behind, rather it is one of the, India, because population is 1/6, so the majority of CKD population, they are staying in India. China followed by India up to 140 million, that is 223 data, that is also patchy data, the number would be more. The prevalence has gone up to almost 15%, out of every 10, suppose out of every 100 population, 15 to 16 are CKD. So this is the thing to be worried. And recently this global disease burden study 2023, recently in 2025 came in Lancet. They highlighted, this data is from that paper. So almost 1.6 million people they are added in 2023 itself. For KTR, kidney replacement therapy, a lot of people are requiring. And the high burden areas, which are known as super regions, where the burden is much more than the global average, They are Middle East, South Asia, we are not behind, almost 15%. The global average around 12 to 13%, ours is 15%. People are suffering from CKD. And coming to the mortality, so this is a very bad disease, high morbid disease, we all know. So it is so the 1.48 million death of which CKD was the underlying cause in adults. And the mortality is much more increasing. It is increasing day by day. In spite of all awareness, in spite of improvement and advancement in healthcare, it is increasing day by day. And not only death, so disability life. I mean, if you are crippled, you cannot work, you are bedridden, you are at home. So that is a big burden on the society also. Death is not only. So this is what is the prevalence. You can see the arrow mark shows India. India is highest prevalence is 18 to 23%, and India is just above that, around 15 to 18%. But if you properly do take registry, the incidence of prevalence will be much more. So that is how the Southeast Asia, southern part of Asia, is a high burden area in the globe. So this is the list. Previously, from our UG days, we are aware that this ischemic heart disease, stroke, cardiovascular, the leading cause, and CKD is competing them. It is coming up and up. Now it is the 9th most important cause of death in 2023. Was a 10-year back, it was 12th important cause. And also it is the 12th major cause of disability life years. So this is creating burden of death, burden of disability in the society, everywhere in all strata of society. So this is one thing I took from KI, which is one published in 2021. You can see the trajectory. It looks scary. So in 2013 it was the 19th most common cause of death, and by 2040 it is going to be the 5th. It comes to top 5 causes of mortality in just another 15 years, 13-14 years. And the burden, you can see, it will definitely cause, now it is around 800, it will definitely cross 1,000 million. And the increasing death rate almost doubled, 50%, 41% addition of death rates, and that too. And now already there are few countries where it is the top 10 causes of death already in Singapore, Greece and Israel, some countries, because of various causes. Nowadays it's coming. Same thing in a different paper. I mean, the way it is increasing, why it is increasing also they highlighted, because increase in the diabetes burden, increase in cancers, and also infective disease. Some of the bacterial infections we have, we could control, but viral, HIV and all, they are again resurging. TB also we know in India it is resurging. All these causes contributes to this, and soon it is going to be the 5th most important cause of death. But more important is, suppose there is, the number of patients who are requiring renal replacement therapy, that means they are advanced kidney failure. Those who are having advanced kidney failure, this is the Global Kidney Health Atlas in 2009, is old, recently I didn't get anything, but this gives a picture that in 2010, there were people requiring KRT, I mean kidney replacement therapy, dialysis or transplant. Almost 10 million, but only 2.5 million are getting treatment. Just imagine, even in US, even in the best of the countries, the so-called developed world also, only 25-30% only people are getting a chance to receive RRT, renal replacement therapy. 70% not. Whereas in countries like us in India, low middle income, it only 10%. Out of 100%, they are advanced CKD, they are requiring only 10%. So I am telling, yesterday night we have at least referred 10 cases from our casualty. We don't have space to do dialysis. And they are doing dialysis somewhere where technician is running the show, little bit of breathlessness, they are referring. They have gone to SCV, they referred, they came here, we referred, where they will go? They will die, on the way they will die. So this is what is happening, and this is the reality. What to do? The dialysis unit, they are overburdened. Even 24 hours, we are running our dialysis unit 24/7. Still we are not able to cater. That is the scenario, everyday, daily scenario. That is in Bhubaneswar, in capital I am telling. Forget about rural. That is they don't know also that they have died of CKD. And so this is the gloomy situation. Only 10% of our people, those who need RRT, they are getting the treatment. And CKD and what happens in India? In India, the problem is true burden is not known. Why? Because lack of universal access to RRT, and we don't have a registry. There is no registry. In outside countries, if you go to Australia, Canada, I'm sure many of us might have gone. So they have a registry, everything. They have a registry. Now, Government of India is already starting registry for cancer, for diabetes, and kidney CKD is coming. Though there is a project going on, I am also part of it. State government is planning to bring a CKD registry. So CKD registry along with dialysis registry. So it will take some time, but it will come. So that's why we don't know the burden. And 90% of people, those who need renal replacement therapy, they die before they get dialysis or transplant. And those who even we start RRT, 60% they stop within 6 months because of resource constraint, because of family burden. Government is giving free dialysis, like Pradhan Mantri dialysis Yojana, that is covering that. Rahi Care has taken that collaborative. State government is giving them land, infrastructure, and central government is providing machines, technicians, salary and all. Every district there is, when previously our relatives were there, those of CKD, they used to go to Kolkata for dialysis or SCB, MKCG, 1 or 2 places. Now every district there are dialysis centers. In Bhubaneswar itself there are more than 30 dialysis centers, but still it is less. And they are stopping dialysis because it is family burden. Those for our dialysis patients, those who are coming, they are telling, sir, we don't have money for traveling also. To come and do thrice a week, coming to a center, going, and that's really a true burden on the society. And out of that, somebody has a stroke, somebody is having amputation, that still increases burden. And every year there are almost 2 lakh people of ESKD are getting added in India. And if you take total CKD, those who are having stage 3, 4, 2, it will be, I'm sure it will be more than 5 lakh people every year. How to manage this? So it's a huge burden. And we are mostly dependent on hemodialysis because PD is a distant third. Even PD has gone down below transplant. Second is transplant. We know that requirement for organ in lakhs, but we are only able to do 14,000-15,000 per year. That is what data is there. So the burden on dialysis is much more. And the number of dialysis stations, what I am showing, this is 2018 data. Now it is increased much more, but still the patients has increased beyond that. The increase in patients and increase in dialysis centers are disproportionate. And hardly 10,000 patients are on PD. So this is a study which is published in Nephrology in 2025 to show in India state-wise what are the areas where, like Eastern zone, if you see 8.6, in Southern zone it is 14%, but I am 100% sure the data is very patchy and not proper. If we what we are seeing is much more than that. But this is one study, at least some studies there to tell that in Eastern and Western zone it is much more. Northern little bit less, but the Eastern zone also they are increasing. The number is increasing now. The percentage is more around touching 15%. And this is one what Indian Society of Nephrology, some enthusiastic seniors, they started CKD registry. When I was in Vellore that time, they were also involved. So, but registry it could not continue. This data what I am showing you is 2012. Whether nobody cooperated, but there itself is a manpower burden and all. So, and if you see the bluish line, blue portion is advanced CKD. You can imagine out of 10, 6 are advanced CKD by the time they are diagnosed. This is more dangerous. Diabetes and all, why we know there is a medicine we can control, but by the time we know CKD, that is already advanced and we don't have anything to do. And so this is what is the data. Now it has much increased, but I just wanted to show some Indian data just to have an idea. And you see the red portion, the renal failure death rates among Indians. It was in south, it was very patchy little bit. Now it has gone up to everywhere. The whole south, so we tell that in the coastal belt, the whole of Bay of Bengal, I don't know what is there in Bay of Bengal, from everywhere the CKD is increasing like anything. And we don't know the exact cause. Somebody is telling water, somebody is telling soil, somebody is telling heavy metal, but exactly we don't know the cause. And so the prevalence of CKD is 128 million cases, that is representing almost 10% of Indian population. Every 10% one is there, and this is 2021 data. Though it is patchy, something is there. and the deaths almost 2 lakh, 1.8, 2 lakh, which is 3%, 2.5 to 3% of all deaths. So gradually it is coming up to top 5. And there is 38% within a span of 10 years, there is 38-40% increase in death because of CKD. And men are majority, their deaths are women, they survive better. Women are hard fighters, we always know. And then the burden, why it is increasing? It is true for whole globe. The increase, now we are the diabetic capital. Now we are going to the obesity capital. Every capital is going to be India. So is CKD capital. So disease burden has sharply increased. 80% elderly population is again it is problem. Increasing age itself is a risk factor for CKD and death. So half of the patient who what we see and more than 50-60 years. And the major etiology is diabetes and hypertension. So here not only nephrology, not only medicine, not only plastic surgery, everybody should join hand together. This diabetic and hypertensive patients should be taken care of, because most of our patients are uncontrolled diabetes, uncontrolled hypertension. There we can act before it is too late. And so now a new term is coming, CKD hotspot. What is that? In news, in media, we are seeing CKD hotspot. These are nothing but specific geographic areas or communities or ethnic groups with a significant higher average rate. So the global or Indian average is suppose 15%. So now 20% we are seeing, we might be heard of this Badamba Narsimhpur area, Nayagarh, some Sambalpur Bargarh area. So those every patient, there are many pockets where villages, in every household there are CKD patients. And the cause, that's what we are talking about, CKDU. They are mostly daily laborers, agricultural farmers, where they don't have good health facility. They are having this one. There is only symptom is easy fatigability, loss of appetite, loss of weight. By the time we check, creatinine is 5, creatinine is 4, hemoglobin 6, 7, no edema, output is preserved. So the early diagnosis is not happening because we are not screening and they are not symptomatic. So that is a big burden. So depending on that, few classifications is made, either geographical, environmental type, another is socially determined type, like environmental, like this CKDU is not only in Odisha or India, it is there in different pockets. It started from Mesoamerican nephropathy, where mostly farmers and sugarcane workers, they are there, which they are exposed to heat stress the day long. They don't take frequent breaks, they don't drink proper water. So those are the postulations made at that time, and the name was made Mesoamerican nephropathy. In India, in Andhra Pradesh, there was an area known as Udanam. This is Odisha border. Udanam, there are every household there are CKD patients, though named as Udanam nephropathy. Todai Mangalam nephropathy near Jipmar people, they came out in Tamil Nadu. Now in Odisha we have not given any name, but this is again. So Sri Lanka in 2017-18, there's like a epidemic outbreak. Every household there are CKD. So they found out, and so different type of causes or etiologies has been postulated, and socially determined type, like now war zones are going on everywhere. Half of the world at war. They are not getting proper food, no vaccine for children, no hydration, communicable diseases, socially vulnerable group, we tell that, and high poverty. Certain areas are coming out of poverty, and again certain areas are going to socially determined. The common drivers are occupational hazard, the dehydration, agrochemicals. We have too much use of pesticides, insecticides, using heavy metals. Those things, and genetic factors, of course, like APOL1 gene in African population. We have not found out any specific gene in Indian or Asian population. So major hotspots, as I told, Udanam nephropathy in India, Andhra Pradesh, Sri Lanka, Mesoamerican nephropathy, they usually affect young farmers. So this is almost 20%. The rate is, the prevalence is almost 20%, which is much higher than the global or national prevalence. That is why this area is known as hotspot. So to conclude, estimation of CKD prevalence and risk is important to develop priorities and plans. So we need to know what is the burden, how much are CKD number, how many are requiring RRT. Then only government will come up with plans and policies. It continues to rise. There are now many medications we might be aware of. We are finding medicines like SGLT2 inhibitor, GLP1 inhibitor, ASARB. Lot of medicines are coming to retard the progression of to reduce the cardiovascular mortality and retard the progression. Still nothing is properly useful. Of course, they are retarding to few more years. Otherwise, in spite of that, burden is rising exponentially. Urgent action are required to address the data gap, CKD prevalence and cause, and we need to make the therapy available everywhere. Then only people can be benefited. So thank you so much for your patient hearing. Thank you so much. Southern and western, that was more, whereas eastern zone and north was the least. That is because they told that it is because the availability of data capture, electronic media. In South India, where I was working, Vellore, from 2000 they have a hospital information system, whereas government hospitals now they are adopting after 25 years. So likewise, in the private sector also, they involve themselves more. Probably that is why they have some type of record where you will get the data from some type of record. We don't have eastern part, not much, and northern also only Delhi and few areas they have good healthcare. Otherwise, it's not there because of better healthcare facilities and because of better data capture. Probably that is what they discussed. But overall, almost similar, 14 to 15% they are getting affected. And also it depends on the burden of diabetic and hypertension. More diabetes, hypertensive, there the CKD will be more. That is
Any
what.
specific metals in the water that causes? Water, metal, presence of metal.
Metal, they studied, they are telling that heavy metals, we know lead, mercury, all these are culprits, but there is no concrete data.
Registry.
Some areas, they are telling that is why government has set up filters, they have abandoned the deep wells, bore wells, they are giving government supply water, but that didn't solve the problem really. Okay. So we need to find out exactly, yes, one of the culprits, heavy metals, whatever is the permissible limit. Even now recent, a lot of you might be aware of, I want to tell everyone the cream, fairness cream which are using, which contains mercury which is much more than the permissible limit, which causes membranous nephropathy.
Okay.
So I always tell that avoid these fairness creams. Whatever fairness God has given, that's enough. So those are the problem. That's why we don't know. Without unknowingly we are using many packet foods, many cosmetics, soaps. All these things, they contain lot of metals and minerals which is much above the permissible limit, that don't cause only kidney problem, other problems also. So that we have to be very careful. Thank you. Okay. Thank you. Thank you so much. Thank you everyone.
Thank you, sir, for your valuable insights. It's now my privilege to invite Dr. Bibhuti Bhushan Nayak, sir, to deliver his talk on applied vascular anatomy for AV fistula surgeons.
1 minute. They will after, please. Duplicate kar. Kaun korcho eta? Mouse are. Extend kai korto? Paunu.
Very good morning to all of you. At the outset, I must congratulate Dr. Giri for holding the first AB Fistula workshop. So he and his team have been on the forefront of education and training in plastic surgery. Now we just heard the talk on the CKD burden in the country, the alarming rise in the number of cases. And for that, the lifeline is AV fistula. Dr. Parag, who has been the invited faculty, you must all know that was the first to start the AV fistula workshop in 2015 in Pune. And in the last decade, the plastic surgeons have been in the forefront of AV fistula creation. And amongst all the specialties that are taking up AV fistula, I think the specialty that is best equipped to handle AV fistula is the plastic surgery specialty, because the microvascular training and the vessel handling capacity is the best with the plastic surgeons. So AV fistula is what is the lifeline of the CKD patients, and we need to create an accessible vessel through which patient can undergo dialysis. And when the fistula is not possible, obviously, we have arteriovenous graft. So AV fistula is the gold standard vascular access for long-term hemodialysis in patients with chronic or end-stage renal disease. So it's a connection between the artery and vein to provide high-flow access for dialysis. That means we have to be familiar with the vascular anatomy of the upper extremity especially, and it is most commonly created in the non-dominant upper limb, and distal sites are more commonly preferred over proximal sites for obvious reasons. So the basic idea is to anastomose the end of the vein to the side of the artery, so that the arterial pressure gets transmitted into the vein dilates, becomes arterialized, and is suitable for repeated cannulation from a superficial approach. So the arterial anatomy, what is pertinent to us is the brachial artery and its branching the cubital fossa to radial artery and the ulnar artery. These are the vessels on which we have to focus in a AV fistula. So axillary artery, you all know, continues as the brachial artery. So the axillary artery continues as the brachial artery, and it runs in the medial part of the arm. And in the cubital fossa, it divides into radial artery and the ulnar artery. And the radial and ulnar supply the muscles of the forearm and in the hand and to the fingers by forming the palmar arches. Radial artery is most commonly used for AV fistula creation in the wrist. So brachial artery is the continuation of the axillary artery at the lower border of the teres major. It runs in the medial part of the biceps.
There is some problem in the
So the brachial artery is at the arm. We are interested in the lower part. In the upper part and the middle part, normally we don't do the creations. The brachiobasilic or cephalic is done in the lower part or in the cubital fossa. So there, what is more important for us to understand is the median nerve, which remains laterally in the upper third, anteriorly in the middle third, and in the lower third, the median nerve remains on the medial side of the brachial artery. So in the cubital fossa, it divides into the radial artery and the ulnar artery. The radial artery is the smaller branch, and the ulnar artery is the more dominant branch. Okay. So the brachial artery is used for brachiocephalic and brachiobasilic fistula. And in the cubital fossa, you have to remember the relation with the median nerve, which is medial to the artery. Radial artery is the smaller terminal branch. It runs in the lateral border of the forearm between the FCU and FCR. And in the distal third, it's most superficial, therefore we see the pulsations there. And this is the area where we prefer for the fistula formation, the radiocephalic fistula. All these connections are made to the superficial venous system because we want a superficial access. So we must know the anatomy of the superficial veins. The veins of interest are the cephalic vein, basilic vein, and the median cubital vein. So the veins, they arise from the dorsal venous network of the hand, and they run on the lateral border and the medial border of the forearm and the arm, and then into the axillary vein. The cephalic vein runs along the lateral side of the forearm and arm, drains into the axillary vein, and it is most commonly used for the AV fistula because it's in the superior border or the lateral border, which is easily accessible. The ulnar border becomes difficult when the patient lies for a long time. And it is used in radiocephalic and brachiocephalic fistula. Here one has to know the relation of the superficial radial nerve, because in the distal part of the forearm, you know, the superficial radial nerve is very closely associated with the cephalic nerve, cephalic vein. So one must not injure or handle the superficial radial nerve. In some patients, you will get complications related to it. The basilic vein runs on the medial forearm and arm. It has a larger diameter, but it is deeper in the upper arm. So therefore, when you do a brachiobasilic fistula, it needs to be brought superficially or transposed superficially. So these are the this is the classical or the most common AV fistula that we do if the vessels are ideal and all the vessels are available. Our most preferred site is the radiocephalic fistula. You might ask, the more distal is the site at the snob box. Yes, we can do it, but most surgeons prefer at this level. So the common fistula sites are the radiocephalic, brachiocephalic, or brachiobasilic. But here again, we can take advantage of the perforator between the deep vein and the superficial or the cephalic vein close to the radial artery. That is the Graz fistula. So the radiocephalic fistula is anastomosing the end of the cephalic vein to the side of the radial artery. People also do side-to-side anastomosis. In certain situations, end-to-end anastomosis can also be done. But the most common or preferred fistula is the end of the cephalic vein to the side of the radial artery. The details of the techniques will be discussed by Dr. Parag. And here I was talking about the Graz fistula, when you have a perforator between the deep vein and the cephalic vein in the upper forearm, and you can take advantage of this perforator. And this is a very good fistula, the Graz fistula. And when the vessels are not suitable, one can think of using a arteriovenous graft, where you use a Teflon tube for the fistula creation. Brachiocephalic fistula is doing the fistula, the end of the cephalic vein to the side of the brachial artery. It's usually done at the elbow or just in the lower part of the arm. Brachiobasilic fistula, this is where you require the basilic vein to be superficialized because in the deeper plane. This is also, this requires a longer incision to superficialize the basilic vein. This is the most distal fistula that you can do, that is this anatomical snob box, but this is not a very popular site. Mostly it's the distal wrist. So the preferred limb is the upper limb vessel, then the lower limb vessels, and non-dominant arm should be selected because the patient's dominant arm has to be left free for day-to-day activities. One must protect the potential access vessels. We have seen the burden of the CKD, and the patients who are potential candidates, one should protect the access vessels very early into the disease. avoid repeated venipuncture in the forearm, avoid intravenous cannulation in the potential fistula veins, avoid invasive monitoring lines in these vessels. And access should be done, or the fistula should be created as distally as possible, because the patient who live longer, they might require multiple fistula. The fistula that you have done today may not be functional a couple of months later, a couple of years later. So we have to plan in that manner. So we have to do the most distal fistula first. So this allows future access procedures if distal fistula fails. Vessel selection is the most important, because the quality of the vessel, they will decide on the success of the fistula. So the CKD, which is usually seen in the age group beyond 60, you encounter atherosclerotic vessels. And the vessels which are grossly atherosclerotic, it's very, very difficult to create a fistula, because even your scissors, even the blade will not cut into the wall of the vessel. So leave aside taking sutures. So one has to avoid atherosclerotic vessels, go more proximally, or select segments where they're less involved. Choose veins with good caliber, diameter, and patency. So many times you have dissected and you find the vein diameter is not good, and if you cut the vein, there is no backflow. You have to be careful. You have to be sure about the patency of the vein as well. And again, when we are selecting a vein, a long segment of the vein should be available, because that's the access vessel for the fistula. So for fistula, we need, it should allow easy cannulation, therefore it has to be superficial and on the superior border or the lateral border of the hand. And position should ensure patient comfort during dialysis. And we should select straight superficial vein segment and not the curved veins. The rule of 6, you all must know who are involved with the fistula, that the diameter of the vein should be at least 6 millimeter, and its distance from the skin should be less than 6 millimeter. The flow rate at the fistula site by the end of maturation, that about 6 weeks, is about 600 ml per minute. And the linear segment available for cannulation should be at least 6 centimeter, but ideally it should be 10 centimeter or more. So in the event of fistula, you can encounter stenosis at different sites, which will be dealt with by Dr. Parag in the next lecture. So we can have the inflow stenosis, that is the atrial stenosis, or juxta-anastomotic stenosis, this is more common, and outflow stenosis. This can be clinically known by just palpation, by clinical examination, by auscultation, or if you have doubt, you can also do a duplex ultrasound. The dialysis machine itself will be able to pick up if there is any problem with the fistula. The arterial pressure is usually between -60 to -200. If it is more than that, then you think of inflow obstruction. And when the venous pressure is more, it should be usually around 110 millimeter mercury. If it's more, then you suspect outflow obstruction. So if it's beyond -260 arterial pressure required for your dialysis, that means there is an inflow obstruction. And more than 300 on the venous side implies outflow obstruction. So the fistula selection should be patient-centered and vessel-guided. A successful AV fistula creation depends on individualized vascular assessment. The distal first should always be the principle to preserve for the future. So prefer the distal sites, that's the radiocephalic AV fistula when feasible, and maintain the proximal vessels for future access. Preoperative mapping improves outcomes. So routine clinical plus duplex ultrasound evaluation is helpful for better maturation rates and reduced primary failures. Vessel quality should always take precedence over location of the fistula. So the vein should have adequate diameter and There should be a venous return after the vein is cut. Arterial inflow should be good, and the wall quality, they are critical. So avoid marginal vessels if anatomically convenient vessels are there. You should always go for vessels with better quality than a vessel which is more anatomically or conveniently located. Multidisciplinary planning enhances our success. So there should be collaboration between the surgeon, nephrologist and radiologist. And early referral and longitudinal planning access for the future should be done. Long-term perspectives matter. So think beyond the first fistula. Plan for lifetime vascular access strategy. So right patient, right vessel, operated at the right time will give you the best result. So distal first fistula should be done to preserve for the future. Ultrasound mapping is non-negotiable to have better outcome and better planning. The quality of vessels should always get precedence over the anatomical convenience, and plan access as a lifelong strategy, not as a single procedure. The best fistula is not just the first one that works, but the one that preserves the patient's future. Thank you.
So we have a question.
It's individual, it depends on the patients. So when you get a patient where the artery quality is good and the vein is good, your success rate should be 100%. In the hand of a trained surgeon, the success rate is 100% if the vessel quality is good. All the vessel quality depends, dictates the outcome. Obviously, next comes how well you take care of the fistula, and the technician who gets the venous access. There are patients where the fistula worked for 8 to 10 years. Some patient where we have done fistula patient have lived 10 years and died without a second fistula being done. There are patients where the fistula have failed after 2 weeks and have undergone another fistula. So it all depends on the quality of the vessels.
Sir, suppose a patient, we have planned for surgery and the patient's vein or artery has been pricked today only. Then what should we do? How much should we wait for the fistula creation?
See, whenever you create a fistula, most of these patients already have a central line, majority of them. Or if the patients don't have a central line and they are coming for a fistula, they are already under the supervision of a nephrologist who have already instructed them not to take any pricks on the hand to be used. It's very unusual to get patients like that. But if there is a single prick either in the artery or vein, you can just go more proximal to the prick site and do the fistula creation. It's not a problem. But what is more important is what is the quality of the artery and the vein. That's more important.
Sir,
Even by the same logic, suppose you are, I think you are a plastic surgeon and you might have seen radial free flaps. Many times, same flap, the same forearm, the cephalic vein has been pricked. Still we go ahead with the free flap. Not a problem if there is a single prick.
Suppose I want to wait, I do not want to miss the opportunity to do the AV fistula distally. So how much should we wait, or should I go forward by examination only, or we should go for color Doppler again?
See, before any fistula, if you have color Doppler mapping of the veins and the artery, that is the best. So a good clinical examination and radiological workup is not only required for your first fistula creation, but you're planning for the future, because there are chances that the patient is going to require more fistula in the future. So your planning should be longitudinal. So if you wait few days and you have time, you can wait, no problem.
1 week?
1 week is enough. So one prick in endothelium will heal even in 24 hours. So maximum is 1 week you can wait.
Thanks.
Thank you.
I would now like to invite Dr. Tara Prasad Tripathi to deliver his talk on preoperative planning and Doppler mapping.
इनका खाली क्लोज कर हाँ सर अब कुछ नहीं क्लोज कर लो पूरा
लेजर पॉइंटर टेडी लगे दो नहीं नहीं सर मैं बैठे लगे तो चलेगा पॉइंटर इतना ही करता हूँ
नहीं
ଆସିବ ନା ଆସୁଛି ତ
ଜୁମ୍ରେ ଛଡ଼ା ହେଉଛି ତ
ଆଚ୍ଛା
ଜୁମ୍ରେ ଦେଖୁଛି
Good morning. So, in the next 10 minutes, I will be covering regarding the pre-operative Doppler evaluation of AV fistulas, and if time permits, I'll also cover the fistula, post-fistula Doppler, how we evaluate those fistulas and see their maturity. So, initially we'll cover the normal Doppler ultrasound of upper extremity. So, already sir has covered the anatomy part. So, grossly, we need to know the basic anatomy, that is from the brachiocephalic artery, the right subclavian and the right common carotid originates. The left common carotid originates directly from the arch, and the left subclavian also originates from the arch. Sometimes these two can have a common origin known as bovine arch, and from then the subclavian artery continues as the axillary artery, then the brachial artery, and then brachial artery divides into the radial and ulnar artery. There can be variants like the early bifurcation of brachial, early origin of the ulnar artery, or low bifurcation of the brachial artery. All these can be evaluated on the preoperative Doppler. So the normal brachial artery on the B mode looks like this. So this is the sagittal ultrasound scan, where you can see this is the lumen of the artery, and we are able to identify the thin echogenic line here, which is the intima. Okay, and the diameter of the artery is intima to intima, and similarly, after evaluating the artery on B mode, we apply the color Doppler, where you can see the color feeling within the artery, which indicates its patency. So there should be homogeneous velocities, and diameter is measured from intima to intima. Then we apply the duplex Doppler. So a normal artery will have a triphasic flow. So what is a triphasic flow? That means there will be two peaks above this baseline and one peak below the baseline. So below this baseline, the part of the arterial waveform below the baseline represents the arterial stiffness. So as the arteries become stiff, like in atherosclerosis, this component of the Doppler vanishes out, which indicates that this is an unhealthy artery. So coming to the venous anatomy of the upper limb, so the veins in question in our fistula is the superficial system, that is basilic and the cephalic veins. The basilic veins run along the medial aspect of the upper limb and penetrates the fascia in lower arm into the brachial vein, whereas the cephalic vein continues from the forearm to arm and then penetrates the clavipectoral fossa, inserting into the draining into the axillary vein. So the normal venous Doppler should be spontaneous. So we'll see the images. These are the characteristics that we evaluate while performing a Doppler. So we see whether the flow is spontaneous or not. The physicity with respiration, which is very important, because in cases of central venous stenosis, there won't be any physicity, or there will be loss of this physicity. We do the compression test, which is a very easy way to identify any thrombosed vein, which can be done also intra-op before performing any fistula or surgeries. Compression is very simple to perform, and we can sure shot rule out any thrombosed veins. Then augmentation is done to rule out any thrombosis distal to the level of examination, and Valsalva again it rules out any thrombosis or obstruction proximal to the level of examination. So this is simple compression. So this is the basilic vein we are evaluating. You can see without compression the lumen being nicely seen, and once you compress your probe on the patient's body, then we cannot see the basilic vein. So this is compression test, and this compression test is very useful to rule out any thrombosis or thrombosed vein. So you may see even in cases of acute thrombosis, you may see a completely black lumen, but if it is thrombosed, it won't be compressible. Okay, so you should not stop at only seeing the vein, but you should compress and confirm that the vein is not thrombosed. Then we use this color Doppler and duplex Doppler. So on color Doppler, we see wall-to-wall flow and this monophasic flow of veins with this phasicity that you are seeing, this undulating pattern. This is because of the respiratory phasicity. So if there is lack of this kind of pattern, or there is lack of this dip, it's a straight line, that means there is lack of respiratory phasicity, which may indicate a which may indicate a central vein stenosis. So coming to the next segment, that is preoperative ultrasound vascular mapping. So for identifying a good artery and vein is what we are doing in our evaluation. So for arteries, the minimum diameter is 1.6 mm, and this is Western data. So I think our surgeons are good at 1.2, 1.1 mm even. So this data what we are seeing are all Western data. So they have larger side arteries and veins. So these arteries should have a hyperemic response, and we also do ultrasound Allen test if requested. So peripheral veins again should be at least 2 mm without tourniquet and at least 2.5 mm with tourniquet. The central veins, we directly cannot see the central veins because of this bony cage. However, we do the indirect assessment on ultrasound, that is through the presence of respiratory phasicity, transmitted cardiac pulsatility and Valsalva, where we rule out any central vein stenosis. So for measuring the artery diameter, again, as we have already discussed, we do the distance from intima to intima. So inner to inner diameter we take. So in this case, the radial artery diameter was 2.2 millimeter. So arterial hyperemic response can be useful to predict the risk of arterial steal. So here what we do is first ask the patient to clench the fist for 3 minutes, where we can see the high resistance flow. That means the triphasic flow. High resistance flow means the third component, that is below the baseline, will be nicely seen. So once the patient has to release the fist, then the flow will become low resistance. That means you will not be able to see the component of the waveform below the baseline. So such presence of this indicates that patient will not land up in arterial steal. This failure of such response regarded as contraindication to arteriovenous fistula. So this is how we do perform a ultrasound Allen's test. So this is just a variant of the regular Allen's test, where we place a probe on the palm of the patient and identify the palmar artery. And once we compress the radial artery, there will be flow reversal, that is flow from the ulnar side of the palmar arch, there will be flow. So basically this red or blue color indicates the direction of flow and not the artery or vein. So in this case, the direction of flow was from the radial side, and once we obstruct the radial side, the flow changes its direction from the ulnar side. Okay, so this is modified Allen's test or the ultrasound Allen's test, which improves the accuracy of Allen's test. Then coming to the radial artery evaluation. So sometimes on evaluation we see this kind of images like this occurs because this shadowing occurs because of atherosclerosis and atherosclerotic calcification. So in this case, patient had segmental occlusive lesions where you can see the flow is not continuous because of calcification. So such calcified arteries are again can have poor outcomes while doing arteriovenous fistulas. So we mention the calcified arteries and the level of the arteries where there is calcification. So these veins, when we evaluate from the wrist, level of the wrist, both cephalic and basilic, from the level of the wrist to the distal end of the clavicle, and we evaluate for these 6 parameters that we have discussed, that is spontaneity, phasicity, compressibility, lumen echogenicity, wall irregularity, and the diameter of the veins. So this cephalic vein, you can see had marked wall irregularity, the wall thickening being more on the posterior aspect. coming to central vein stenosis, again on ultrasound we directly cannot visualize the level of the central veins because these lie within the bony cage of the ribs and clavicle, but indirectly we can evaluate for any central vein stenosis because of the abnormal respiratory physicity. That means there won't no decrease to baseline with inspiration. That means when we ask the patient to take a deep inspiration, there won't be any significant variation in the physicity, and this helps us to be suspicious of any central vein stenosis, which we can rule out on a venogram or on a CT venogram or more less radiation, less contrast usage through a simple venogram where we can see for any narrowing or obstruction. Like in this case, there is significant narrowing in the right brachiocephalic vein. Similarly, in this case, the patient had a Doppler ultrasound for fistula evaluation. Prior to fistula evaluation, we can see the straight. There is no physicity in the venous waveforms. So this raises the suspicion of central vein stenosis. Then when we perform the venogram, we can see there is significant narrowing at the level of brachiocephalic vein and a few thrombus within this brachiocephalic vein. So usually these patients have a central line or a dialysis line in place, and usually this dialysis lines lead to thrombosis of the central veins. So recognition of central vein stenosis again is a contraindication. However, we can perform a brachiocephalic vein plasty or a SVC plasty, restore the flow, then a fistula can be performed. So coming to the this upper extremity arterial mapping, what we do is we give similar images in our report where we measure the diameter of the arteries at the level of brachial artery, ulnar artery, at radial and ulnar artery in the proximal part, and radial and ulnar artery in the distal part. Similarly, for veins, what we do, we give these diameters at 8 levels in forearm, 4 levels in the forearm and 4 levels in the arm. And again, 2 measurements are given, one with tourniquet and one without tourniquet. Besides that, we also give the depth from skin, which is important for surgical point of view. So this was a 50-year-old man with non-palpable cephalic vein in wrist, scheduled for a forearm graft. So in the preoperative vascular mapping, you can see this is the radial artery with the paired veins besides this radial artery. We give the diameter of the radial artery and the distance from the skin surface. Then we also take at the level of middle forearm. Then cephalic vein at the level of the wrist, cephalic vein at the level of middle forearm and the antecubital area. And since the diameters of artery is more than 1.5 and diameter of vein is more than 2.2, so these are adequate diameters for arteriovenous fistula placement. So for preoperative vascular mapping, the recommendations from KEDOQI is duplex sonography of upper limb arteries and veins performed in conjunction with clinical examination in all patients for whom an AVF is being considered. So so this type of AV access I will skip. So I'll go to how the normal Doppler ultrasound of AV access looks like. So after a fistula has been placed, you can easily palpate a good thrill, and clinically you can easily see whether it's a good AV fistula or not. Besides that, sometimes if there is any doubt, patients are referred to us for ultrasound evaluation. So while performing these immediate post-op fistulas, it's important to avoid pressure on that fistula, otherwise it will go down. So we use abundant gel and do longitudinal and transverse scan of the artery, the anastomotic site, and the outflow vein, and we evaluate for any abscess, hematoma or seroma in the perianastomotic or in around the surgical area. So for normal Doppler ultrasound in post-arteriovenous fistula, we see monophasic flow in the feeding artery with a large diastolic component. In the anastomotic area, usually there is very turbulent flow, and the draining vein we see pulsatile flow because of the arterialized vein, and volume flow usually more than 500 milliliters per minute. So dilatation of feeding artery and draining vein usually takes some time to develop. So this is a brachiobasilic fistula, where immediately post-op evaluation, where we can see this is the brachial artery with good physicity of flow and large diastolic component. This is the outflow vein side, where we can see the veins also showing the arterialized type of flow. So there is a upstroke, then downstroke. This is known as arterialized vein. So we also measure the volume by this formula. Most of our ultrasound systems have this formula already set, where we take the measurements and we get the volume flow in milliliters per minute. Okay, so coming to the routine surveillance of a mature fistula. So what are the causes of immature fistula? Stenosis at or near the fistula site, which can be corrected using which is a primary failure, which can be corrected using a angioplasty. If angioplasty fails, the patient can be taken off for surgical revision. If there are one or more accessory veins or the competent veins, that can be ligated, and deep draining veins can be surgically placed in more superficial tissues. So immature fistulas can be converted into usable fistula with correction of the underlying problem. So for diagnosing a sonographically mature fistula, repeat Doppler ultrasound is performed after 6 to 8 weeks, where the epi diameter of at least 4 mm and distance from skin to anterior wall less than 5 mm and flow volume of at least 500 milliliters per minute is considered to be a sonographically mature fistula. And again, the rule of 6, as already sir has covered, the same points, like epi diameter of the draining vein should be at least 6 mm, skin to anterior wall should be within 6 mm of the skin surface, and flow volume should be more than 600 milliliters per minute. For epi diameter of draining vein in transverse scan, usually we should take the measurement only from the intima to intima. The distance from the skin to anterior wall of the draining vein we measure. So any veins, early veins, to identify early veins, the initial 10 centimeter of the outflow vein we scan, and any competing vein is identified while the surveillance ultrasound is done. And flow volume usually we take 3 to 5 times, and the average is taken. So how does a mature fistula looks on an ultrasound? So you can see this is the transverse ultrasound of the draining vein. The draining vein diameter is more than 6 mm, and from the skin surface it is 4.8 mm. So this indicates it's a mature fistula. So this is another patient with a immature fistula, where you can see there is a the draining vein, large accessory vein or competing vein within 10 centimeter of the anastomosis, which is the cause of immature fistula. So this competing vein can be surgically or even radiology under ultrasound scan can be ligated off to help in maturing this outflow vein. Then immature, some fistulas can be quite deep. This fistula outflow vein is around 7.6 mm from the skin surface and also small in diameter. So this is immature fistula. Again, we do the volume calculation of the outflow vein. Like in this radiocephalic fistula, the outflow vein volume was 130 milliliters per minute, much below the 600 cutoff. So this was an immature fistula. So I think I will not cover the complication part. Complications and the interventions related to the heavy fistulas will be covered by Dr. Ranjan in the second half. So thank you. I'll conclude here.
I would now like to invite Dr. Parag Sahasrabuddhe for his talk on nuances, principles and techniques of AVF creation.
At the outset, I would like to thank Dr. Sanjay Giri and his entire team and President Madam and entire APRASO and my dear friend Vibhuti for inviting me here. And as you have seen, the burden of CKD is huge in India, and when we started our workshops way back in 2015, hardly any plastic surgeons in my city were doing AV fistula surgeries. And today the scenario has completely changed, because as Dr. Vibhuti has said, we being trained as microvascular surgeons, we can do better quality fistulas, and as our results were better, then gradually nephrologists started sending more and more patients to us. So today, at least in my city, I can proudly say that all of the fistulas are done by plastic surgeons, and I wish that happens all over the country. So today's talk is about nuances, principles and technique of AVF creation. Now some of this some of the images and everything has already been published in Indian Journal and Indian Journal of Nephrology, so that's a disclosure. So AV fistula is an Achilles heel in hemodialysis. It's just a surgical communication between artery and vein. So for us plastic surgeons who are trained in microsurgery, just doing an anastomosis is not a big deal. But is AV fistula just about joining an artery and vein together? Then the answer is clearly no. The surgeon must be aware of anatomical, physiological and hemodynamic changes that happen after AV fistula creation, so that, and when combined with patient selections, surgeon skill and experience, it can give a long-lasting outcome. So how AV fistula is different from just doing an arterial anastomosis or venous anastomosis? It's a communication between high flow and low flow system. So changes will occur post AV fistula creation on both the sides, the arterial side as well as the venous side. In artery there will be increase in flow, because suddenly it has got an path which is of low resistance, so the flow will be diverted to the low resistant path, so there will be increase in arterial flow. In 75% of the fistulas, there is also a retrograde flow from the palmar arch which is feeding the fistula. So the fistula can be fed from both proximal as well as the distal artery. And in vein, what happens is there is sudden increase in the blood flow in the vein, so the vein dilates. There is dilatation of the vein, there is hyperplasia of the media of the muscles of the vein wall, there is endothelial hyperplasia, and all these changes will eventually determine whether your fistula is going to mature or it is going to fail. So the second talk that I am going to talk about the hemodynamic changes that occur after fistula creation is very important, and that will be something that we have to look for, because finally just doing an anastomosis is not end of the story. If you have done an anastomosis, even if there is good bruit and thrill in the patient, and if the fistula doesn't mature, then the nephrologist will come back to us saying that the fistula is not mature and I cannot use the fistula. So practically for the patient it does not work. Though it is successful at your hands, you have good bruit and thrill. So ideal hemodialysis access. So what is an ideal hemodialysis access? It should have adequate flow rates to sustain hemodialysis. Minimum flow rate required is 250 to 300 ml per minute. For dialysis technician, the vein should be easy to access. Remember that he has to make two punctures in the vein, one for the outflow and one for the return flow which comes from the dialyzer unit. If the two ends, two needle pricks are too near to each other, then it is going to cause what is known as recirculation. So you are going to the purified blood is again going back to the dialyzer. That is what is recirculation. So if the two needle pricks are too near to each other, so you have to have a long segment of vein available for the dialysis technician, so that the dialysis is more effective. It should be cost effective, acceptable to the patient, should have long-term patency and minimal complications. And the AV fistula is the most amongst the three types of accesses, that is AV grafts, or whether you do central line or AV fistula. The AV fistula is the closest which classifies all the criteria. So why it is the best access? It is durable, minimum patient morbidity. It is tailored to patient needs and life expectancy. Does not involve recurrent costs unless your fistula fails. Safe and cheap in the long run, and lowest number of complication as compared to AV grafts as well as central line catheters. Now these recent kidney disease outcome quality initiative guidelines which have come in 2019. Now there is a huge, there are some changes in the 2006 guidelines and 2019 guidelines, and there is, the thinking had changed, and now the thinking is in 2006 They used to say that fistula first initiative. We have all known about that. So a patient who is likely to need dialysis in near future, you do the fistula first. And they have reported in that guideline, they have said, in the guideline itself says that the primary failure rates of fistula are up to 40 to 50%. In spite of that, they recommended that you do fistula first. So even if there are high failure rates, you do fistula first. That was the recommendation in 2006. In 2019 guidelines, the thinking had changed. Now they say it is more patient-centric approach. So it has to be a particular treatment plan has to be devised for that particular patient in consultation with the nephrologist, keeping in mind the life expectancy of patient, because that is the most important thing. You don't want to create a fistula for a 80-year-old patient who is not going to take dialysis, or maybe is not going to take dialysis more than a 1 year time. Then in that case, don't go for a fistula in that patient. It is better to manage him with either a permacath or a central line. So now it has to be a patient-centric approach, and for each particular patient, a life plan has to be designed when the patient is diagnosed with CKD. So what are the principles of AV fistula creation? This has been said already. I'll just go fast through this. Distal preferred over proximal, non-dominant hand, native AV fistula better than grafts, adequate vessel size, a good arterial venous flow, preserving veins before surgery. Nowadays in nephrology unit, we have put big boards, and I think you should do that here also, that if a patient needs an AV fistula, one limb has to be preserved. So we put a sticking on the patient's hand there and there itself. The nephrologist or the nurse there itself, if the nephrologist says that this patient is going to require a fistula, preserve one limb for AV fistula, because otherwise what happens is these patients are extremely unstable. They get repeatedly admitted into intensive care units, and all the veins are fired by the time patient reaches us for fistula creation. Follow the rule of 6 for maturation. Remember that rule of 6 is for assessing the maturation of fistula, not for creating fistula. Avoid complication. And the last thing that is what we lack in our country is post-operative surveillance. Most of the times these patients, we do a fistula, the patient is hardly ever going to come back to you and show how the fistula is working. And this is very important, because there are few signs. If you examine the working fistula properly, I'm going to talk about that later in my talk, you can pick up early signs of failure there and there itself. And if you can do that, then you can probably salvage that fistula. But for that, a regular surveillance has to happen. So fistula first initiative now is more patient-centric approach. In patient-centric approach, there are different things that need to be done. There has to be a plan for each and every patient. What is the plan? P stands for patient, life plan, access, and needs. So when you create a fistula, you have to think about the future plan also. So you have to have a contingency plan and succession plan. Suppose this fistula fails, when is the next fistula you are doing? So that is why distal is preferred. You always go from distal to proximal. It's not true in each and every case, because it will again depend upon the life expectancy of the patient. Proximal fistulas, bigger vessel diameters, mature faster. Distal fistulas will take more time to mature, so it has to be matched with life expectancy of the patient as well. But here, vessel preservation, insertion, and contingency and succession is very important. And this has to be planned on day one, like we do in any other plastic surgery. So we always have a backup plan. So here also we have to have that in place. So out of the 3, central venous catheters, AV grafts, and in AV fistula, what is preferred? So patients who are prevalent on hemodialysis already, AV access is preferred over both the options, AV grafts as well as central venous catheters, provided there is sufficient time and patient circumstances which are favorable for fistula to mature. As I said, if the life expectancy is less, till the time the fistula matures, if that fistula doesn't mature, how the patient will undergo dialysis? So in which case, you probably have to do the fistula at the same time when you are putting a permacath or a central line catheter, so that by the time fistula matures, central venous catheter will tide over the time. So when to do an fistula? These are all guidelines from the recent KDO QI guidelines of 2019. When patient is on progressive CKD or with eGFR of 15 to 20 ml per minute. This guideline also adds that there has to be an annual review of patient's life plan that you have made. and minimum quarterly review of the AV fistula itself, so that you catch up the complications early and prevent fistula failure. How you choose the site? Dr. Vibhuti has already shown these are the multiple sites where a fistula can be created. So what are the factors that will decide where you are going to do the fistula? One is dominance of the hand, diameter of the vessels, history of previous cannulations. History of previous cannulations in the neck, they are important, because if there is a thrombosis here, every patient has to be, when you do a Doppler, just don't do a Doppler only for the site where you are going to do the fistula, or you are planning to do the fistula, do the Doppler for the entire upper limb to rule out central venous thrombosis. We have had patients where fistula was created with central venous thrombosis in place. I will show that in complication talk, which will be either late in the evening or tomorrow. Vein distensibility, which is already being talked about, atherosclerosis of the vessels, reactive hyperemia in arteries, because that is very important. If there is no reactive hyperemia, or if the veins are not distensible. Sometimes what happens is, since these patients come back repeatedly from ICU, their cephalic vein is already thrombosed and recanalized. So you see a good vein there, but the vein is not distensible. So you do a fistula, if the vein is not distensible, eventually there is going to be endothelial hyperplasia rather than media hypertrophy, and the fistula is going to fail. So distensibility of the vein which you are joining to the artery is very important. Patency of the palmar arch, we have talked about. Quality of the skin, important, especially in patients with collagen vascular diseases like SLE, sarcoidosis, and patients who have been on steroids for longer duration. The vein can be very thin and friable, so you have to take care of that. And age expectancy of the patients. If you are expecting that the patient is going to be on hemodialysis for more than 1 year, then AV fistula is the best option. So again, distal radiocephalic first, followed by proximal forearm fistula or a brachiocephalic fistula, and the last is brachiobasilic transposition fistula. However, if the expectancy of the patient on dialysis is going to be linear, then a brachiocephalic fistula is preferred over a radiocephalic fistula. Again, because more likelihood of unassisted maturation because of bigger size of vessels. So it will depend on patient age and life expectancy, whether it's, as I said, not necessary you always go from distal to proximal. In such scenarios, you will go for a proximal fistula because it will mature faster and it will be usable faster for the patient and for the nephrologist. Now, why cephalic vein is preferred? We always try and do the fistula with the cephalic vein. Now, there is a role of perforating veins. We know that the superficial system and the deep system connects to each other through the perforating veins, and they can play a very important role here. It can have a detrimental effect on the fistula, as it can steal the flow from the cephalic vein into deeper vein. So you will have a less flow in cephalic vein after the fistula. If the fistula, so it is like an kind of accessory vein or a diversion which causes less flow in the cephalic vein. And the good part is, if your main cephalic vein gets blocked, still you may have a bruit and thrill at the fistula site, because your perforating vein is draining the fistula. So it is double-edged sword, the perforating veins. And why cephalic vein? Because cephalic vein has got the fewest perforating veins, and most of these perforating veins communicate with the muscle, not with the vena commitants. So maturation of a cephalic vein fistula is better as compared to any other vein in the forearm. So this is why a cephalic vein is always preferred for fistula as compared to basilic or antecubital or antebrachial vein. Given that vessels are all available, good vessels are available, this is the sequence of fistulas that we create: radiocephalic, brachiocephalic, brachiobasilic, and arteriovenous grafts as the last option. What is the optimal vessel diameter? Well, the recent KDO QI guidelines say that there is no minimum diameter where we can do a fistula or not do a fistula. It all depends on operator skill and individual patient assessment. Again, they give more importance to reactive hyperemia and vein distensibility than the diameter of the patient. So this is a change in thinking from 2006 to 2019 guidelines. But in general, arteries and veins less than 2 millimeter diameter better not to go for the fistula at the same site, choose a different site. And this we have published in our 2014 publication of 505 fistulas, which shows that less than 2 millimeter diameter had 5.3 times more failures as compared to veins which were more than 2 millimeter in diameter. So in general, today I follow 2 millimeter as a guideline. If less than 2 millimeter, I choose a different site. Is preoperative ultrasound must? Again, the thinking had changed. Today the guidelines say that you don't need to do a preoperative ultrasound in each and every patient. If you have a clear-cut young individual, young male, you can feel a thumping radial artery, you see a nice cephalic vein clinically on tourniquet application, you may or you may not go for vascular mapping. This is a change in thinking again in the guidelines from 2006 to 2019. But it's always better to go in for vascular mapping, and not only mapping, duplex ultrasound, so that you evaluate both arterial as well as venous system, that too of the entire limb. In cases where previous fistulas have failed, there is peripheral vessel damage, multiple pricks, intravenous catheters, atherosclerotic vessels, and limitation to physical examination, like morbidly obese patient or patient has huge edema on the upper limb because even after doing repeated dialysis, he is in overload. In such cases, then you have to go for a duplex. So these are clear-cut indications where a Doppler is a must. But the recent guidelines say that it may or may not be done in each and every case, though we do it in each and every patient in our scenario. So what should we see in the Doppler ultrasound? One is the reactive hyperemia test, ability of the artery to dilate. I think that was covered in the radiology talk. Distensibility of the vein. Inflate an BP cuff for 60 millimeters of mercury, and the vein has to be dilating more than 2.5 millimeters from its resting diameter. Then it's a good vein to anastomose to the artery. You look for accessory veins within 5 centimeters. So you're doing a radiocephalic fistula. You are going to take a small incision here, but through that small incision, you try and explore if there is any vein branch which is draining onto the dorsum of the hand. Because once you do the fistula, that vein might act as or develop as an accessory vein and steal the flow towards the hand, and you will get inadequate flow in the cephalic vein when they actually do put the patient on dialysis. Plus the complications caused by the accessory vein like dorsal hand swelling, discoloration of fingers and all. So it's always better to look for accessory vein when you are creating an AV fistula. Of course, there are going to be multiple branches of the vein. You cannot ligate each and every branch. But some fistulas, we have done that also. That also I will show in, because the fistula was working well, very young female, thin build, and low flow in the cephalic vein because of multiple side branches. We ligated all the multiple side branches of the cephalic vein, and the flow in the fistula and the main cephalic vein increased. So that's a procedure that's been described for the same. Flow-mediated dilatation is the most well-established method to assess endothelial function. Now this is important because endothelial function is going to decide whether your fistula is going to mature or whether your fistula is going to fail. We will see about that in details. Rest, diameter, flow rates, patency, and proximity of artery and vein to each other, and distance from the skin that is what we all do. So this is an ideal Doppler report where you should have. If you see here, I asked the radiologist cephalic vein 2 centimeter to the wrist, mid forearm, proximal forearm, at cubital fossa, mid arm, proximal arm. So you measure diameters at each and every level because you might have to decide the site accordingly. What type of anesthesia? Well, then again there is the guidelines say any anesthesia is good, depends on surgeon's preference. I personally do all my cases under local anesthesia, 2% 10 cc plain xylocaine without adrenaline. Only in cases where you do a brachiobasilic transposition, we take a help of our anesthetist for the supraclavicular block, because there you require a long incision on the medial aspect of the arm. Which suture to use, whether it is 70, 80, doesn't matter. We have also proved the same in our first publication in Indian Journal of Nephrology, where it was about 271 cases. So again, it's operator's preference whether to use 70, 80, double end needle, single end needle, depends on whatever you are comfortable with. Do post-operative, because we have seen that you do a fistula, and there is no bruit or no thrill, we tell the patient or we try to blame the patient that you have not done enough exercise, so the fistula has not matured. It is not so. Fistulas are, exercises are not the thing that will make your fistula successful. It is your technique. So don't blame the patient that he has not done exercise. There is no evidence that any exercise will help the fistula to mature or make the fistula patent if you have not done it properly. As a whole arm exercise is preferred as compared to just squeezing the ball in case you want to advise exercises post-operatively. Do post-operative pharmacological agents help? Again, KDQI guidelines say they have compared heparin, clopidogrel, ecosprin, glycerin nitrate. Nothing works for maturation of the fistula. It is finally your technique. So just I may give in a atherosclerotic patient, in all my patients I give single shot of low molecular weight heparin at the end of the anastomosis. In atherosclerotic patients, if the artery is severely atherosclerotic and you see plaques coming out of it, then maybe I will give heparin for 2 or 3 days and followed by ecosprin for at least 7 days. So what are the contraindications for AV fistula surgery? Now this is our article, this is a review article published in Indian Journal of Plastic Surgery, absolute contraindications and relative contraindications. EF less than 20, avoid an AV fistula because then it's going to put more load on the heart. Life expectancy, central venous stenosis are all relative contraindication. Low BP. Point I want to make here is that normal BP is 120/80, that is good, but for these patients 110 by 70 BP is a low BP for them because their body is acclimatized to 180 by 170, 210 by 170 BP is what is they are acclimatized to because they are hypertensive patients. And suddenly during dialysis, if the BP goes to 110 and 70, we have seen fistulas failing. Because that is a low BP for them, the blood stagnates there, there is a thrombosis and the fistula fails. So hypotension is the most common cause of a working fistula failure in hemodialysis unit. The patient goes more repetitive episodes of hypotension, then fistula is likely to fail. So this is the point that we need to remember. Prerequisites we all know, venous anatomy is talked about. Only point I would like to make is that remember that the basilic vein in the arm is subfacial, so it needs to be superficialized as well as transposed anteriorly in place of the cephalic vein so that it can be accessed by the dialysis technician. And in the cubital fossa, as you can see here, there are multiple veins here. This is a median antebrachial vein, as you can see here. This fistula, the new fistula that we have described, is a direct communication between brachial artery, side to side fistula between brachial artery and medial antebrachial vein in cases where cephalic vein is not available. And it has got distinct advantages compared to brachiobasilic transposition fistula. We will come to that in details. So this is standard sequence of AV fistula creation. Operator technique, I just do it as I said, 10 cc 2% plain xylocaine. I do use most of the time 7-0 Prolene on double end needle, continuous running sutures for the posterior wall. One knot at 3 o'clock, one knot at 9 o'clock, and then continuous anterior wall and continuous posterior wall. So this is an incision. Again, the type of incision, because we have seen multiple incisions, avoid transverse incision as far as possible because of it causes more damage to lymphatics. So what I generally do, if you see a marking of the artery here, marking of the vein here, I generally take a lazy S kind of incision and raise this flap to expose the arterial side and this flap to expose the venous side. So this is exposure, this is arteriotomy. Yeah, as you go from distal to proximal, the size of the arteriotomy has to reduce. Because otherwise, if you do a larger fistula proximally, two things can happen. One, the venous return will increase, and if the patient's ejection fraction is low, patient will go into cardiac failure. One, and with a large fistula, there is likely to be steal phenomenon happening in the limb distally because most of your blood is diverted back to the heart and you will have less flow in the artery, especially common in patients who have got atherosclerosis. So if they have large diameter vessels, radial artery and ulnar artery, more likely to cause a steal phenomenon. So that's posterior wall completed. This is anterior wall completed. Again, the angle of anastomosis. What should be the angle of anastomosis? What is an ideal angle? Now you see this is an ideal angle which is about 30 to 45 degrees. Ideal angle is less than 30 degrees. And this is what a fistula should not be done. If you see here, an artery This is the wrist side. This is the vein. Vein is dilated vein. But there are two mistakes that I've made here. One is the length of the vein is excessive. This is an accessory vein which is going to the wrist, which is not ligated. And because of which the angulation is such that you see this is 90 degrees angulation for the fistula. This fistula will never mature. This is surely likely to fail. So avoid this kind of technique. There are multiple papers in literature, and study has shown that 30 to 50 degree angulation is ideal. Anything less than 30, because it all depends how the hemodynamics change with angulation. And they have they have made multiple studies, compared 30 degrees, 45 degrees, 60 degrees, 90 degrees, and they have showed how the hemodynamics of the fistula and the vein maturation changes with angulation. So that is, and final conclusion is 30 or less than 30 is the ideal angle. Proximal fistula, radio, like we showed clinical pictures for radiocephalic. Brachiocephalic is again end to side. Then comes the conventional brachiobasilic transposition fistula. And then what we have described is an proximal side to side brachio-antecubital fistula. So which now we prefer over a basilic transposition fistula, because basilic transposition fistula will require a long incision on the medial aspect of arm, will require axillary supraclavicular block, and that can be avoided by the technique that we have described. So this, our preferences have now changed. So this is an example of a end to side brachiocephalic fistula. You can see brachial artery here. I just wanted to point out that when, see, the cephalic vein is in a different plane, brachial artery is in a different plane. So when you get the cephalic vein here, sometimes the medial edge of the bicipital aponeurosis can cause, when patient flexes and extends the elbow, it can rub against the medial wall of the bicipital aponeurosis. So sometimes you need to create a space there for the vein to accommodate. And you can check that intraoperatively on table after you do the anastomosis by flexing the elbow and do it accordingly. Conventional brachiobasilic transposition. So you cut the basilic vein here near the elbow, transpose it anteriorly in place of the cephalic vein or in front of the arm, and then joined as end to side with the brachial artery. So this is a conventional brachiobasilic transposition. These are the steps. So exposure of the basilic vein. When we do surgery, we'll explain you that this is the basilic vein, and you see it comes in between the two branches of the cutaneous nerve of the forearm. So you will have to divide this basilic vein here, get it out of the branches, and this is a problem when you try to do transposition of the basilic vein secondarily. If you have not done primary basilic transposition, because people are not confident whether the anastomosis will work, whether the fistula will work, so they just do side-to-side anastomosis here, and then thinking that my fistula is working well, vein has matured, now I will transpose the vein anteriorly. But we have videos will show that transposition of vein secondarily becomes difficult, because there you have to cut one of the branches of the nerve and re-anastomose the nerve. Otherwise you cannot transpose that nerve anteriorly very easily. So this is how this is the vein, this is the branches of the nerve. So you can either do it by two methods. Either you raise that entire flap anteriorly, then cut the fascia and position your vein from this within the cut in the fascia so that it becomes subcutaneous, and close the fistula. And then what you can do is the medial end of the fascia can be sutured here so that the vein remains superficial. So this is how the vein is transposed, and then anastomosis end to side. And this is, can I have a sound? Yeah, I think, yeah. So this is how you get the problem with brachiobasilic transposition fistula. You have one single vein which is available for vascular access. So it's like lifeline for that patient. Anything happens to that vein, then the fistula is gone. So you have to do a new fistula in a brachiobasilic case. So conventional brachiobasilic fistula, what are the advantages? Basilic vein is hardly pricked because of its subfacial location, so it's always available. There are less chances that it will be thrombosed. It is large in caliber, so it is easy to do a fistula with basilic vein. However, disadvantages are long incision, need for regional block, and you do more dissection, chances of hematoma and seroma formation are more. So our two earlier publications, what were the conclusions? What we compared was patency of the fistulas with site of fistula, diameter of vessels, long-term patency. So what we did was a Kaplan-Meier analysis where we had conditional probability of patency being evaluated statistically. And what we found was first year patency rate were 90%, and they finally dropped to about 13 to 40% by 5 years. So all these patients are diabetic, and we were just discussing there is atherosclerosis. So it's not that you do a fistula and that fistula is likely to last you for lifetime. Of course, I have a patient whose fistula he's a chartered accountant, he's working as well as he's taking dialysis on the fistula that I created, radiocephalic fistula, 20 years back. But there are very rare occasions like this. Your fistula will eventually fail after 5 to 6 years. So you have to remember that and take steps necessary. And that is why we try to preserve future sites when we plan the first fistula. That is the whole concept. So again, this was the first time in these two studies that we established a direct correlation between bruit present on operation table and thrill felt at the end of the surgery with maturation of the fistula. Nowhere in the literature it was described, and this was the first time that we have described this. So nowadays it is a dictum that at the end of the anastomosis, either bruit or thrill has to be present. Without that, the patient doesn't leave the operation theatre. And if it is not present, you have to check a couple of things which we will talk about. As we have said, post-operative anticoagulation has no role, no site or no suture material or type of anastomosis is better than other. So what was the new fistula that we described was a side-to-side fistula between brachial artery and antecubital vein. It develops forearm veins by retrograde flow in the vein, easy for cannulation because forearm veins are easy to cannulate, and avoids need for long incision and transposition of the basilic vein in the arm. So this is how it is done. Small incision, again S-shape incision just above the cubital fossa. You identify the vein. After doing a venotomy, we pass a long vessel dilator distally towards the wrist site. So if you see, this is whenever you have branching, there is most likely a valve there. So you dysfunction that valve like this, and we have got a specially designed vessel dilator, long arm vessel dilator here. So you dilate this valve here, and then you confirm that there is going to be a retrograde flow after your completion of the anastomosis by infusing hyperonized saline, where the assistant can feel for thrill on the forearm. So that confirms that the retrograde flow is going to be there, and then you do a side-to-side anastomosis. So this is side-to-side anastomosis. And here you can see this is the proximal vein, this is the distal vein. But the distal vein has dilated more. Why? Because that's the natural direction of the flow as far as the brachial artery is concerned. So it's not going to give a flow in 180-degree reverse direction. So more likely the distal vein will dilate more as compared to the proximal vein. And this is what you get at the end of 6 weeks when the fistula matures. As you can see, this is the site of anastomosis, and you see a long median antebrachial vein. So now this vein is very easy to access for the dialysis technicians. So advantages: smaller incision, can be done under local anesthesia, limited dissection, veins developing in retrograde fashion, and you always have a backup plan. Suppose, I'll go one slide back. Suppose anything happens and there is a counter prick and there is thrombosis of this vein. Your basilic vein is still patent up. So you can always transpose that vein secondarily in case your forearm vein is not available. So you don't need to do a new fistula. You just have to transpose that vein which is already mature, which is subfacial. You just transpose it suprafacial. So the same vein can be used. So there is a backup plan with this fistula as well. In case your forearm veins get thrombosed eventually, you can superficialize the basilic vein as a secondary procedure. And as we normally do, we did about 171 cases with this kind of technique, and we have published that also, and we have compared this technique with conventional brachiobasilic transposition fistula. Number of patients you can see, we have 171 patients. These are all studies. Maturation days are comparable. Primary patency rate were 81%, again comparable with other conventional brachiobasilic transposition techniques. We also gave a questionnaire to dialysis technicians about ease of access. How many times in the first prick they could access the vein. So in 83% of the patients, they could access the vein in the first prick. So which is very good as far as, because accessing the basilic vein is a problem. And complications rate, as you can see, our complications rate was much less compared to the conventional brachiobasilic transposition, because again you have a long incision, chances of seroma, hematoma formation are more. So now our preferences have changed. The number 3, which was a brachiobasilic transposition fistula, now we do at number 4. And our technique we first try before we do a brachiobasilic transposition fistula. What affects maturation of fistula? I'll not go into details of that, but there are multiple factors which will affect maturation of the fistula. Post-operative care, very important. I've seen patients coming to me with post-operative nice circumferential bandage applied on the forearm, and then on table you have bruit and thrill, patient comes back, there is no bruit and thrill. So non-circumferential, non-compressive bandage, I just keep a gauze and 2 tapes of micropore tape, that is more than enough. Instruction to patients to check for thrill every day, because as we said, the patient's thrill has to be there before you discharge the patient. So the dictum is, there is no thrill, there is no fistula. So thrill has to be there, patient has to check every day. I normally tell them, as you pray to the God every day morning, you do namaskar, you just check for the thrill, and if there is no thrill, report immediately. Because if you report immediately, if it's a soft thrombus, then we can do embolectomy and salvage the fistula. But if patient misses when the fistula, because they sometimes come back after they have done a dialysis, they come for the next dialysis, they say the fistula is not working. So when did it fail? Nobody knows. So whether it failed, thrombus got immediately after the first dialysis, before, or, so then it is once the thrombus gets organized, it is impossible to remove it with embolectomy. Ask the patient to report if he has got any pain, coldness or numbness, ulcerations of the fingertip. Ulceration fingertips comes love, but if he has got pain in the fistula, if he's got coldness or numbness of the fingertips, then there is a problem. Then you have to evaluate the fistula. There is either an outflow obstruction or there is a steel phenomenon that is likely to develop, and you can pick up that early. Rule of 6 is for maturation, and this was stressed in 2006 guidelines, but now they say that 0.6 centimeter long segment from the vein may not be necessarily, and they say that this rule of 6 needs to be revisited because there are a lot of improvisation that has taken place in the dialysis needles available today. So it's not necessary that you should have a 6 centimeter diameter vein and it should be within 0.6 centimeters from the skin surface. So but remember that this is rule of 6 is for judging the maturation of the fistula, not for success of fistula. I would advise everybody to go through this of nuances, because of all these things have been already been mentioned in this is a CME article in 2021 IGPS. So common mistakes made during AV fistula creation: poor patient selection and poor vessel selection. As we said, ignoring peripheral vascular disease, central venous veins, choosing deeper veins. I will show you in complications. I have seen a fistula which has ruptured, aneurysm which has ruptured, and when we explored, we saw that anastomosis was done between brachial artery and the vena comitant, not the superficial system. Now, you will have excellent bruit and thrill audible all along, but that fistula is of no use to the nephrologist because it is never going to develop superficial veins, and you cannot access vena comitants by needle prick. So, avoid that. Skipping preoperative vessel mapping, because then you will miss either venous stenosis or arterial stenosis preoperatively. Choosing the wrong site, excessive vein handling, excessive use of electrocautery, avoid that. Anastomotic angulation you have seen. Tension and twisting of vein, more common when you do a brachiobasilic transposition, especially primary transposition by tunneling through the forearm. And during the surgery, we will show you how it is to be avoided, the twisting of the vein. Failure to ignore bruit and thrill. And surveillance, I think, is most important, because normally what I do is patients don't come to me, they come to nephrology OPD, but I do regular, at least twice weekly visit into the dialysis unit to see my patients and see that the fistula is working well, because there you can pick up things which before the fistula fails, you can pick up things earlier and try and prevent that. So how to evaluate a working fistula? A pulse of the fistula is soft and compressible. That is how it should be. A strong thrusting pulse indicates that there is an outflow obstruction. Similarly, a bruit should have either equal systolic and diastolic components or more of a prominent diastolic component. If you have a high pitch bruit, then it indicates that there is again narrowing of the fistula. You have to check for juxta anastomotic stenosis, either just beyond the anastomosis. And we'll show you in the next talk how to check for juxta-anastomotic stenosis. So abrupt disappearance of bruit or thrill beyond one point in the vein, just suspect that there is going to be a juxta-anastomosis stenosis. Again, check for accessory vein. How to check for access sequential occlusion test, that also we'll tell you during complication talk. So thrill over AV fistula should disappear after you occlude the outflow vein. Even after occluding the outflow vein, if the thrill still remains, that means there is some vein which is draining the fistula, and that's going to be your accessory vein. So these are the ways you can check whether your fistula is working properly and catch complications earlier. From the literature, these are the predictors of outcome. A perioperative flow increase up to 120 to 160 ml of minute 10 minutes after AV fistula indicates that there is likely to be maturation. Similarly, internal diameter of the vein more than 4 mm indicates maturation. Intimal media wall thickness 0.13 mm indicates maturation. And there is a study which shows that if you cannulate the fistula earlier, the normal time for fistula maturation is about 4 to 6 weeks. And primary fistula failure is defined as fistula failure of maturation at 12 weeks. So there is nothing like if you don't have primary bruit thrill and the fistula fails in 1 or 2 days, it is not primary failure, it is immediate failure. As per the definition, primary failure is defined as failure to maturation at 12 weeks. In general, fistula mature between 4 to 6 weeks time. If you prick the fistula early, there are chances of twofold more chances that the fistula will fail. So there are sometimes nephrologist and the patient need is there, they prick the fistula within 15 days. The fistula is working well, you have good bruit, good thrill, good flow rates, they prick the fistula within 15 days. But then chances of failure are more high in the long run. Special patient groups, diabetes, we know, calcified arteries, obesity, avoid fistulas in the arms in obese person, because even if cephalic vein is superficial, it is not easy to puncture in an obese patient. In fact, I had an occasion where I had to superficialize the cephalic vein in the arm in an obese patient because dialysis technicians were not able to access this. Amputees and paralyzed limb, use that limb for fistula because anyway patient is not going to use that limb. AVF in children, special thing is that their fistulas take time to mature. Always better to go in for proximal fistulas in such patients as they have a very short time for transplant. Mostly these children will go for transplant and surveillance is must in these cases. These are recent advances, new things that are happening. Hero device is being, which is a hybrid graft. Then you are now, people are experimenting on endovascular AVF. Then again, bioengineered human or cellular vessels instead of AV grafts. So these are all into pipeline. So conclusion, each patient should have individualized patient plan, thorough post-operative and pre-operative examination. Remember that it's not just joining artery and vein together. And presence of bruit and thrill at the end of the surgery is a must and direct predictor of success as far as AV fistula is concerned. So coming to nuances, patient selection, limb selection, careful mapping, gentle handling, adequate vein mobilization, optimal anastomotic angle, prevent vasospasm, no fistula, no thrill, no fistula is the dictum that you should remember. Preserve venous drainage pre-operatively, so preserve veins earlier. Proper skin closure and avoid BP measurements, IV cannulation or any tight ornaments on that limb. So thank you ladies and gentlemen for patient hearing. Any questions I'll be happy to take, but I think we are waiting for, yeah.
The blood pressure related absolute contraindication?
No, it's not absolute contraindication, but the working fistulas have failed because of, most likely because of hypotension during dialysis. So you have to be careful, you have to tell to the dialysis technician also, avoid hypotensive episodes during dialysis.
And sir, one more question. What if the patient has encephalopathy? Should he proceed with the surgery or?
There's no question of proceeding with encephalopathy. See, the question that I asked on the group yesterday morning was, all the patients we are going to show live surgery are able to lie flat without any dyspnea. Because that, if they are not able to lie flat, because see two things. One is after you do the fistula, the load on the heart increases. They are likely to go into failure immediately, such patients. So if they are not able to lie flat today without dyspnea, after doing an anastomosis, so they will 100% go into failure. I had an incidence where I completed the anastomosis, and even before the skin closure could be completed, patient went into failure, and we had to immediately shift him to dialysis center and do dialysis. So pre-operative, normally we do fistula next day of the dialysis, and we avoid doing a dialysis, do a heparin-free dialysis previously, so that you don't have intraoperative too much of bleeding. So that's a normal dictum that we hold. Every patient has to undergo dialysis before taking up for surgery.
Thank you, sir.
Which will then be followed by the live OT workshop. A very good morning to everyone. On behalf of Department of Burns and Plastic Surgery, AIIMS Bhubaneswar, it is my proud privilege to welcome you all to the workshop and CME on AV fistula. Today, we come together not just to discuss a procedure, but to deepen our understanding, refine our craft, and reaffirm our commitment to patient care. We are truly honored to be in the presence of such an esteemed gathering of dignitaries, faculties, and participants. Your presence truly makes the occasion meaningful and inspiring. The lighting of the ceremonial lamp is more than a tradition. It is a symbol of knowledge over ignorance, of clarity over doubt, and of the light that guides us in our pursuit of excellence. I now request our esteemed dignitaries to kindly come forward for the lighting of the ceremonial lamp. I would now like to request our dignitaries, Professor Dr. Dilip Parida sir, Officiating Executive Director, AIIMS Bhubaneswar, Professor Dr. Prabhas Kumar Tripathi sir, Medical Superintendent, AIIMS Bhubaneswar, Lieutenant Colonel Abhijit Sarkar sir, Deputy Director Administration, AIIMS Bhubaneswar, Dr. Ruchi Gupta Madam, President APRASO, Dr. Parag Sahasrabudhe sir, and Dr. Vibhuti Bhushan Nayak sir, our esteemed guest faculty members, and Dr. Sanjay Kumar Giri sir, Organizing Chairman and HOD Department of Burns and Plastic Surgery, AIIMS Bhubaneswar, to kindly come forward and light the lamp.
फ्लावर देते हैं मीठा भी कितनी बार देते हैं
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्थं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्थं ज्योतिषां प्रभुरव्ययः
I would like to request all dignitaries to kindly take their place. I now welcome Professor Dr. Dilip Parida, Officiating Executive Director, AIIMS Bhubaneswar. Go ahead, go. Professor Dr. Prabhas Kumar Tripathi, sir, Medical Superintendent, AIIMS Bhubaneswar. Lieutenant Colonel Abhijit Sarkar, sir, Deputy Director Administration, AIIMS Bhubaneswar. Dr. Ruchi Gupta, ma'am, President APRASO. Dr. Parag Sahasrabuddhe, sir. And Dr. Vibhuti Bhushan Nayak, sir. To formally welcome the gathering, I now invite Dr. Sanjay Kumar Giri, sir, Organizing Chairman and HOD, Department of Burns and Plastic Surgery, AIIMS Bhubaneswar, to deliver the welcome address.
Good morning to all of you, respected esteemed guests in the dais and of the dais. Dilip sir, Officiating Director, DDA Abhijit sir, and Pravas, our MS. Vibhuti sir and Parag sir, the guest faculties who has come from BJ Medical College from long distance to tell about this workshop and CME, and our President APRASO, Ruchi Madam, and the dignitary and the and the delegates who has come from outside, offline and online. So welcome to these 2 days of CME and live workshop. Today is our live workshop and tomorrow is demo of this AV fistula, which is an important part. We have already started the CME and the importance of the kidney disease and how the role of AV fistula has been already explained to everyone, and gradually we are going to show the cases, the different methods by that we can assess these AV fistulas, and the patient should be taken properly care of. The motto of this small CME and workshop is this, so that proper AV fistula can be done and the proper justice should be given to these CKD patients, because Dr. Sandeep has shown the burdens of CKD in just yesterday in the morning CMEs. So we have to do this AV fistula in a proper and basic way, so that we'll get this knowledge and we can, and I think after these 2 days, tomorrow we'll get how to do this and how we can improve in these fistulas. This is going to help us. So in this way, I am thankful to Parag sir, who has come from long way, and also Vibhuti sir, who is my teacher also, to attend these 2 days of CME and workshop, which is going to benefit us, and I hope it will definitely going to benefit of by these 2 days by attending all these CME and workshop. Thank you.
Your warm words and for setting the tone for today's academic gathering. May I now invite Dr. Ruchi Gupta, ma'am, President APRASO, to address the audience.
Thanks. First of all, on behalf of APRASO, I welcome you all to the temple city of Bhubaneswar, especially Dr. Parag, who has come from a very long way. And I'm sure, sir, the program today will be a good value of your time. And already Dr. Sandeep has told the importance of AV fistula. He has talked about the burden of kidney disease that the world holds today. And I'm sure our trainees will definitely be benefited, and without demeaning the value of this program, they will pass on the benefit to the patients. Thank you.
Continued support for academic initiatives. I would like to call upon Professor Dr. Prabhas Kumar Tripathi, sir, Medical Superintendent, AIIMS Bhubaneswar, to kindly address the gathering.
Thank you. A very good morning to all. On the dais, Professor Dr. Dilip Kumar Parida, Sir, the officiating Executive Director, Dr. Ruchi Gupta Ma'am, who is the President of the Rashtra Society, and Dr. Sahasrabudhe, Sir, is the resource faculty for today's program and very eminent in the field, renowned Sir Dr. Vibhuti Naik, Sir, the organizing secretary Dr. Sanjay Giri, and Deputy Director Administration Lieutenant Colonel Abhijit Sarkar, all esteemed faculty members, resource persons, and the most important, the trainees who will learn from this workshop. Is very encouraging to know that such a state-of-the-art program or workshop is organized by the Department of Plastic Surgery. No doubt at the end stage kidney disease, the creation of a really state-of-the-art fistula is really challenge and also on demand, looking into the burden of the kidney disease. And when I was just listening to the last 10 minutes to the talk lecture by the Dr. Parag, the challenges are so much. Look into its anatomy and its patient selections and doing a proper cannula, maintaining it and functioning it are really very technically demanding things. And I'm sure that the resource faculties will address all of your concerns, and I came to know there is also a live workshop followed by some practice in the model. So that is how the workshop will be designed. I congratulate the team and all participants as well for this 2 days workshop. Thank you, and thank you all.
Words. I now invite Lieutenant Colonel Abhijit Sarkar, sir, DDA AIIMS Bhubaneswar, to share his thoughts with us.
Warm good morning to everyone. Respected and honorable dignitaries on the dais, Professor Dr. Dilip Kumar Parida, who is the acting executive director, Professor Dr. Ruchi Gupta, who is the president, and Professor Dr. Sahasrabudhe, Professor Dr. Vibhuti Naik, then Professor Dr. Prabhash Ranjan Tripathi, who is the medical superintendent, and Professor Dr. Sanjay Kumar Giri, the head of the department, as also the organizing chairman of the Department of Burns and Plastic Surgery. The present respected the honorable dignitaries and visiting faculties, respected head of the departments, eminent faculty members, resident doctors, and the participants who have come here, or rather most of them have come from distant places for this 2 days CME program. I firstly see the subject or the just a glance for 10-15 minutes at what of the presentation has been covered. It's a very significant topic, and it's quite a articulation topic, and I'm sure for the next 2 days on the hands-on training workshop and with the various demonstrations which will be in place, so it will be a good learning phase where there will be a lot of interactive decisions, and there will be a lot of takeaways when with one's expertise and the various reached experience of the various expert faculties who will be delivering their expertise on the subject. I once again welcome each one of you for this CME program, and also thank the head of the Department of Burns and Plastic Surgery, Dr. Sanjay Kumar Giri, and his team for organizing and conducting this workshop. Thank you very much.
For your words of encouragement. Dr. Parag Sahasrabudhe is widely renowned and respected plastic and reconstructive surgeon, known for his extensive experience and contributions. With a special interest in reconstructive microsurgery and vascular access procedures, he has played a significant role in advancing surgical techniques and training across the country. He was awarded honorary FRCS by Royal College of Surgeons, Edinburgh in 2024. He has held various positions of eminence, being the former Honorable Secretary of the Association of Plastic Surgeons of India and the past President of the Maharashtra State Chapter of Association of Plastic Surgeons. An inspiring teacher and mentor with over 50 publications in PubMed Index journals, Sir is widely appreciated for his academic excellence and commitment to patient care. It is now my honor to invite our esteemed guest faculty, Dr. Parag Sahasrabuddhe, to address the audience, sir. Please.
Thank you for those kind words. Respected dignitaries on the dais, delegates and friends. Let me at the outset thank Dr. Giri, because we were talking in last couple of conferences that we should have a similar workshop like this. And the whole idea was, since 2015 we have organizing workshops at my native place, that is Pune in Maharashtra. But every time everybody cannot travel to Pune and there are a lot of restrictions. So I told him that I'm more than happy to come to Bhubaneswar and we can have a workshop like this, and he immediately agreed. You know, he's a great organizer. So so that is how I'm here today. And I thank Dr. Giri for this excellent organization. As we have seen that, as Dr. Panda said, the magnitude of problem of CRF is huge. And as per the WHO statistics, India will be diabetic capital of the world by 2030, which is not very far, which is just 4. So you can imagine how more number of CRF patients are going to be there for we to cater. So maybe even if all plastic surgeons across the country start doing AV fistula, which is our aim to do so, because we should train more and more colleagues so that they go into AV fistula surgery. And how I started, I'll tell you, in 1999, when I passed my MSH plastic surgery, I had no knowledge about how fistula is done. I didn't know anything about AV fistula. And when I entered my practice, a good friend of mine, Dr. Tushar Dighe, is now professor in nephrology. He just called me one day and said, "Ki Parag, अरे मेरे patient का fistula करोगे क्या?" So I just knew that fistula is just joining artery and went together, as I said. And मैं बोला ठीक है, micro anastomosis आता है अपने को? हाँ बोल दिया मैंने phone पे. And then after that I went back to the literature, read about the original article from Seminobrassica and everything, and that's how the journey started. But then as we started doing more and more fistulas, then the nephrologists were also happy, because we created probably better fistulas than our contemporaries. So more and more the workload was all diverted to plastic surgeons. Same thing happened in a government medical college, where I went to the nephrology department. I said, I am willing to do a fistula. You send fistulas to us. Because most of the times these patients get neglected. They move from one place to another, fistulas fail, they don't come back. And as I said, as Dr. Panda said, the death rate is going to be huge in such patients, basically because of not being identified as CRF patients. So I feel that every individual, plastic surgery trainee should get exposure to AV fistula surgery. It should be part of our curriculum, so that we will be able to serve the society better. So thank you for inviting me here. Thank you.
Sir, for sharing your expertise and motivating us all. Dr. Bibhuti Bhushan Nayak sir has over 22 years of dedicated government service at SCB Medical College, Cuttack to his name. He has conducted 9,000 plus free flap surgeries and 1,000 plus replantations, including a double hand replantation. He has been instrumental in popularizing microsurgery and plastic surgery in the state of Odisha, making advanced care accessible to the masses. He has contributed significantly to academics with over 50 publications and has trained over 30 plastic surgeons who now serve across the country. He has been the recipient of the Odisha Citizens Award in 2023 for outstanding service. Recognized as a pioneer in reconstructive surgery, he has restored the lives and dignity of thousands. It is now my proud privilege to welcome Dr. Bibhuti Bhushan Nayak sir to the dais.
I have two illustrious seniors on the dais. Dr. Dilip Parida, who was my senior in MKCG Medical College, Berhampur, who happens to be the dean here, and Dr. Parag Sahasrabudhe, who was my senior in Sion Hospital, Mumbai, Dr. Abhijit, Dr. Pravas, Dr. Ruchi Gupta, and Dr. Giri. He needs to be congratulated because this is the first AV Fistula workshop happening in the state of Orissa, and for undertaking so many academic activities under the AIIMS banner and bringing in so much of expertise and training in Orissa in plastic surgery. So when I came here in 2003, AV Fistula was happening only by the urologist and the CT-based surgeons. So we started doing in 2007 and 8. And last year I checked one of the OT list. We had 21 AV Fistula on the list. And the AV Fistula by urology department and CT-based department have come to nut in SCB Medical College. That's the reason. The reason is not anything else. It's the quality that we deliver as plastic surgeons, the precision, the microsurgical expertise, and the knowledge of handling the vessels with love and care and passion. That is what stands out with the trained plastic surgeons, especially trained in microvascular surgery. And I'm happy that they are finding time to do AV Fistula, which is need of the hour, because with the alarming increase in the CKD patients, AV Fistula by and large remains the lifeline of these patients. And by performing good quality fistula, we actually give them a good quality of life, whatever number of days or years is left in them. So I once again congratulate AIIMS for taking up this initiative of conducting the first AV Fistula workshop, which will not only train but also will generate interest among so many budding plastic surgeons who are interested to take up this specialty and help the patients who are suffering with CKD. Thank you.
Professor Dr. Dilip Paridasa, Officiating Executive Director, AIIMS Bhubaneswar, to kindly address the gathering.
Good morning and warm welcome everyone. Dr. Parag, Ruchi ma'am, my younger faculty colleague on the dais, Professor Vibhuti, famous plastic surgeon in the state, Professor Pravas, the medical superintendent, Dr. Giri, head of the department, Burn and Plastic, and Colonel Sarkar, our deputy director, administration, faculty members of the department, and participants of this workshop. It gives me immense pleasure. AIIMS Bhubaneswar is organizing this CME and workshop. Today morning when Dr. Sanjay called me, I was also surprised. He told me, sir, you have to come to the inaugural function. I told, what is the function? AV Fistula. My response and reaction was exactly similar to that of Dr. Parag when his nephro friend requested him to go for a AV Fistula. For 5 minutes, actually, after the talk, for 5 minutes, I thought, what Burn and Plastic department is to do with AV Fistula. Then I called one of my friend, surgeon friend, because I am illiterate about the procedure, and he told, anyone can do that, any surgical department, because the demand and supply, there is a huge gap. Then I understood, in the interest of patient care, the Burn and Plastic, and the Burn and Plastic is not only the leader in organizing such workshop, AV Fistula, but in so many other things, Burn and Plastic department is now taking the lead, and that's good. Because as we go higher up in perfection, super specialization, and the super specialization departments taking interest in doing peripheral things. That's always actually in the better interest of the patient. That's what I think. And I again congratulate the Department of Burn and Plastic for taking lead in training and teaching department and section. And I am hopeful after this workshop, all the participants will be doing better, functional and aesthetically functional AV fistula than before. Again, congratulating the department and wishing the workshop a grand success. Thank you.
Thank you, sir, for your visionary. Felicitate our guest faculty with a token of our gratitude and respect. To Dr. Parag Sahasrabuddhe, sir.
Bring in the next tray.
Kriti. No. It's okay, come back. I've been trying to call you from behind now. Okay. Take it. To Dr. Vibhuti Bhushan Naik, sir. I now request Dr. Sanjay Kumar Giri, sir, organizing chairperson, to felicitate our dignitaries with a token of our love and appreciation. To Professor Dr. Dilip Parida, sir, officiating executive director, AIIMS Bhubaneswar. Can we have a huge round of applause, please? To Professor Dr. Prabhas Kumar Tripathi, sir, Medical Superintendent, AIIMS Bhubaneswar. To Lieutenant Colonel Abhijit Sarkar, sir, Deputy Director Administration, AIIMS Bhubaneswar. It is now my honor to introduce and inaugurate the Odia translation of the book Navigating Dialysis, the AV Fistula Handbook.
This book is the only Odia. This is the Odia translation of the book.
This book is the Odia translation of the book Navigating Dialysis, the AV Fistula Handbook. As we come to the close of this inaugural session, I invite Dr. Ranjit Kumar Sahu, sir, to propose the vote of thanks.
Respected dignitaries in the dais, my dear delegates on the hall, I am grateful from the CME on AV fistula, which is a small subject and a rare subject. It is rarely happening in this country. This CME is overwhelmed with the presence of our officiating director, sir, DDS, sir, and MS, sir, our President Apraso. And our special thanks to Parag, sir, who has been from Pune, giving here his time and energy for the propagating the knowledge throughout India, not only confined to Pune. Earlier it was only conducted at Pune, now it is outside Pune. In few days back it is conducted in Calcutta. Now today it is in AIIMS Bhubaneswar. So thank you, sir, for your time and your way of thinking. And Vibhuti, sir, who is master in microsurgery, he is my teacher also. And for his time and presence here, we are grateful and thank you, sir. Special thanks to our Dr. Giri, who is initiating his idea, and our team hard working for last few days, my SRs and our all faculties. So we are at least little enlightening a candle to spread this knowledge, to make this knowledge imprint in the youths, to have a willful action, and to able every creator. This is our motto. Every young youth surgeon, plastic surgeon should be able to be every creator. Now, henceforth, every fistula creator. Now you are a creator. Hope with this knowledge, what will impart in this AIIMS Bhubaneswar, with all everything, the best way of transmission. I hope, my thanks to our transmission also. Now it is in the online mode, so both offline and online. So your presence is graciously welcome. I hope you will enjoy the study, the live show with our experts, and the food, everything from Bhubaneswar. Now it is pleasant weather also, so we can enjoy everything. I hope you will back with good of thoughts, good of knowledge, good of skill. Thank you everyone. Thank you all.
It's our honor and privilege to have you here for such a meaningful academic interaction. We should be starting with the live OT workshop in a short while.
Thank you, Shastri Buddha sir. Thank you, sir. Thank you, sir. We show certificate happy to do one also. Assisted AV fistula. Okay. How many of you have done AV fistula? Okay, very good. I had. So, what is the significance of Allen's test? I am just trying to make it. Whenever you want the mic, you can take the mic. Yes. I am just trying to not to utilize the time in between. So what is the significance? Anyone can tell. Like, we are not giving any marks here. Yes. Yes. Yes.
It is to check the patency of the palmar arch, since we'll be operating on the radial artery, which is one of the dominant supply to the hand.
Okay.
And in case there's a thrombosis of the radial, or we might end up doing
I'll interrupt you. I needed just a brief answer. So what is Allen's positive? What is this is related to your exam. So what is Allen's positive and what is Allen's negative?
So if once we occlude the vessel, in case there is a flow within 5 seconds, less than 5 seconds to the, let's say we are occluding the radial, if the thumb, the capillary refill is within 5 seconds, then it is positive.
Okay.
And if that is delayed, then it shows Allen's negative, and we have to be careful.
Okay, no problem. One very important thing that was mentioned in the radiologist lecture also was related to different variations in bifurcations of brachial artery. So sometimes we don't have a brachial artery. Axillary artery divides into 2 branches. Sometimes I had one instance where the artery divided and again it united, again it divided. So that is why it is better to get pre-op Doppler done. Okay. So our biggest enemy is blood pressure. Our biggest, Parag sir also told in his lecture that hypotension is the cause of failure. So our biggest enemy is blood pressure. Many times patients go in hypotension and fistula can fail. Proximal fistula or distal fistula. Okay. So, regarding brachial artery to basilic vein, AV fistula, Sir Parag sir had suggested single stage transposition. Okay. We do double stage. Sir is much senior to us. You are getting my point. So both ways are accepted. If we are doing single stage, then we'll transpose it in the single stage. If we are doing double stage, we'll first do the anastomosis. Then after the vein is around 6 mm or 8 mm in diameter, then we'll transpose it anteriorly. Okay?
So during the second stage, then do you divide the nerve also?
Yes, we have to many times divide the nerve. The thing is, if we have during second stage, if the vein is very tortuous, then we might not cut and do the anastomosis again. We'll just transpose it anteriorly below the flap. We might have to cut one or two branches of the nerve and coapt it again. Getting my point? But if the length of vein has not increased in length, it has not become tortuous, it has only increased in diameter, then we might have to divide, tunnel and redo the anastomosis. Okay? Regarding proximal radial artery anastomosis, like anastomosis in the proximal forearm with the radial artery. The thing is that at wrist and at cubital fossa, we don't have much muscle mass. Okay. At wrist and cubital fossa, we don't have much muscle mass. So dissection of the artery is easy. Okay. So we were doing a lot of this mid forearm AV fistulas before. Now also we do, but the numbers have reduced because we have to go inside the muscles and do the anastomosis. Second problem was, in case there was aneurysm near the anastomosis site, it is difficult to do dissection between bifurcation of brachial artery and the site of anastomosis because we have a very small segment around 2 to 3 centimeters. You are getting my point? That is why we do either distal or proximal. Sir mentioned about deep tributary of the vein being Greg's fistula for anastomosis. So that also we have done many before, but dissection, it is a very good vein, but dissection can take some time. Okay. Regarding grafts, so what grafts can be used? If there is no vein, cephalic is not good, basilic is not good. So which all grafts can be used? Cephalus. So we'll do bilateral thigh. We'll get Doppler for thigh also to check how much is the vein diameter, which is good, which is not good. Then we can use either Cephalus graft or we can use PTFE graft. So PTFE graft can be either a cylindrical graft. So from above below, diameter would be 6 mm. So it will be a long cylindrical graft. There is another graft in which it is spatulated at the venous end. So the arterial end would be 4 mm and venous end would be 6 mm. They would be elongation. Okay. Oval opening on the venous side. It is slightly more expensive. Okay. So does all patients, do we need to do Doppler, venous Doppler in all the patients? Yes or no? Ideally no, but for our safety it is better. What happens is, if we have done the Doppler and the fistula fails, then patient thinks that डॉक्टर साहब ने अपनी तरफ से कोशिश की थी. What happens is, patient got fistula done from me, his distal fistula fails. He goes to some other surgeon, and that other surgeon might say कि Doppler पहले क्यों नहीं किया. So for our safety, it is better to get the Doppler done. My wife is a radiologist, so it is important to have friendship with a good radiologist who would discuss all things with us. It is important to know if there are any major tributaries in the vein,
velocity in brachial artery, radial artery, and ulnar artery. These things we ask in all the patients. If there is too much calcification in the artery, that the radiologist should call us and inform. If there is any anatomical variation, they should call us and inform. Because if there are 3-4 patients posted in a day, we might miss these findings. But it is always better to go through the Doppler report before we go ahead with the surgery. It is not must. If veins are good, we can. But patient needs to know this, that like an anomaly scan in a pregnant lady, doing anomaly scan would not alter the outcome of pregnancy. So doing a Doppler scan would not alter the outcome of our AV fistula surgery, but it helps in deciding the level of surgery. Okay. What are the, if how to reduce chances of lymphoria in proximal AV fistula surgery? I am just trying to make it interactive. What have you seen any patient? Has anybody seen a patient of lymphoria? Okay. What happens is if we take a longitudinal incision at the cubital fossa, we are less likely to injure the lymphatics. If we are taking a transverse incision, there is chance of injury to the lymphatics. Okay, so if there is, and it has happened with my own hands also. So it is a possibility. If we are taking oblique or transverse incisions, lymphatics can be injured. So ideal way to avoid this is to take longitudinal incisions. Okay. If we have taken transverse incision and if lymphoria happens, how to treat it? We can use the ICG camera. Put a dye from here and see where the lymphatics are and can try to cauterize that. But I have not done that till now. Few patients, it has subsided on its own. Okay, with dressing. It is few tips I am giving you for your practice, private practice. Being in a government hospital is different. Being in private practice is different. So I work as a team with another plastic surgeon. I had not done any fistula in my residency. He had done few. So we did our 1,000 AV fistulas together. First 1,000 AV fistulas together. We used to get 4,000 rupees, 2,000 rupees each, and travel 50-60 kilometers for that. Okay. But it does not matter. We share the fees equally, and having a trained assistant helps a lot. Even now, if we have some complicated cases, we do it together.
Hello? Yes, Dr. Kirti. Hello? Are you able to hear? Madam? Yes.
A very good morning, respected faculties and my dear delegates. I would now request Dr. Parag sir to take over for the procedure.
And Dr. Parag, am I audible? Hello? Section.
Yes, I hear audible, sir.
Yeah, okay.
Yes.
So I'm just explaining the markings here. This is where I can feel the radial artery. Okay, so I have marked the radial artery here. Okay. Now this was the markings which were done pre-operatively with a venous tourniquet. You can see this is a cephalic vein and it has got two branches here. So this is what I was talking about, the accessory vein. If you are doing this vein anastomosis as end to side with the radial artery here, then we will have to ligate this vein because it is within 5 centimeters of the anastomosis. Otherwise, it will steal the flow towards the forearm on the dorsum of the hand, and there can be edema and swelling on the dorsum of the hand. So now, once you know your markings, okay, now you see the distance here between artery and vein is really far. We'll just measure. Do you have measuring tape?
Scale, please.
Please give me scale. See, the distance here is almost 3 centimeters from the artery and vein. So what I will do, and we have a branch here which we have to ligate. So how you plan your incision is now the main thing. You can take an incision here, but then that you will not be able to expose this cephalic vein. So you will have to go slightly proximal so that you want to expose this cephalic vein, branch of the cephalic vein here, so that you are able to ligate this. Now the artery marking is here. So you draw a parallel line in between to the artery as well as to the vein. And the simple way is to just mark an S-shaped incision like this. So this is the central limb, and then you have two small gentle curves on both the sides. So this is going to be the incision which I am going to mark. So once I expose this flap here, I will be able to find the radial artery here, and once I raise this flap outward, I will be able to find this bifurcation of the vein here. So this is going to be the incision, and this is how you plan the incision. Sometimes you will have to take it low down, sometimes you will have to take it a little bit higher up, but it all depends on the surface marking of your artery as well as vein. So we are just going to give patient the local anesthesia now. एक इंजेक्शन दे रहे हैं, थोड़ा बेहोशी का इंजेक्शन दे रहे हैं हाथ के ऊपर. Okay, can I give? Yeah, okay. So this is 2% plain xylocaine 10 cc without adrenaline. एक सुई लगेगा बोल. Okay, okay. Okay. This is. It's always better to take Luer-Lock syringes because sometimes under pressure the needle can just separate. Always aspirate before you infiltrate. That's what we have all been trained about. Okay, and that should be good enough. We just wait for 2 minutes before we check that local anesthesia acted, and then we can start. In the meantime, I will just check the instruments. Can I see the instrument? Yeah, okay. This is
Dr. Parag?
बहुत बड़ा है.
Dr.
Yes,
Parag?
please, yes.
I'm Dr. Ruchi, and
Yeah.
I have been given the honors of asking the questions.
Yes, madam, please.
Students are not able to ask, I'll ask.
Okay.
On behalf of them. So first thing is, in preparation, what things we have to keep in mind? Like you said that dialysis has to be done 1 day
Yes.
before. Anything else?
Dialysis, see, you have to take the fitness from the nephrologist. Unless the nephrologist gives fitness, no, I don't want to. So patient has to be adequately dialyzed earlier so that he is comfortable on operation table in supine position. As I said, pre-operatively one has to do dialysis maybe sometimes 2 times, 3 times depending upon patient's comfort.
Any creatinine threshold?
Any?
Creatinine value threshold? Value of serum creatinine value?
No, that's not, because see, most of these patients will have creatinine of 7, 8. As long as they're stable and comfortable, we have no issues, because level of creatinine really doesn't matter when you're doing AV fistula. They are going to have high creatinine anyways.
Okay.
Only thing that they should not be in overload. That's the main thing. So that is why you dialyze them pre-operatively.
and adequately dialyzed, adequately made negative. So sometimes they do about 3 liters, 4 liters negative during dialysis. And that quantity is decided, how much to be made negative is decided by the nephrologist.
Okay.
Can I have a kidney tray where you can keep all these instruments in heparin saline? Hep saline. And put all those instruments in hep saline. Yeah. So we're just waiting for local to act. We'll just check whether he has pain. Just ask him whether he has pain.
दर्द हो रहा है क्या?
दर्द हो रहा है क्या? अभी हो रहा है? What is he saying?
हिंदी में बोलो।
दर्द नहीं हो रहा है ना आपको? अगर आपको दर्द होता है तो बताओ हमको. हाँ?
हाँ उनको बोलो वो महसूस होगा. ठीक है.
आपको सब समझने वाला है हम क्या कर रहे हैं. टाका लेंगे तो भी आपको समझेगा कि टाका ले रहे हैं, लेकिन दर्द नहीं होगा. दर्द होगा तो बताइए. कैट्स पॉ. दर्द होगा ही नहीं आपको. दर्द होगा तो बताइए हमको. 15 नंबर में.
15 मिनट प्लीज.
Okay, so we are starting with the incision now. Give me a tenotomy scissor.
Sir, do you have a tourniquet control?
No tourniquet. No tourniquet at all. Yeah, okay. Bipolar pad. Where it is? Yeah. Okay. I don't know whether you can appreciate a superficial vein here, but that's too small in size, so that's not what we are looking at. We are looking at a cephalic vein, which will be much more in diameter. Okay, get a cat's paw. Okay, hold this like this, yes.
ये हाथ पकड़ो ऐसे.
Just, there is a cephalic vein here. Can you see this? Can you see the cephalic vein here? I'm just coagulating this smaller vein. You have a clip?
Yes, sir.
Yeah, give me a clip. 100, yeah.
Excuse me, sir.
Yes, one more.
Can the image be magnified? We are unable to visualize.
Can you see the cephalic vein?
No, sir, it is not visible. Can the image be magnified?
Not visible, just a minute. Huh? Give me a plain person. I'll just deliver it out. Wait. See, here is the cephalic vein. Can you now see?
So we need magnification. We're not able to see properly.
Okay. Can you do something for the magnification before I...
Yes, sir.
We'll wait. They are doing something. Somebody is coming to do magnification. Can you see it now? Can you see the vein here?
Yes, sir.
Yes, sir, it's visible.
Yeah, it's visible? Good.
I would like to request Dr. Ruchi Gupta ma'am, Dr. Ramesh Chandra Das sir, and Dr. Ritesh Panda sir to chair this live OT demonstration.
Yeah, okay. छोड़ो इसको. Can you see the bifurcation now? I think you can, if you zoom, you'll be able to see the bifurcation as well as the valve near the bifurcation. It's
Yes.
clearly visible.
Yes, sir.
Yeah.
Can you see?
Yes, sir.
Can you see this valve?
Yeah.
Okay, so this is the branch that we are going to ligate, and this is the vein that we are going to anastomose with the radial artery.
Clip, please.
No, wait, we'll do that later on. That's not okay. Just dissecting anteriorly now. The way we have to follow the vein, because the vein has to be mobilized, because here the distance is 3 centimeters. So we'll have to mobilize the vein distally so that it reaches the artery very easily without any tension. Oops, sorry. Oh, sorry. Wait. I almost dropped. Okay.
Hello. Parag sir, good morning. Dr. Mitesh here.
Yeah, morning.
Sir, there are so many discussion going on for the lymphatics, regarding lymphatics. So do you visualize the lymphatics or you do?
The thing is, one is avoid transverse incisions. That is one which I already told. Secondly, do is whatever minimum dissection is required. Don't dissect the flaps too much. You just want the artery and vein to be identified. You've got this thing in this.
So anything
So don't-
specifically you do, sir, to avoid any lymphatic damage or something, sir? In this case or in brachiocephalic?
No, nothing specific we do. Now you see here there is still further branching of this cephalic vein. Can you see?
Yes, sir. Yes, sir.
So there was one branch proximally and one branch here. So what I would try
Can we
and
get
do
some
is-
magnification?
Okay, so all these small branches we are going to clip away. Okay, give me a liga clip. Yeah.
No, it's good now.
One more. Okay. Now we are going to ligate this branch also, which is likely to develop into accessory vein. The importance here is, if I do the fistula anastomosis first, and then I ligate this vein, what can happen is, suppose we have done, can I have a microforceps? Yeah, okay. So now if this vein is mobilized and is, suppose we say the radial artery is here like this, you join this and this together, you can see the tension on the accessory vein now?
Yes, sir.
Hello? Yeah, okay.
Yeah.
What will happen is the length of the vein will be wrong. If I ligate this after the anastomosis is done, probably there will be increase in length of the vein.
Yes, sir.
Yes, sir.
So it is better that you ligate this branch first and then see which is the best point where the arteriotomy has to be planned. Now we have a clip here. If this part of the vein proximal to the clip reaches the site radial artery easily, I would not take this part in the anastomosis at all. I will discard, we will put another clip here and let the distal vein remain like that. Only if it doesn't reach, then only we will go distally. Plus we have a valve here, as you can see here again in the vein.
Okay.
So I'm just first going to mobilize the vein completely before you decide on arteriotomy site. Ligating all the branches. A bigger clip.
Okay.
Because see, if you have done it at 30 degrees and then suddenly this branch is cut and released, the vein is going to come towards the radial side. And then your angulation of anastomosis might change because suddenly there is increase in vein length.
Yes, sir.
See, now this is a well mobilized vein here. You also go proximally and to check that there are no fibrous band which are obstructing the vein, or there are no any other branches. Okay, so I'm not going to mobilize this right now. This is in case we required additional length, we can always mobilize that. So the vein is done. Now we go for the artery side. Just leave this. Yeah.
Sir, how much do you mobilize proximally?
Proximally, no, after the anastomosis, I see if there is any proximal compression, only then I will mobilize proximally. Otherwise, I will not mobilize proximally.
Okay, sir.
Yeah, just. Okay, just leave it in place. Yeah, lift it up. Okay. So now we are trying to dissect the artery here.
Sir, OT2 is ready. Can we shift for some time?
Yeah, OT2 is also ready, I think.
Yeah.
So you can shift for some time, and by the time I will expose the artery, and then we can
Yes, sir,
come
we'll
back
come
here.
back to you, sir.
Hello, Dr. Amrish, can you hear me in OT2?
Yes, ma'am.
You can start the audio from there.
Good morning, everyone. This is the second case of the day. This is a case of a 54-year-old male, chronic kidney disease, stage 5, for duration of 1 year. The patient is on hemodialysis since March 2026 through right IJV. The patient has diabetes mellitus and hypertension, and he has a dominant right hand. The plant lymph is left upper limb. The arterial status is the brachial, the radial, ulnar artery are well palpable. The Allen's test is normal. The venous status, the vessels are prominent. Hemoglobin is 7.8, while the creat is 5.26 and potassium is 3.8. On ultrasound, distal radial artery is to be 9.2 mm in caliber and cephalic vein is 2.1 in caliber. The proposed plan for the surgery is distal radiocephalic end-to-side anastomosis.
Yeah, can you hear me? This is the second case. Yeah, this is the second case, and you have been already briefed about the patient. This patient has been worked up really well, because many times you get patients where even though the Doppler shows the vein is okay, diameter is okay, but because of the edema in the hand, you are not able to see the vein. In this patient, we can see nice and engaged vein. The artery is very well palpable.
That is what I wanted to know, sir. Normally we get very edematous hand. So what should we do for that? Can we do anything for that?
Which one?
The edematous hands. Normally these hands are very thin and arteries are very much palpable.
Yeah, many times you don't see the vein, but you have to bank on the ultrasound report, and based on the anatomical landmark, you take the incision and dissect out, because once you go inside, you'll definitely find the vein which is already good on the ultrasound. Okay. So here clinically we see a nice vein, so we don't have any doubt about the quality of the vein. Sir. So this is a good, this is an ideal case, and normally in practice you'll find about 25 or 30% of the cases who have nice and engaged veins and good vessels.
Yes, sir.
Most of the other cases you will have to guess.
Sir, what is the recommendation regarding the dialysis? The day before the fistula is to be done, dialysis has to be done?
Yeah, at least 24 or 48 hours before the fistula.
And any, sir, this any hemoglobin levels, anything you specifically see before this AV fistula, sir?
See, basically, the CKD patients, they have physiological problems. Hemoglobin is on the lower side, but then at least it has to be 8 gram plus hemoglobin.
To help in healing, I think.
Yeah, at least 8 gram plus. Below that, you should wait. Normally, these patients receive erythropoietin, which is given to improve the hemoglobin in the renal disease patients. So once the hemoglobin is, if it is around 10, that's the ideal. More than 10, it's still better. But below 8, we should delay the surgery.
At least 8.
And another problem with these patients, CKD patients are also immunocompromised. So your asepsis has to be spot on. You should not have any wound infection. Once it happens, then you can have problems. So they are immunocompromised. And another patient they have is the bleeding, the tendency to bleed is little more than the other patients. So, and you don't want hematoma at the side of the fistula. So you have to see all the small bleeders and control them before you do the fistula.
Why you will not give blood transfusion?
Sir?
Why you will not transfuse blood if the hemoglobin level is low?
No, you can, you have to decide how urgent is the fistula. If the fistula needs to be done immediately or within a couple of days, it's better to give transfusion and then go ahead. This patient has started dialysis just 1 month back, has a central line. So, and the hemoglobin is okay, so we need not. But if the hemoglobin was low, we could wait for a few days, because once you give erythropoietin, the hemoglobin goes up within a week's time.
And you recommend a heparin-free dialysis day before, sir, or a normal dialysis, whatever they are doing?
I will recommend heparin-free dialysis after the surgery.
Okay, not before it.
And normally I do under tourniquet control under brachial block, but here we are doing under local anesthesia. And if I give local, I prefer a combination of xylocaine with sensocaine, because the patient will have analgesia for about 6 hours after the surgery. 15 more blood. So here you can see this is the vein that we have marked. There's a nice vein here, and this is the artery. I am little more liberal in the incision, because you should have a good dissection of the artery and vein. Any tributaries nearby have to be ligated. And the incision I place is in between, the equidistant between the artery and vein. Here it is the vein, here it is the artery. So I place a longitudinal incision midway.
So what is the ratio of this local infiltration what you give, sir?
50, I have given 5 ml plain xylocaine and 5 ml plain sensocaine.
Okay, you don't add this ADR.
See, from the incision you can make out the patient has a little tendency to bleed.
Yes, sir.
Normally,
they usually have a higher PP, so you always give one dose of antihypertensive before the surgery, sir?
Yes, most of the patients have hypertension, and they have to get all their medications, antihypertensive medication. If thyroid, hypothyroid drug, everything has to be given before the surgery. And most of the surgeries are done under block or local anesthesia.
Bibur sir, can we shift to the OT1? Parag sir wants to show the artery.
Yeah, please.
Yeah, thank you very much, sir. Please switch to OT1.
Hemostasis is done. Normally they have a tendency to bleed. Okay, dolphin, long dolphin. Tenotomy seizure. So you can put the hook here.
Yes, Parag sir.
Skin. What is the blood pressure of this patient? Dolphin.
I know.
Yes, sir. Parag sir, we are with you.
Okay. So this is the vein that we have dissected.
Yes, sir. It is visible.
There was small branch here which we ligated. Now we have decided that this is the artery that is being mobilized. I put the clamps for the artery. Can you just retract this a little bit? Can you see the artery now? Focus करना पड़ेगा. I think it's not clear.
Focus is required.
Little bit of focus is required in the camera. They are adjusting the camera, like. No, focus.
Hold the hand like this.
No, but it's focus, it's not in focus.
Hit the tap autofocus on that screen.
Is it in focus? Can you see in the focus? Because in the monitor here I cannot see the...
Yes, sir, we can see the artery.
No, is it, image is absolutely clear?
Yes, sir, it's clear.
Okay, fine. Okay. So there is a branch here. I have put a distal clip here and now we are going to cut the vein. This was our accessory vein which we clipped. So I am just going to check how the artery and vein are going to come together, and accordingly we are going to make an oblique cut here. So I am cutting the vein now. Okay. Give me a syringe and flush.
So what is the length of the arterial segment you have clamped?
Length of the arterial segment that we have mobilized is not more than 5 to 6 millimeters. See, this is how the artery is going to the vein. Can I have another? Leave this. Yeah. Can I have another micro instrument? Forceps. Can you keep the micro set here only? Keep the set here only. Yeah. Okay. So this is how the anastomosis is going to be, like this.
This is valve here. This is the...
I'm just releasing the clamp on the vein to the backflow or not. Flush, please.
Small gauze piece. Okay. Give me a stitch cutting.
So here you see that there is no backflow in the vein. So now what do you do? Whether you proceed or not. Now the test is, if there is no backflow in the vein, I would like to put a hyperinized saline, infuse the hyperinized saline into the vein, when I will ask my assistant to feel for the thrill on the vein, in the forearm. So you can see there is some backflow coming now.
Yes, sir, yes.
Okay, so this is...
Yes, okay.
So can you feel for the thrill?
Yes.
So he says that he can feel for the thrill. I take his word. So now after the anastomosis, if there is no thrill, he is responsible.
So what is the concentration of heparin you are using, sir?
It is 100 cc saline. How much saline you have taken?
300, sir.
Okay, so he's put 500 cc saline and 5000 units heparin in it. So very dilute. Actually, it's a holding solution for the instruments. Okay, now we are going to do an arteriotomy. Give me 11 number blade.
This knobs. This is knob. Superficial radial knob here. So we should not injure the knob. The patient will complain later on.
Sir, any specific formula for this length of the diameter of the vein to the arteriotomy length?
Yeah, so as far as possible, you match the diameter of the artery and the vein. So accordingly, you can take and cut depending upon, if you have a small vernier caliper, we can measure the diameter of the artery and the vein and then take it accordingly. And another thing is sighting the arteriotomy. Now, see, I have not talked about the planarity of angle, which I am going to talk on my talk during hemodynamics of the flow. Now what happens is, this is the vein. Here in the radiocephalic fistula, you have artery and vein in the same plane. Okay. But in brachial fistula, it doesn't happen so. The artery comes from the top. So, the vein comes from the top. So your arteriotomy has to be adjusted accordingly. Here, you cannot have an arteriotomy here and try to put vein like this. Here the venotomy, the arteriotomy has to be on the lateral side so that this comes in the same plane. Because that is going to change the three-dimensional twist of the vein, and that is how the flow dynamics change. That we will talk when we talk about hemodynamics. So I'm just making a puncture on the artery here. Irrigation, please.
These patients tend to bleed more than the other patients. So normally I prefer to do under tourniquet, do brachial block myself and do it under tourniquet. It's much
You can switch to the other OT, and when we start anastomosis, you can come back here so that I will talk about the anastomosis.
Sure, sir.
Yeah.
So can we switch to the OT1, OT2? Yeah, Vibhuti sir, we are with you.
I have already dissected the vein. I am on the verge of completing the dissection of the artery microforcibly. So,
can we have some zoom in?
Yeah, skin hook.
Zoom karo, Girija. Girija, zoom.
So what you are seeing is right now the radial artery. And all the perforators in that segment, I normally dissect about 4 centimeter length of the radial artery.
It's 4 centimeters, sir?
Yeah, about 4 centimeter length. Okay. So that it should be comfortable. Whenever you do the anastomosis, you should be able to put clamps very comfortably. So if you have a good segment and artery and vein, your anastomosis becomes much more convenient.
Yes, sir.
Just a moment. Where bleeder? There is a bleeder there.
Switch. Okay, so I'm starting the anastomosis. Am I audible?
Yes, sir. Yes, it is audible.
Okay, so it's a.
Vibhuti sir, we are
show me the
shifting to
suture.
OT1.
Show me the. Let me show you the suture. So I don't know whether you can. Can you see this?
Focus.
Yeah. Okay.
Yes, sir.
Yeah.
70
So
proline.
it's a 70 proline, round-bodied, 9.3 millimeter, 3/8 circle, Visi-Black needle. Okay. I have taken the vein at 3 o'clock from outside in and artery inside out. So I have 2 needles in my hand. इधर गया दूसरा. पानी मारो हाथ के ऊपर. So I normally do continuous suture, so I will just tie this knot.
Leave the other one. Let's see the vein whether it's.
Since it is proline, at least 6 to 7 knots. Okay, and after that, you keep one thread aside at the proximal end. Take a saline soaked gauze and put it over it so that you don't leave. That thread doesn't come up while you are suturing. Another thing that I do is, if you can see here, I put 2 gauze pieces here to cover the clamp. Okay.
Yes, sir.
Because while since it's a continuous running suture, sometimes it does happen that the thread gets stuck into the clamps. So you don't want that when you are doing it. That is why you keep 2 small well-soaked clamps.
Yes,
so I'm going to follow, I'm going to do the posterior wall first.
So what is the magnification we are using now?
I am using a 4x loop magnification. I do all my fistulas under loop magnification. So I'm coming again from outside in into the vein. Inside out on the artery. Just give traction to the opposite thread, then everything will fall in place.
You will tell your assistant to follow, sir?
No, I don't allow assistant to follow. It's not required at all. Because it's not going to get entangled anywhere because I put gauze pieces here.
Okay, yeah. That is a good idea, sir.
See, now you can clearly see some part of the vein wall is being done.
Yes, sir.
Yeah, okay.
Can you have some magnification?
Don't put too much of saline here because it's going to cause the field is going to be blurred then for them.
फोकस करो, स्लाइडली जूम आओ और फोकस करो, फोकस करो, फोकस करो। थोड़ा जूम आउट करो।
It's got stuck here now. You see this? छोड़ो।
जूम आउट करो।
इतना लंबा गया वो।
जूम करो जरा। स्लाइडली जूम। बस वेट।
You put water on this so that ये ऐसा लूज होके नहीं निकलेगा.
Tell your assistant to put saline on your hands or on this one.
Yeah. When I'm picking up the needle, he's putting saline there.
Okay. Sir, sometimes it has happened that when we have done an arteriotomy bigger than the vein, so
Yes. So then you have to reduce the size of the arteriotomy. The distal artery you can close primarily.
okay.
Can you give me the Caesar? This adventitia was coming in between this. It came second time, so. Awesome.
Parag sir, we are shifting to the OT. Another OT. We'll come back to you.
Yeah, okay.
Vibhuti sir.
Yeah. So here we have progressed to, we have dissected a segment of the radial artery. You can see this. This is the radial artery. This is the radial artery. We have dissected the radial artery.
Can you have some focus on that?
You can see the radial artery now.
Yes, sir.
We have applied the double clamp on that. This is the radial artery. There were three perforators which we have ligated. And here in the cephalic vein, you can see one. I have kept it long to show you. This branch was there, which we have clipped. So if you keep this branch and do anastomosis, then there will be accessory branch. So we don't want that. So I have clipped that branch. And now the decision to make is there is a valve close by. He was asking whether the valve is in a favorable direction. Even if you do the anastomosis, there will be no problem. The flow is in this favorable direction, no problem. So this is the comfortable lie. I'll make it little shorter here, around here. Okay. The vessel dilator.
Is there a good backflow from the vein, sir?
Yes, you can see the backflow here. Plus,
Yes, sir, yes,
plus. We have checked it. The other bands had good backflow because it's above the valve here, because there is a valve, but still, after dilatation, you can see this. So once I dilate it, you can see the valve is competent, therefore you are not getting.
Sir,
once I dilate the vein, you can see. Now you can see.
Yeah,
okay.
yes, sir. Sir, if we don't get a backflow, what else to be done, sir?
No, if there is no backflow, then you have to take the venflon and then flush.
Okay, heparinase saline.
And see whether there is free flow into this thing. And many times after you flush, there is backflow, many times. But when you flush and there is resistance, there is no backflow, then you have to rethink. Here there is backflow, there is a valve here. Once I dilate the valve, once I manipulate the valve, you can see the flow here.
Yes, sir. Yes, sir.
Okay. The another thing I have done here is I did put papaverine on the vein. The vein is looking more engorged and dilated just because of papaverine. I normally prefer papaverine. It dilates the vein, and at the same time, the adventitia becomes non-sticky. See, adventitia, it's easier to do adventectomy after you put papaverine. And the chances of spasm also is reduced. This patient had a spasm just above this valve, so we did adventectomy, and papaverine did help in this particular case. So I am planning to do end to site. So the end of the, you can see the end of the vein, and the artery, I'll do arteriotomy now. Background.
So you do a proximal dissection of the vein, sir, apart from other problems?
Yeah, I have already done, just do a skin hook.
So how much is advisable approximately to dissect, sir?
As far as possible through the incision you have. From this incision, see, there is a good backflow. All we have to ensure that, see,
there is no kinking.
There is no constriction. Only fibrous bands around, they don't constrict the vein. There is a comfortable, I can put this up to this.
Yes.
About 2 inches behind the incision I can go. So there will be no problem. This will be a good case for fistula. Yeah, background. Okay. Artery, mosquito. You can see the field is little bloody. You are asking about heparin-free dialysis before.
Yes, sir.
This is what happens if the patient doesn't have, but we can manage. This bleeding that you see here has to be controlled when we are doing the fistula. So we have to be meticulous in hemostasis. Seizure.
Sir, we are shifting to the other OT. We'll come back to you.
Okay. So give me microscope. Microscope. Yeah.
Okay, have we come back?
Yes, sir. Yes, sir. We are with you.
So we have completed the anastomosis. You can see here.
Please focus.
Please focus. Okay, so we started from my side. If you see, I started at 3 o'clock, completed the posterior wall and the long thread. Here we tied a knot. And then from the other thread, which was towards the head end of the patient, we started the anterior wall continuous running sutures, and we have completed the anastomosis, tied both the sutures, and we are about to cut the suture now and release the clamps. Hold this. Yeah, thank you. Another forceps to me. It's okay. Okay.
Sir, in your experience, which is better, continuous suture or intermittent suture?
I always take continuous suture. So I am releasing the vein. Clamp. As we saw, there was no backflow, but now there is some backflow. You can see here, this clamp is too tight. Release the distal arterial clamp first. So check for any leaks. If it's a minor leak, don't. I think we need to take one stitch here. You can actually release the clamp and take a stitch, then you exactly know where it is leaking from. Give me this thing, retractor. Okay, hold it like this. एक नीडल दे दो छोड़ो छोड़ो बैक हैंड में क्यों दे रहे हो नीचे रखो irrigate the leak seems to be quite significant here. Flush. Flush. Okay.
Flush. Wait, it has to be a... What is the patient's BP?
155/80.
Okay. Okay, that should be okay. Release this. कट स्टीम आ रहा है क्या यहाँ से? और लेना पड़ेगा शायद, देखते हैं। ठीक है, देखते हैं। I'm releasing the clamp just to check.
Irrigation open करते हैं.
Okay. So we just give pressure for 5 minutes and then we'll wait.
Yes.
You can go to the other theatre and come back.
Sure, sir.
We're just going to give pressure now and wait, not immediately taking any further sutures.
Okay, so
yeah, we will sir, we are with you.
Here you can see I have gone under the microscope, and you can see this is the arteriotomy that I have done. I introduced a needle, not 11 hour blood. I introduced a needle.
Sir, what is the suture you are using, sir? You will be using?
I'll use 80.
Nylon.
So, proline, I prefer proline. So, this has to be almost equal to the diameter of the vein. And this will be neatly done. The intima should be very neatly cut.
What is the size of arteriotomy you will be doing? Dr. Vibhuti, what is the size of the arteriotomy?
It's approximately the diameter of the vein. And the vein also I have cut little obliquely to make it larger. It's almost 2.5 millimeter. Focus is changing because the okay. Just want a little bit of okay. Adventitia is gone. Now vein adventitia also is there a little bit. Just hold this adventitia, this one. Yes. Okay. Now leave it now. Give me now 80. Leave it now. Leave it now. Give me 80.
Sir, how much adventitia we should remove? What you recommend, sir?
Adventitia should be in the zone of suture material movement. So the suture normally sticks to the adventitia. So wherever you expect the suture to move, that area should be free of the adventitia. Otherwise it sticks and makes things a little difficult. Of course 80 is not that sticky, but if you go for a finer suture material, it can be more sticky. The 80 there.
So one of my vascular colleagues he told me that, sir, we don't remove adventitia because sometimes it helps in stopping the bleeding after the suturing. Is it true? Does it help, sir?
See, adventitia, the purpose is adventitia fibers should not go inside the lumen.
Yes, sir.
They are extremely thrombogenic.
Yes,
so that's the reason why at least few millimeters from the side of the anastomosis, the adventitial fibers should be dissected. So how extensive or it should be conservative is up to you, but at least conservative excision has to be done. Otherwise, some fibers getting into the lumen, it will be thrombogenic.
Yes, sir.
This is a very high pressure system, so you may not have any problem here. But in classical vascular, microvascular surgery, you should be very careful about the adventitial fibers. AV fistula, the caliber is the caliber of the vessels are big, so it's little forgiving, little bit of error. Give any scissor which I just want to cut this. This is coming in my way. Disturbing us. So, no?
Is the mic on?
Sir, we are shifting to OT1.
Yeah, okay, put on. One more. Test.
Parag sir,
am I audible? Yeah,
yes,
okay, so we have completed the anastomosis. We have just taken a vernier caliper to show what is the diameter. It is 6 millimeter diameter of the fistula here. So you are asking Dr. Vibhuti that how much should be the diameter of the anastomosis. It should be 6 to 7 millimeters for distal fistula and not more than 5 millimeters for proximal fistula. So now you can see here there is small facial band. Can you appreciate this facial band which is crossing over the vein?
Yes, sir. Yes, sir.
Okay, so we'll just release that. See, these are small minor points after your anastomosis that you have to look for, because this will eventually cause outlet obstruction. See, the vein has dilated up to here and it is still constricted. Can you appreciate that?
Yes, sir. Yes.
Okay, so I'm just going to milk the whole thing out a little bit.
So do you put any pentaverin?
No, I don't use anything. I don't use anything. So this is it. And I will just leave it like this. You can feel a nice bruise and thrill here as well as on the forearm. Now you appreciate how the thrill has improved. Put your finger here. After I dissected the adventitia, you see how the thrill has improved? It is very clear now. So if you haven't Doppler, you can get the Doppler. We'll close the skin here and then we'll show you how far the thrill is, the bruise is audible on Doppler. Skin closure. The skin closure I normally do it either with 30 or 40 ethylon single layer. Interrupted sutures.
30 ethylon.
Tooth forceps, small needle holder, 40 ethylon.
404.
Anything specific for dressing we need?
I will show the dressing also once we close. You can shift to the other side at the time of dressing. I will call you back.
Sure, sir. Kindly shift to OT2. Bivu sir, we are with you.
Yeah, we have just taken the polar stitch. I take continuous sutures. So we have taken the proximal suture first. Now I am getting inside the lumen and taking the posterior wall. The needle is just a moment. Quite stunning, this needle. Do you have another needle holder? This is not holding properly. Okay. Okay, now we are inside. Needle holder, I want a little better needle holder. This is not holding properly. I think got knotted somewhere. No, it got knotted. I would forceps, give me another forceps, microforceps. Microforceps. Yes. This is getting locked here. I don't know when it got. Okay, needle holder. Better needle holder. Yeah. This is a better one, no? Yes, now it's better. Now all here, we are inside, so we'll go from inside and out. In, out, out, in. Okay. Give me gauze piece here. I'll just, no, it's getting locked there, no? So we'll put a gauze piece so that this remains protected. Saline shot gauze piece, please. It will not get locked there. Okay. What is the needle? We're out. So out, in. Little counter.
Sir, we are shifting to the OT1. We'll come back to that. Okay. Parag sir, where are you?
Yeah, okay, so the skin closure is done. I'm just applying, they've got a neosporin ointment here, so I'm just applying neosporin ointment, skin ointment on the sutures. Give me a small gauze. This is the dressing that I normally give. Okay, right. Scissors. Okay, just small and micropore.
Sure, you are going to show us a Doppler.
Yeah, after the dressing is done, I will show you the Doppler. We'll show it on the vein here. Do you have Doppler? Give me the Doppler. Yeah. Doppler. चालू करो. Okay. चालू करो. इधर ही है. इधर. अच्छा ओके. बहुत आवाज आ रहा है इसमें. दूसरा डॉपलर लेके आना वो. बाकी का आवाज ही ज्यादा आ रहा है फिस्टुला से. Hello, can you hear this?
Not appreciable, sir.
No, keep it. मेरे माइक के यहाँ रखो तो आएगा. See, I'm just removing these gauze. The maximum bruit will be at the level of anastomosis.
Yes, sir. Now it's appreciable.
As you go proximal, it's going to reduce. Can you hear?
Yes, sir. Yes.
Can you hear this?
Yes, sir.
We are almost about 1.5 inch away from the anastomosis. Okay?
Yeah.
Almost 2 inches away from the anastomosis, more than 2 inches, 3 inches away from the anastomosis. So we have almost reached to the, this is the cubital fossa here. Let's see how much. See here also you can hear that.
Yeah. Yes, sir.
Okay. Thank you.
Sir, what is the post-op advice you give, sir?
Post-op advice is avoid any pressure on the hand. Okay, some people have a habit of, sleeping. No, the smaller one. Some people have a habit of, taking their hand below their head while sleeping.
Yes, sir.
So you have to specifically tell them not to do that. Avoid any outside pressure on the hand. And if this is a well done fistula, no leakage or anything. Patient's BP is also 160 by 157 by 77. So by evening, if everything is okay, I will start handball exercises from evening itself.
Okay. And when you call back the patient, sir?
Normally I call back the patient the next day if we are doing it on OPD basis.
Okay.
Just to check bruit and thrill, because if at all thrombosis, early thrombosis happen, it's going to happen in first 24 hours. So this is the only dressing that I give. I don't give any compressive dressings at all. And patient can start with handball exercises immediately.
So sometimes it has happened that the next day we are getting a good pulsation, but we are not getting a thrill.
Okay.
So what has to be done in that cases?
If on operation table there is good bruit and thrill, you have assessed your veins properly, there is no proximal outlet obstruction that you are pretty sure about, you can wait, because sometimes the bruit and thrill will improve over a period of next 1 or 2 days also.
Okay.
Sometimes it does happen that you don't get thrill immediately on operation table, you get only bruit.
Yes, sir.
So either bruit or thrill has to be there before you take the patient out of OT. That's the rule.
And we have to tell whether we have to tell the patient to maintain that BP on the higher side, or sometimes they do the dialysis next day or 2 days back after.
So that is why I said if you do the dialysis pre-operatively, either within 24 hours of your AV fistula surgery, the patient may not require dialysis immediately post-op. And in case patient requires the post-op immediate dialysis, then obviously it has to be heparin 3.
And the BP has to be maintained.
Yeah, and BP has to be maintained.
Yes, sir.
Yeah. See, most of these hypotensive episodes are during the dialysis when the patient is on dialysis. So that is what you have to avoid.
And these patients also take at least three antihypertensives.
Yeah. So sometimes they are on multiple antihypertensives. Yes, 2 or 3 drugs are there. So maybe you can consult if you think sometimes if you think that the radial artery size, the vein size is not very good, and you are in question whether this is likely to get thrombus, you can ask the nephrologist, talk with the nephrologist, and he can cut down on one group of antihypertensives. So if he is on 3 antihypertensives, you can just give 2. Let the BP slightly be on higher side at least for first 24 to 48 hours. Once the flow gets established across the anastomosis, intima recovers, intima heals, then there are less chances that there will be a clot at the anastomotic site.
Okay. And you prescribe any antibiotics, sir, post-op?
Most of these patients are already on IV antibiotics when they are referred to us, if they are in ICU and all. So you don't need to add anything else.
But this is daycare procedure, outdoor?
Daycare procedure, 3 days oral augmentin or amoxicillin.
Okay, sir.
No painkillers, huh? Okay.
Yeah.
Can I sign off?
Yeah. Sir? Thank you very much, sir.
So one question, sir.
Thank you.
Sir, excuse me.
Parag,
yes.
sir.
Parag, sir.
Yes.
Sir, within 48 hours, if the fistula doesn't work or thrill doesn't appear, do you re-explore?
Yes, so there are multiple reasons why it can happen, why you don't get fistula and bruit on table. In the complications talk, I'm going to talk about it. You have to first, there could be a technical problem. You have maybe taken a single stitch including the posterior wall. You have not cleared the adventitia well, or there is a fibrous band which is crossing across the vein. So all these things need to be looked at. But because or you have not assessed the patient preoperatively properly, there is already an outflow obstruction. The vein is not distensible, it is a thrombosed vein. So these are all the reasons. If you have assessed the patient properly, there is no reason why bruit and thrill should not come on operation table. Bruit and or thrill, I am saying.
Sir, if the thrill comes, but after 48 hours, maybe if
then there is likely to be early thrombosis at the anastomotic site.
So that
So you
needs to
need
be
to get a
explored.
Doppler done. Get a Doppler done then.
Okay.
If there was good bruit and thrill and the patient comes back after 48 hours with no bruit and thrill, most likely it is anastomotic clot and you need to explore.
Sir, thank you, sir.
Thank you, sir.
Okay. Thank you.
Can we go to the next OT?
Pardon?
When can we do or do we get a
Yeah, Bivu sir, we are with you.
Yeah. So you can see we have finished the anastomosis.
Yes, sir.
And this is pulsating, and we can also. Yeah, we are able to feel the thrill now. So this is, I have taken continuous suture. First started with one polar stitch. Then after I completed the posterior layer, I did a locking stitch with the same one and then completed the anterior layer. So the vein is nice and engulfed. The only demerit this fistula has is there is a valve nearby. But because it's in the favorable direction, so there will be no problem with the fistula. Four. Three is okay. So because there is a valve, I can do some more adventectomy to make the valve incompetent. Microseizure.
So do we need to maintain some angle between this vein and the artery?
Yes. Angle has to be around 30 to 45 degree. So it should not be 90 degree because the favorable angle is 30 to 45 degree. Adventectomy in the vein just close to the anastomosis helps dilate the vein at the same time, no spasm.
Sir, you do routinely adventectomy in all the reconstructive procedures
Because there's
also?
a valve here, I'm doing a little more extensive adventectomy. If there is no valve, maybe I'll just do a short segment adventectomy.
Okay, sir.
Okay, start there. Here, stitch there, skin stitch, loop.
Sir, what is the post-op protocol, sir? Sir, any antibiotics or?
With 4O nylon, no circumferential dressing, just dressing on the side of the suture with whatever ointment is available. I normally prefer Neosporin eye ointment. And the patient has to be told not to keep the arm under his head while sleeping because many patients have the habit of sleeping with their left hand under the head. So that's one. And the hand should be elevated. Give a sling to keep it elevated.
And physiotherapy, sir?
Normally I admit the patient for 1 day because many patients, some of the patients, they go 2-3 hours later, they will have some bleeding. Some patients even have bleeding which is troubling them, so they have to come back. So my protocol is to keep them for 1 day after the fistula, ensure that everything is fine and then discharge the patient. Even though it can be done as a day care, but I prefer to keep them hospitalized for 1 day.
they marluch. Sir, they leave it now.
So do you give any antibiotics, sir, post-op?
Antibiotics, I normally give oral antibiotics, cefixime or cefuroxime.
Okay, sir.
And painkiller SOS, normally it's Ultracet. I don't, or paracetamol only.
Yes, sir.
And most importantly, heparin-free dialysis for at least 1 or 2 sittings after the fistula. Heparin-free dialysis. That's what I always follow.
Okay, sir. And physiotherapy, sir, from the evening of surgery?
Which one?
Physiotherapy, softball physiotherapy, when we will advise?
Physiotherapy, I do only after stitch removal, 2 to 3 days after stitch removal. I don't do it before the stitch is removed. And first 1 week I don't do because I feel that the anastomosis is not completely healed. There can be bleeding, patient can have hematoma. So I prefer it about 7 days or 10 days after the fistula.
Is it required, sir? Is it help? Do it helps?
See how much it helps, I don't know. But we normally ask for exercise only after 7 to 10 days.
Okay, sir.
It will help because what happens when you do the exercise, the palmar arch. So whenever you are holding a ball and pressing it, the palmar arch gets pressed and the blood gets pumped into the system. So that definitely increases the load on the fistula. So that will help in maturation. Theoretically, yes. Practically, how much it helps, I don't know.
Okay, sir.
So, subtle differences that I had with Dr. Parag is his incision was a little different. My incision was longitudinal, placed in between the artery and vein. Second is, in predation I use Sensaken because I feel that patient will have analgesia for a longer time. And vein, I always use papaverine over the vein because when you handle the vein, it goes into spasm. So I dissect the vein first, put papaverine, let the vein dilate, and even the adventitia becomes sticky and it's easier to do adventectomy. And then we do the venous, we cut the vein.
Okay, sir. Yeah, he is not using any papaverine or anything, sir.
No, he didn't use, but I normally, I routinely use papaverine.
Yes.
See, ultimately it's a high pressure system, and even if the vein has gone into spasm, you can dilate it, and once the blood goes into the system, it dilates. But on table, before you start the anastomosis, if you have a nice and dilated vein, you feel more comfortable doing the anastomosis.
Yes, sir. We have seen that.
Okay. So you have the Doppler, huh? Huh? It's on, Nachi? It's on? Sterile, no? Jelly, give jelly. So is the jelly? Huh? Entire thing is jelly? Yeah.
Can we put the mic near the Doppler?
No, I've not got the signal. I'll just see what has happened. Huh? Which one?
Cover. This cover. Huh? Yeah, you can. I think there is some problem with the Doppler. I'll just show it. Very good feel I can feel. Just you put your hand like this. Okay. Just Can you hear now? Can you hear the hello?
Yes, sir. Yes. Good.
Okay. So clean it, spirit. Just ointment and little dressing only, not the full circumference. Thank you. I had a little problem with that needle holder. That was not holding, or maybe I.
While we proceed with the OT cases demonstration, lunch is available in the hall opposite to the mini auditorium. Many can proceed. The OT demonstrations will continue as per schedule. Patient is shifting, then once you...
So our routine bulldog clamps might not work. So what we need is Satinsky clamp or some special clamps. Okay. If those clamps also don't work, then we have to do it holding the loops, venous loops. We put the clamp, we put the loops, and then we do the arteriotomy so that the bleeding can be controlled. Okay. Another problem is while putting the sutures, usually we go outside in the artery. Usually how do we go? Outside in the artery. But here we'll need to take all the sutures reverse, inside out on the artery. Okay? Got it?
How does it work? How does it help? Because when you take it here,
No. It will not. The thing is that it is calcified. It will hold the calcified layers with the vessel wall, with the arterial wall. If we are going outside in, the calcified plaques would go in the vessel. If we are coming inside out, they would stick to the vessel wall.
The pliability of the wall is very...
They are very rigid. Yes.
So when you take a suture,
No, I prefer to do continuous, and it won't cut through. It won't cut through. In the calcified vessels, another problem is even our needle puncture holes, they also bleed a bit, but they stop after some time. Okay. One very important thing is size of incision. So there are some doctors who take very small incision. There are papers also on that. 6 mm incision, 1 centimeter incision. But taking a small incision, it is very difficult to take care of the tributaries. It is very difficult to ligate the extra tributaries. Okay. So that is why we prefer to have at least 2 centimeter incision. 2 centimeter, 3 centimeter, and if the vessel is calcified or if there are too many tributaries, we'll take a larger incision. In first case, Parag sir showed it very well that many times there is a dorsal branch which is going from the wrist. So I sometimes take a separate incision for that. I'll take a longitudinal incision near the wrist for the anastomosis. If the vein cannot be visualized through the same incision, I'll take a separate small 1 centimeter, 1.5 centimeter incision near the dorsal branch. Okay? You are understanding what I am telling. For the dorsal branch, we can take a separate incision. But it is important to ligate that. Rule of 6 was mentioned in detail. So, another important thing is day of dialysis. So, usually we operate next day. Like if the patient is taking dialysis on Monday, Wednesday, Friday, we'll operate on Tuesday, Thursday or Saturday. But if patient is hemodynamically unstable, first and foremost, AV fistula is not an emergency surgery. AV fistula is not an emergency surgery. If I am very tired today, if I have too many cases today.
Hello?
Yeah, you can continue.
Hello. Am I audible?
Yes, sir. Yes, sir. You are audible, sir.
So I am explaining. See, in this patient, they have already done a.
Dr. Kirti, kindly remove the PIP, picture-in-picture configuration.
Picture-in-picture? I can't see any picture.
Yes, sir. Dr. Kirti? Yes, sir. Thank you. Yeah.
Okay, fine.
Thank you, sir.
Achha, wo niche ka picture-in-picture. Okay. So this patient already underwent a distal fistula. I don't know why, but they have done a fistula here. Can you see this scar? So I think they didn't proceed with fistula. They explored the ulnar artery. I don't know why they went for the ulnar side, because radial pulsations are also well felt here. But an attempt was made for the fistula here. They couldn't find any vein, so they've not gone ahead. So this is a case of failed fistula. all the veins in the distal, I think she's already told the diameter of the veins. They are about 1.3, cephalic vein diameters are 1.3, some 1.5, 1.6 here, and 1.3 again in the above the elbow. The basilic vein diameter at elbow is about 1.8. So we have decided to do a primary brachiobasilic transposition in this patient. So the markings are, hold this. You first mark the elbow crease so that you don't want the incision to go below your elbow crease. Then you feel for the pulsations of the brachial artery. So the brachial artery is here. Okay, now your basilic vein is going to come from the medial side. This is medial epicondyle. The basilic vein is going to come from here, and then it will probably join the median anti-brachial vein, and then join the cephalic vein on this side. So this is normally an H-type collection. Suppose the vein comes from here like this. This is what normal I am talking about. This is a cephalic vein, and you always have a connecting vein like this here. Okay, so this is where you are likely to find the junction of the basilic vein and the median cubital vein. So I am just doing surface markings of the basilic vein. Okay. So now my incision, I'll try and don't try and take a separate incision for brachial artery exploration. So here in this area, first we'll take an incision, longitudinal incision like this, to explore the vein, basilic vein. Now if you divide it into 3 halves, suppose say from axilla to elbow you divide it in 3 halves, the upper 2/3. So beyond this, this will be all subfacial part of the basilic vein. This will be suprafacial part of the basilic vein. So we explore first, once we identify the basilic here, then you extend your incision as you want. They have already given a supraclavicular block, and give me a forceps. उनको पूछो ये समझ रहा है आपको ये समझ रहा है ये okay. So now typical after either axillary or supraclavicular, there is likely possibility that the median the antibrachial part is spared. So here we might have to give some local anesthesia. So can I have some local? So they have marked the zone where she is not got anesthesia. So just I am going to infiltrate in subcutaneous plane. Again 2% plain xylocaine. एक सुई लगेगा? हाँ एक सुई लगेगा. थोड़ा इंजेक्शन दे रहे. थोड़ा दर्द होगा.
ठीक है ठीक है बस.
Bus. Okay, so we start with exploration here. Knife, please. Marker. So idea is to take this exploratory incision. Then as you find the vein, explore it. You can extend the incision towards the axilla as you want in whichever. And to expose this artery from here, once we get the vein, I can slightly curve my incision on this side like this, so that I'll be able to open the artery also here for the anastomosis. You don't have to take separate incision here, but everything has to stay above the elbow crease. दर्द हो रहा है?
No.
Okay. Scissor.
मैं देख रहा हूँ, मिलेगा? No, the vein is going to be small only here. Plain first. Let me find the vein first. Yeah. Gila? So can you appreciate the vein? This is the cutaneous now. Can you appreciate the vein? I don't think I am audible down.
Yes, sir.
So that's the basilic vein.
Yes, sir. Yeah.
Okay, I'll just separate the nerve. Chodo. Hold it. I will show you the and anteriorly now, yeah. So this is the bifurcation. Is I don't know. This is at the lower end. Is it visible? I'll lift it up and then show again. Okay.
Yes, sir. It is visible.
Yeah. Okay. See now. Give me a forceps. Yeah. Okay. This is your basilic vein which is coming, and this is the vein which is communicating with your cephalic system.
Okay.
The cubital, median cubital. Okay.
Yes, sir.
Okay. And they join to form the basilic vein.
Right.
Okay. So once we have the basilic vein exposed, we know the location of the basilic vein, and then we just go on exploring higher up. So it is like you see the course of the nerve and then extend the incision slowly. Cautery. Better to do use cautery.
Sir, may I shift to the other OT?
Knife.
Sir, may we shift to the other OT? They want to speak about something.
They are doing a brachiocephalic fistula there.
Yes, sir.
End to side brachiocephalic. I asked them to shift to other city. Can you shift to other theater?
Yes, sir. Yes, sir. Hello, Dr. Surya. Are we audible?
Good afternoon, everybody. Can you hear me? I'm talking from OT2.
Yes, you are audible.
Yeah. So we are going to have the second case. We are going to start the second case. This is a 52-year-old gentleman with 2 months duration of stage 5 chronic kidney disease. Has been on hemodialysis for the past month. Diabetic and hypertensive on regular medication. So he has brachial, radial, and ulnar good pulsations with normal Allen's test. Good visible veins are noted. However, we had noted that cephalic vein in the mid forearm region is thrombosed. So the plan for this case is proximal radiocephalic fistula, and we are going to perform it under supraclavicular block under tourniquet control.
Okay.
Can you see our screen in note 2?
Yes, your screen is visible.
Okay. So welcome to OT2. So here you can see that the cephalic vein distally is dilated. But what happens is in the mid forearm, in this area there is a thrombus. So the vein is not, and it corresponds to the ultrasound finding. Plan is to do a proximal because forearm the vein is good. So we are planning to do a proximal radiocephalic fistula, end to side. And this patient is under brachial block and under tourniquet control. So we are planning this side, the proximal junction of the proximal third and middle third, where we will be doing the fistula. Monopolar. Tooth forceps. There's a skin up there also.
Good afternoon, sir. Vibhuti, sir. You use monopolar cautery Colorado tip, sir, for dissection?
Yeah, for cutting the skin and the dermis, I use monopolar. Because the edge normally bleeds. And this patient is on tourniquet. Later on it will bleed.
Okay. Thank you, sir.
A longer tenotomy for sir. So you can see this vein, but this is the vein which we are not doing. This vein, you can see looks fibrosed and whitish. So this is thrombosed. Give me lump, yes. Tenotomy. Not there now. Okay. Okay, so it will be difficult to do with this. This is what we have planned now. This one. You have so give me the skin or cat spa. Okay. Papavirin. Papavirin. Okay. So immediately it has gone into spasm. Therefore, I always prefer to put papavirin before we. So we have chosen from which side? Just see. Yeah. Okay, we are corresponding. So that was our plan.
Vibhuti, sir.
Yes.
Any. This is Dr. Kumail, sir. Sir,
Yeah.
any effect of AC, theater temperature on the vessels?
Yes. If the temperature is low, the vessels can go into spasm. So temperature should be ambient temperature. For microvascular, always the temperature should be optimum around room temperature 22, 24 is what you should want. Chilling will have deleterious effect, especially vessel spasm. There are cases where there will be no bleeding from the vessel just because the AC is chilled. So for microvascular surgeon, it's better to do it at about 20 to 24 degrees. Chilling, too much of chilling is not recommended. Microforceps.
Sir, for irrigation also you use heparinized saline?
No, I don't
Normal
use.
saline. Okay.
No.
So do you use Liga clips?
Liga clips, yes. Liga clip, give me Liga clip 100. So this is the major vein. There's a branch here. So if we ligate this branch only, otherwise then the blood will get diverted there. So this Liga clip 200. So this is the segment of the vein that we have dissected. This is joining the cephalic in the proximal forearm. Microcissure. Like keep 100. A little microforceps.
Sir, can you ask to please zoom out a bit?
Zoom out.
And keep it stable, zoom out.
So now you can see back bleed from this vein.
Yes, sir.
You can clearly see back bleed from this vein.
Yes, sir.
Plus. Here. Okay. You can see bleeding from this vein?
Yes, sir.
Okay. So now, in the first case, we were asking the angulation. Angulation should be about 30 degree to 45 degree. Now leave that. Single clamp. Leave it now. Leave it now. Yes. Single clamp. So if you want to dilate this vein, I can dilate it just by inflating saline there. So if wash it. Papaviri should not go into the lumen. Wash it properly. Vessel dilator.
Sir, what will happen if papaverine goes into the lumen? Sorry.
It damages the intima. So papaverine is just for external, outside the vessel, not into the vessel.
Okay, thank you, sir.
It will thrombose if the papaverine goes inside. So what we are doing is just
Sir,
distending
please
the
ask
vein
to zoom out.
It going inside. Now you can see. So now it's distended. Okay, fine.
But this was heparinized saline.
Is looking better now. This vein is looking better. We can use this vein. No. No, what has happened here? Now, this was looking white. But anyway, that vein is clinically better, so we'll use that. Dolphin?
Sir, you dilated the vein with heparinized saline?
No, I prepared it for N2-side anastomosis.
Yes, but you dilated with the heparinized saline solution, sir?
Yes. Descended with heparinized saline.
5,000 units, how much you put in 100 cc, sir?
100 ml, 1 cc. So that becomes 1 in 5 lakhs.
Okay, thank you, sir.
I think this vein is not looking all that bad. So proximally it's not thrombosed, no? This, only this area is till mid forearm. But here it's looking okay. It's looking nice and dilated, no? Better than the other vein. Yes or no? So we'll cut and see the back bleed. If it's there, we'll use this vein only. Okay. $100 like Didi. One more. Achha, okay. I'll cut here and see if it bleeds. That will be another indication that it's bleeding very well. Back flow is there. So we can use this. Okay. Single clamp. Yes, like a clip. So this vein is bleeding well, so we can use this, huh? Like a clip. Hmm. Okay. Hmm? Not now. Give me tenotomy scissors. We'll go to the radial artery now.
Sir, can we shift to Parag sir's theatre for some time?
Which one?
Can we shift to other theatre for some time?
Yeah. Now, right there is the radial artery.
Yeah. So we've dissected the basilic vein almost. Now there are too many branches here, so we'll see whether we need to ligate this or this is good enough. Can you see the basilic vein now nicely?
Yes, sir.
Bipolar. Bipolar is ortho, no?
And you see the nerves that we talked about. See, it is bifurcating between the branches. So unless you cut the nerve, cut the vein here and deliver it out of the branches of the medial cutaneous nerve arm as well as forearm, it is not going to get transposed anteriorly.
We'll take advantage of the entire.
Sir, how far proximally we should go, sir?
Up to the axilla as far as possible. Because see, finally you want about 8 to 10 centimeter long length of the vein available to be pricked to the dialysis technician. So as much as mobilization and plus, this is a straight segment here. When the vein is, leave this, when the vein is going to be transposed, the vein is going to come from here like this, and then we are going to do anastomosis in the brachial artery. So there is additional loss of length here. So go as proximal as possible.
Because it's a microforcep.
So you almost freed the vein all along the thing. So what we will do is now we will divide the nerve. Now before we divide the nerve, leave that. Give me a wet gauze. We will extend our incision down to identify the brachial artery as well. So I'm just keeping a hyperonized gauze here.
How many singles clamps you have? 3 or 2?
Knife, please.
Single, how many? 2 to 4. Very good. Then I don't need double.
Caesar.
Give me one more. Is it now? So now we have to decide. We have chosen this vein. But I think this vein.
So that is your median cubital vein. Can you see this?
Yes, sir.
So the fistula that we do, what I said, this side to side proximal fistula is this antecubital with the brachial artery. We'll show that also, but that is all done under local anesthesia.
Okay, sir.
Sir, can we shift to theatre, sir? Parag, sir?
Yeah, you can, of course.
Yes, sir. Yes, sir.
Yes.
The middle third forearm. The cephalic vein here looks good. This is the cephalic vein.
It can. No, side by side play.
So like keep 200. Micro seizure. Release the tunicate. Let's see how is the. Release the tunicate. So because the patient is on tunicate, before we start the anastomosis, I am releasing the tunicate because whatever bleeding is there, we will control now.
Vibhuti, sir. Sir, do you use tourniquet in all the cases?
Most of the time I use tunicate. I do under block. I give the block myself. Plus.
Okay. Okay.
So we have actually two veins. You can see this when tunicate is released. Huh? Let us see the pulsation. What is the pulsation? Was able to see? Okay. But the venous return is not that good. Considering the other vein, I think there is some block somewhere. I think so, because see, there is no back bleed and there is resistance. So we have chosen the right vein. This is not the vein to be used. So this is what we chose, and here we had clear just there's good bleeding, no?
Sir, what is your threshold for vein in terms of diameter in mm?
Diameter?
Yes, sir. Would you like 2 mm?
It should be at least 2 millimeter.
Okay, sir. Thank you.
When we started off, this was bleeding. Is there a clamp there?
Sure, sure.
I think we have a clamp there. Huh?
Hello?
Yes, sir. Yes, sir.
Yeah, okay. So the dissection is done. Can you have micro instruments here also? This dissection is done. I'll just explain you. So this is our vein. These are the nerves. Here the brachial artery. This is the median nerve here.
Yes.
And this is the brachial artery which I have dissected.
Yes.
See this. Okay?
Okay, sir.
So the vein, leave this. Okay. So what we are going to do now, I put a clamp on the vein proximally. Okay, I am going to cut the vein here as low as possible, because as I said, it will be almost at the bifurcation.
Yes, sir.
So that maximum length we will get when the vein is transposed.
Yes, sir.
Okay, so give me a ligature, silk or something. I am putting a clamp distally on the vein. One more. Ligature, please. So now I'm going to tie this vein here, because we have to pull this vein out from here. But before that, once we have put the clips here, I will be cutting the vein as low as possible, because this lower part of the vein will finally be discarded, because there will be a suture there. We'll have to slightly go at higher level. So before that, I'll show you how we create a tunnel. Now give me a small Hagus. See, finally this vein will be divided here. This is the clamp here. From here, it is supposed to come like this to the brachial artery, which is already exposed. So we pull the brachial artery up. Hold this. Okay. Release that. Okay. So we know where we want the vein to come out. Can you see the brachial artery clearly now?
Yes, sir.
Okay. So bigger one. Yeah. So this, what is this size? 53. It's written Q. Yeah, it has 3 size. So this is. There are 2 ways of doing it now. You can either raise this flap anteriorly right up to here, and then, as I showed in that picture, you cut the fascia and put the vein under above the fascia and suture the fascia underneath it. The other option is to create a tunnel. So don't do too much of dissection. Again, risk of seroma, hematoma complications go up. So now I am going to go. If you see here, I am just going to go subcutaneously. Can you see this?
Yes, sir.
I am absolutely subcutaneous now. So I am creating a tunnel. And it has to come out here where the clamp is.
Yes, sir. We are able to delineate there.
So I have come out here in the subcutaneous plane. Can you see?
Yes, sir.
Now the same tunnel we will dilate. Give another one. Bigger size. Pull it out from above. Slowly. Wait. Yeah, go. Yeah. Okay, go. Take out. Take out. So bigger diameter now. What is this size? What you have given me? 6 now. That should be good enough for us, I think. This is in the subcutaneous plane we are.
Okay, sir.
This is how the vein will be anterior. This is how the vein will come eventually. So 6 is good enough for us. So we keep it in place like this for some time. Now I am going to transect the vein. Give me an intracath. Removing this loop which is around the vein because we have to deliver the vein out. Give me a scissor that cuts. This is not cutting any. I am cutting it with this. Okay. Vessel dilator. So intracath. So what I will do, put a clamp, give me a clamp. Okay, so I am delivering this vein out of the branches of the, from underneath the branches of the nose. Here as well as proximally also. Okay, so eventually it's going to come from the tunnel like this. No, okay, now flush. Now the thing is here it is likely that the vein is going to twist. So while you are pulling it out from the tunnel, so what you do is infuse this hyperonized saline. Since you have put a proximal clamp, automatically all the twists and rotations will get corrected. Okay. Okay, we need to ligate it here. Stitch. Ligate. As low as possible. Low, low, low. As towards me as possible. And now give me your this thing, tender tunnel. Wait. Yeah, go down. Yes, tie. Yes. Yes. Yeah, बस हो गया करो tie. Just sort of 3 tie करो बस हो गया. Yeah. Okay. Lam. Yeah. Okay, so the vein is filled now.
Yes, sir.
I'm keeping it like that. There is a small branch here which we might have to ligate a little bit. I will clip those branches so that the tension on the nerve is or tension on the vein is reduced. Can I get a small clips? You pull the vein a little bit. One more.
Clip is on.
Clip नहीं. Straight सीधा. Straight. That cord is not cutting. One more branch. Okay, clip. The big branches here also. Yeah, give me clips. First 100. Oh, this is 200. Okay. Okay, one more. Here. One more. Small, yeah. So now we are good with the vein. This is how it will get transposed, and then we'll do an anastomosis here. So can I have a tendon tunneler? So I'm removing this now. We have a tunnel already prepared.
Yes.
Tunneler. नहीं मतलब tendon. This is not tendon tunneler. No. Ah, this is okay. This is too big, huh? Small, eh? ठीक है. Anyway, see, it's going very easily. Give the thread. Keep this leg up. Okay. This is a slightly bigger tendon tunneler, but we'll just try to pull it out. Let's see how it comes. I want a tooth forceps. Yeah, hold it like that. Here you have to slightly free the fascia a bit so that make the opening of the tunnel slightly bigger here, so that
Yes.
the vein easily enters. Hold this. Yeah. You can see this fascia. I'm just going to. Yeah, okay. See, now it goes easily. Oh, give me a smaller one. The thread has come off, so we'll have to put it again. Put some heparin saline. Fine है क्या? नहीं तो if you have a fine artery, long artery, curved artery, that will also do. पहुंचेगा क्या? नहीं जाएगा वो. Give me again. Give me that again. Let's try. You have a bigger Hegel dilator? Give me a bigger Hegel dilator. More than 6, because probably it is these branches which are causing. Yeah, that's okay.
No, it will come up here. Pull it out. Yeah. Scissors. Hold this. Just releasing the fascia a little bit more. Give me a forceps. Oh, this is not holding here. Okay, I'll give it one more try. Give it to me. The issue is नहीं उसमें पकड़ के पकड़ना पड़ेगा मेरे को. Okay, wait. What I will do is I want to feed the vein, but somebody has to hold it. Okay, hold this. Don't close. Hold this tight. Hold this tight. Don't leave it ready. Yeah, what I'm going to try is you gently pull, and I'm going to feed the vein in. Yeah, pull. Is it coming out? Pull. Yes, pull. Pull. Yes. So that's done. Okay, give me another clamp so that I can release this clamp. Can you see? It's in the tunnel now?
Yes, sir. We can see the silk.
No, vascular clamp. Clip. Yeah. Okay. So I'm just putting a proximal clip here so that I can release this clip and the vein doesn't get deflated. So that we can pull it further down. Okay. Yeah, leave it. So now our tunnel is done. The vein is in our hands. Give me a clamp. Putting a clamp here. Okay, leave everything now. Let's go to the anastomosis. So now you can see clearly that the vein is exactly dropping exactly where we wanted on the brachial artery. Can you appreciate that? The brachial artery is here. Pull the brachial artery up. Can you see this?
Yes, sir.
Yeah. So I want a clamp for brachial artery now. Brachial artery के लिए clamp से. Dissecting scissors. बड़े वाले पकड़ेंगे ना? I want a big bulldogs. Bulldog. Scissor, dissecting scissor. Just mobilizing the artery a little bit. And then we'll put bulldog clamps on the artery or C4 clamps. You have C4? Okay, this is not going to damage the artery, na? Okay, another one. This is okay, take. Okay, leave that. Don't leave this. Okay. So now we have vein which is completely filled with saline, as you can see here. So there are no chances that no likelihood that it will be turned or twisted. And then you now you have an excess length here. So I can shorten the vein. We are going to discard what we ligated here.
Yes.
Scissor. Vessel dilator. You have the caliber with you? छोटा है क्यों? We can measure the diameter of the vein if they have small caliper that we use in cleft patients. Hold this. Scale है क्या? I don't know. Yeah, scale might be better. Yeah, now you have to measure actually. I think you can measure it with the. See, it's about 5 mm. Can you appreciate? Hello. Hello. Mic is gone.
We are able to appreciate it, sir.
It's working.
Yes, sir.
Okay, so it's 5 mm, so I will make an arteriotomy of 5 mm.
Okay,
11
sir.
number.
Okay.
Here again you see where it is coming. Don't try and do it like this because again you will have 90 degree. So pull it as down as possible, so the arteriotomy has to be as low as possible. It has to be under tension because once you release the clamps, there is slight gain in the length here. Again same principle, the arteriotomy on this side. Don't go an arteriotomy here because the vein is coming from that side.
Sir, Vibhuti sir wants to show us something. Maybe shift to the other OT.
Yeah, you can shift there. This is the anastomosis left now. Okay.
Thank you, sir.
Thank you.
See here, we went for the proximal AV fistula radio cephalic. Actually, the segment of the vein that we had, there was no back bleed and there was some resistance. So we have done with the adjacent vein, which is very well connected with the cephalic system. We just completed the anastomosis end to side. So because the diameter is quite large, interrupted sutures are quite effective. They save time. So there is no need to take interrupted sutures.
Suture.
And
70
one not here, one not
double arm needle.
taking the opposite. That implies there will
तो
be
छोटा नीडल नहीं है कि 70 का व्हाइट कलर का जो नीडल आता है विजी ब्लैक एक आता है एक छोटा माइक्रो पॉइंट नीडल भी आता है व्हाइट कलर का नीडल रहता है डबल एंड 70.
So I have kept a segment of the cephalic vein here by just to show you that it is not that great even now after all.
नहीं, this needle is slightly larger.
Like it.
Every time you have to tell me.
200. 200. But see, the engrossment of that vein, are we feeling any thrill? Not yet. Skin up. Are you able to feel? Another skin hook here. Because it should be now the pulsation should be what is the blood pressure now? 160. That means see give me microprocessor. Say microcedure. You can see good.
Parag sir, we are with you. बोल देंगे Parag sir, can you hear us?
Can you hear me?
Yes, sir.
So this is the posterior wall that I have started. This is the brachial artery. There is the brachial artery, and this is our vein.
This is working really well.
नहीं ग्लोव से क्रैम्प आ रहा है, दूसरा ग्लोव दे दो. वो पहले वाला था वो बेटर था. 7 size, but this seems to be tighter.
Anyway, so flow is good, we will stop. Okay. You can go because this runoff is good. You're feeling, no? Okay, leave it. Just give me the marking, we'll just mark it. Marking is there, so we'll put a doppler at the end. Stitch.
माइक का बैटरी चेंज कर रहे हैं माइक का बैटरी चेंज कर रहे हो.
अच्छा हो गया माइक नॉट वर्किंग.
गुड यस सर.
Good person. Yes, this person is better. Even we did under 2D gate, still the bleeding was not much. The moment we took the incision, the bleeding was a little more. See, decision making.
Am I audible?
Important here.
No.
Yes, sir, you're audible.
Yeah, okay. So I finished the posterior wall now. So this suture stays here. Now I start with the other needle and we complete the anterior wall. This is better. That was tight. Started getting cramps. They can go to the other this thing if they want to, because with the completion of the anastomosis के बाद we'll show that.
Okay, sir.
Yes. Only one I wanted to. The first one. Now I will not. ठीक है, कर सकते हो follow. Sure. Yeah, proximal radiocephalic, there are specific indications. That is Grant's fistula, no, that you are talking about. So that also will show. It takes more time because dissection is a little bit tedious. The perforator is not very, it's very deep. And you have to go in the cubital fossa के नीचे just वो खड्डे में जाना पड़ता है where radial and ulnar artery bifurcate. It's here inside. Yes.
What is the difference between arteriotomy versus arterial punch box?
In arterial punch box, you remove a cuff of. Okay. Hello. Am I audible? Hello.
Yes, sir. You're audible, sir.
Yeah. So there was a question posed. What is the difference between arteriotomy and when you use it a punch to create an opening in the artery? So there you are actually excising a wall of the artery. It's very common with vascular surgeons. What they do is they normally don't take just an incision, and so they will remove a cuff of edge of the arteriotomy or wall of the artery so that the artery remains open. Now in atherosclerotic vessels, the artery will anyway remain open. It will not collapse because of atherosclerosis itself. But if you think that the artery and vein are collapsible, then it's not a bad idea to remove a small cuff of artery here.
Okay, sir.
The edge of the, after you do a arteriotomy, you can just remove some edge of the artery. Yeah, you can cut that. So I've completed the anastomosis. Longer. Okay, fine. So what we'll try and do now is first I'm going to release this clamp. Okay.
Okay, sir.
Then I'm releasing the proximal clamp. Just check that the vein is nicely mobile. Can you check? See this? When I'm pulling the vein, there is a traction on the vein here. I'll release some fascia here also. Yeah, okay. I release the distal arterial clamp now. Not much leak. And then I release the proximal clamp and we wait.
So there are a few more questions in the chat box.
Proximal radiocephalic fistula. This is the Doppler finding of that same.
Okay, hold this. Keep a pressure here. Give him a retractor.
Can you hear it?
Yes, sir. Yes, sir. We are able to appreciate,
this
sir.
is completion of
See,
the
hold
proximal
this. You can
radiocephalic
see the vein is dilated now.
Yes, sir.
Okay. Spirit, just spirit. Just give little ointment, small dressing, no circumferential dressing. Surya, just.
छोड़ो लूज छोड़ो छोड़ो लूज दूसरा वेसल क्लियर करने के लिए वास्कुलर लूप्स नहीं माइक्रो इंस्ट्रूमेंट चाहिए वेयर इज दिस आई मिस द पैड पैड करो प्रेस ओके ज्वेलर्स या रिट्रैक्ट okay so that means it's flowing nicely, don't need to do anything.
Yes, sir.
There's some advantage here which I'll clear. Leave that. Now we'll see the anastomosis. If there is any leak here, flush. Leave it. Hold it like that. Yeah, hold it like that. Okay. So can you see the vein nicely dilated now?
Yes, sir. We can appreciate it.
You can feel the thrill here. Okay, leave it now. Yeah, okay. Let's see if we can get a thrill here at the upper end. Yes, you can. You can probably appreciate the pulsation at the upper end. Let's see. Can you appreciate the pulsations of the vein here? Can you appreciate the pulsations?
Yes, sir.
I am not connected to audio, I think.
We're not able to see, sir. It was not focused. Can we see it again, sir?
Can you see the pulsations here? We are at the axilla now.
Yes, sir. Yes, sir. We're able to appreciate.
Yeah, okay. So that means there is no kink, no rotation, nothing. And now I will show you how the vein becomes prominent. Leave that. Okay. See, you can already see a dilated vein on the top. I don't know whether
Yes,
you can
sir.
appreciate the angle.
We can see it, sir. Yes.
Yeah, okay. So then after closure, this is the vein that you will get all along the length, and you see, check the length of the vein. We have seen. So it's almost good 12 centimeter vein that they can prick.
Yes, sir.
And this is just immediately on operation table. Over a period of time, it's going to dilate further. Yeah, okay. So we are just going to close this incision now.
Okay, sir.
Vicryl 30. No continuous tight sutures, just interrupted vicryl and again interrupted 40 or 30. करेगा ना close? Yeah, ठीक है. Sure. All interrupted sutures, huh? Thank you.
Thank you, sir.
Thank you. निकालना है ना?
हाथ चला में होगा, ठीक है? फटाक से इसको उठा के दूसरा घुसा देना, बहुत ब्लॉक देने के लिए आप क्या है?
You are still doing the same stuff. Sir, actually थोड़ा ओवरलैप हो गया है सर सर मॉर्निंग का वॉइस रिलीज क्वेश्चन बोल रहे हैं like there's one more we had told we can consider to move on for the anti-tuberculosis.
देखता हूँ और क्या ऑफिसर्स करेंगे
Hello, yes,
Zoom भी चलेगा, ये भी चलेगा।
किंतु ये वाला वीडियो नहीं देख सकते।
कोई बात नहीं, इधर का वीडियो देखने से
ब्लूटूथ ताकर कौन ठीक।
कनेक्ट नहीं है, ये कर दो, ट्रांसफर कर दो।
सर मैं डेस्कटॉप पर कर दूँ
इसके फोल्डर को
पराग सर, डॉक्टर पराग सर,
व्हाट्सएप फोल्डर में
खाली এটা হটস্পট কনেক্ট করে দেবে, জুমটা ওপেন করে দেবে, ওপেন করে দেবে, স্ক্রিন শেয়ার তো করা হবে না।
जॉब पड़ेगा
गेम भी पढ़ा होगा, तो गेम भी पढ़ा होगा तो पढ़ने दोनों
Hello, this is from OT1. Can you hear us?
Yes, we can hear you.
Yeah, okay, I'm Dr. Parag here. So some questions were there, so.
Yes, sir.
when do we, hello, yes sir.
Yeah.
Sir, after how many days, like do you use a splint after giving this transposition? Do you use any splint across the elbow?
No splint. No splint at all.
Okay. When is the suture removal, sir? After 2 weeks?
Yeah, suture removal after alternate sutures initially, and then later on after 4-5 days later complete suture removal.
Okay. Sir, any specific advice regarding movement of the elbow?
It shouldn't matter because see, that's why the first thing that we marked was the elbow crease.
Yes.
So your anastomosis is all about the elbow joint. So it doesn't matter even if the patient flexes elbow.
Okay. Sir, do you suggest any exercise for the patient?
Normally, I don't suggest any exercises.
Okay. Thank you, sir. Sir, do you give any post or like antibiotic you give for 5 days or more?
In such case, brachiobasilic transposition, it's a long incision, so I will give at least for 3 days, oral antibiotics for 3 days.
Okay, thank you.
Thank you so much, sir. While we prepare for the next OTs, we will move on to the academic presentations in the mini auditorium.
संदीप यहाँ पे तो नहीं आएगा, जूम पे आ जाएगा, जूम चेक जूम पे आ रहा है। एठी आसला एसडी में आने पड़ेगा। नहीं ये वाला यहाँ जूम पे यही दिख रहा है क्या? एक सेकंड, जूम पे भी यही दिख रहा है क्या? ये वाला ही दिखा रहा है, जूम में नहीं अभी दिखा रहा है। हाँ अभी मैं तो वही अभी यहाँ पे नहीं चाहिए। ये वाला हो रहा है, वो वाला लाइव ओटी ऑफ करना पड़ेगा। हाँ वही चीज़, हाँ मैं तो आप दोनों चीज़ लगे
Getting, but ultimately it is used for CKD patients. So there are few things which, what are the nephrologist perspective? Let us discuss for 5-10 minutes. Once again, I thanks Giri sir and his entire team for organizing such conference and inviting. Thank you, sir. And so we'll start with a case. A 40-year-old gentleman, a banker by profession, diabetic for 12 years, hypertensive for 7 years, having diabetic retinopathy, diagnosed to have CKD for almost 1 or 2 years now. Current creatinine is 5, with hemoglobin 9, proteinuria around 2 gram, and fairly controlled blood pressure and blood sugar. He came to nephrology clinic with the problem of increasing pedal edema, loss of appetite, and weakness. With all these complaints, he came for further advice and management. So, what would be the right approach? So, what did we tell? We'll tell medical management and just follow up, or we'll talk about RRT educations. RRT, when I tell RRT, that means dialysis, hemodialysis, peritoneal dialysis, and renal transplant, everything. Then RRT education, plan for creating of AV fistula at the earliest, or RRT education and plan for early renal transplant. So among these, what it can be? So the preferable answer will be third one, RRT education, then plan for creation of AV fistula at the earliest. So such patients, they come regularly to us. We know that if they are diagnosed to have CKD and they are already heading towards end-stage renal disease, so always it is better to plan it early, fistula creation. One more case, so it is not for all patients. So fistula, and so there are 3 types. We are going to discuss what are the various AV accesses and what to offer, what type of access to offer, which group of patients or which type of patients. So then second case, one more case is 55-year-old lady, known long-standing diabetic, hypertensive, ISD, post-CABG, underwent bypass surgery, diagnosed to have metastatic breast cancer, underwent surgery, then radiotherapy, chemotherapy, everything. Now, she was, and she had multiple admissions recently with multiple infections like pneumonia, UTI, etc. Diagnosed to have renal dysfunction 3 months back itself. It was found to have, she was found to have 3.5 creatinine. Now in this admission, again admitted with some infection LRTI, the creatinine is 8, fluid overload, vomiting, urine output dropped, and what to do? You get a call from radiation oncology or medical oncology, kindly see the patient, what to do. Medical management, RRT education, create AV fistula, or RRT education, start dialysis by a tunneled central venous catheter. RRT education, start dialysis by a temporary catheter, plan for fistula. The last one is RRT education, plan for early transplant. So what do you think, what will be the best answer here? So it would be RRT education start dialysis by tunneled catheter. Here we don't talk about create transplant. We don't talk about creating a fistula, because we know that this is a patient with multiple comorbidities, metastatic cancer. The life survival is not prolonged. It is hardly 1 or 2 years that can be managed by a tunnel catheter. So depending on the patient profile, we have to choose a catheter. Now, what do this box, can we remove this one, please? And so vascular access in hemodialysis. So what do you mean by that? Vascular access in dialysis is often known as lifeline of the CKD patients. That's okay. That's fine. Thank you. So it is a surgically created or some intervention. By doing some intervention, it's a dedicated site, either a fistula or a graft or a catheter, which allows blood to be removed, cleaned by a dialysis machine, and again return to blood. Blood comes out, undergo cleaning, dialysis, and returns back. So that access we need to give. That is AV access, vascular access. There are 3 major type of accesses we all know: AV fistula, AV graft, autologous AV graft, then central venous catheter. So out of these 3, we all are aware of. Now this workshop and everything is about AV fistula. We'll be talking about fistula. We know that this is the best AV access, the best and desirable access for all type of CKD patient, for chronic long-term dialysis, not for short-term dialysis. And when I tell, when we by central venous catheter, we mean it can be temporary, it can be tunnel. So the perm catheter is a misnomer. There is nothing called permanent catheter. It is always temporary. The perm catheter is actually a company which first came up with a tunnel catheter. That's why the name is perm catheter we are telling. So that is a tunnel catheter. So there is a subcutaneous. Just now we saw Parag making a big tunnel. Similar type of, not that big. Similar type of tunnel was made, and there is a cuff. It is also known as cuffed catheter. So there is a cuff. So it can be kept for a long time. Almost the guidelines tell 1 year. So we have patients with 3 year, 4 year on this catheter, and the infection is less, and the chance of infection is less, and we can keep it for a long time. That's the only difference. And patient mobility and comfortability is also better because it's not in the neck, it hangs in the chest. Otherwise, temporary catheter we all know, like central line, it is little bit larger, 12-13 French. The normal central line which we use for giving medications and IV fluids, it is 6 or 7 French. So this is around 11-12 French, depending on the age and body habitus. For adults, it is 11 to 12 French, the gauge, the diameter. And graft also is one more thing where fistula is not possible, difficult. Graft is the second best option. So in chronologically, the best option is fistula, then graft, then central venous catheter. This is all about chronic patients, those who require dialysis. So what is a AV fistula? So AV fistula is a connection, deliberate connection. It is done connection between a native artery and vein, and typically constructed to an end to side, end to and vein to artery anastomosis. It can be side to end also, different type. This is just a definition. It is not just an anastomosis. We have to remember that when we tell our students, or everybody should remember, the fistula starts from heart and ends at heart. So the line, everything should be clear. From heart to fistula to heart, the line should be very clear. Any problem anywhere is not going to work. We can make fistulas, it is not going to solve the purpose. So that is to be very clear. So whenever we ask for vascular mapping, we tell them not only hand, please check. I think Ranjan is here or he left. So whenever we tell that AV fistula, they have to check it, the whole limb, including the central veins of the same side at least. Ideally, it should be done for both the limbs and both the central vessels. So when AV fistula mapping or now Ranjan has come, I want to tell you, you should inform your residents and your department whenever they get somebody comes for AV fistula mapping. It should be done in not only in the limb, for the central veins also. So the fistula starts from heart and ends in heart. So from here to here, everything should be clean. So if you do it and particularly those patients who had previous history of cannulation. We will tell that every patient won't need mapping, which are the patient we'll discuss. So AV anastomosis, then there is the inflow and outflow. You all know that inflow, outflow, blood comes and goes, inflow, outflow, monocular artery and vein, we tell that, or upstream, downstream, we tell that. So via artery it comes and again via vein it goes away. So inflow and outflow. So everything, heart, inflow, outflow, fistula, if everything is fine, then only fistula works well. So what are the advantages and disadvantages? So we already know that it is the best form of AV access. It is infection risk is less, low risk of thrombosis, high patency rate. Normally high patency rate, 85% patency 1 year, almost 80% 2 year, 3 year also. Then it is cost effective. Once you create it, that is obviously it stays for a long time, infection less, obviously the overall cost will be less, allows greater blood flow. We do the dialysis with 300 blood flow, we target for 300. So 250 if there is access, I mean central venous line, and 300 if it is a fistula. And those, when we do SDF, we target 350. Difficult to achieve that 350, 400, but 300 is okay for us. Our Indian patients whose body surface area and body weight is not very large. Reduced morbidity. And overall morbidity, mortality, we know that somebody is having central venous catheter, infection, repeated admissions, antibiotic, thrombosis, all these things, dislodgement, everything is bleeding, hematoma, whatnot. So reduced morbidity overall. So but there are, everything comes with, every coin has two sides. So same thing. It's a little bit of disadvantage. Slow maturation. You cannot use it immediately. Once you create fistula, you have to wait for minimum 6 weeks. Maybe, I mean minimum 4 weeks. Sometimes young patients 4 weeks also it gets ready. But average 6 weeks, sometimes 2 months, 3 months also. And before getting matured, we may need multiple interventions that I have not written. Sometimes we need, before using itself, the flow is not good, it is not fine, so we may need to intervene either surgically or by endovascular way. You need suitable vessels, which is a big problem for us, because the education of patients and also many staffs are not good. So by the time patient comes to us, there are multiple pricks everywhere. So that's a problem. So vascular preservation we'll discuss. So suitable vessels, if it is fine, then all right. Otherwise, it's a problem. Maturation failure, stenosis, these are the complications. We know that. And sometimes difficult to cannulate. Once you create, now we have 2-3 patients where this fistula is failed, here display, here created, but unfortunately the vein, they got prominent, it got matured through the medial side. So how to cannulate now? That is also difficult. Sometimes this happens. You create fistula, sometimes the vein mature, the long segment you get from the back side. So that is also difficult cannulation. Somebody is obese, so suppose is it deep seated and some amount of edema, all these problems are there. At that time you need expert people, senior people. And after 2 to 3 years, most majority of the patient they have, it is dilatation, aneurysm, either pseudoaneurysm or aneurysm, they dilated. So a lot of cosmetic issues, particularly young females and even young males also, there is cosmetic issues. When there are a lot of, there is a snake like some structure will be there, those part also as a part of disadvantage, but they are not major. So what are the different sites where we can create fistula? Just now we saw. So the most common fistula is this radiocephalic RCF we tell. And we know in each hand, even 8-9 ways we can create fistula. The most distal most is snub box. And the most preferred is radiocephalic first. We always try to do that. And RCF and BCF, these two. And possible we just saw the transposition. When the vein is brought to anteriorly to get the long segment, that is transposed. That is a bigger surgery. Either under GA or under block, it has to be done. It is done by expert surgeons. We saw the sir has done it very nicely. And so these are the different type of waves. Conventional always first, if not possible problem, then only transposition. So how to plan it? So the role of nephrologist is to plan a fistula properly. Patient is not going to go by himself to a plastic surgeon doctor to create a fistula for me. Very rare. Normally these are the physicians or the nephrologists. They plan and send them right time. So fistula first policy. It is in KDIGO guideline long ago. They found out in US also only 10% had fistula. Only 10% dialysis patient had fistula. I am talking about this 2017-18. So they found what to do, how to educate the medical, paramedical staffs. So they brought in a policy, fistula first fistula banana hai. That's the policy. So, but with that, the target is 68%. Very less. It's not 90, 100%. Not possible. 68%. Suppose 10% are undergoing dialysis. If 6 to 7% we are happy. That also didn't happen. And but this after bringing in this fistula first policy, the number improved. That improved to 30-40%. So what happened? Always CKD patients are not seen by nephrologists. So it is seen by physicians. So at the timely referral to nephrologist is also important. And prior to initiation of dialysis or any form of RRT, so they need to be educated properly. They have to give options which you don't give. Go and do a hemodialysis. We are telling, no, not wrong. Hemodialysis is there, peritoneal dialysis is there, transplantation is there. What are the different type of accesses are there? Everything, pros, cons, you have to give some time and explain. Then only things will move in proper way. Then referral to, now we nephrologists also are at fault sometime. We wait, like create 9-10 meters, jao bhai fistula banao. So by that time patient will have prick here, it got middle of the night they will come, breathing difficulty, they cannot lie down, femoral fistula, femoral access temporary. Then after some days, after 1 or 2 weeks, jugular, right side some problem happened, left side. So by the time they go to a surgeon, everywhere it is pricked. We think that these veins are fine, but that is not enough. You have to see these are also fine, heart to heart. From heart to heart, everything should be clean. Otherwise, you will be creating fistula, but they are waste. It has happened. There are patients. Within 1 month, they will come. There is swelling and all those problems. So even in developed countries, even after fistula first policy, the number went to only 25-30%. So what they told? Fistula first and catheter last policy. So they improved that the catheter by last mein dalna. If nothing is possible, or then only first catheter. So that improved. So the target is to tell them that all the physicians, nephrologists, then the renal nurses, staffs, everyone, that fistula is first. So that is what. Then what to do? Then that is not enough. That is in our mind. We educated counsel. We have to preserve the vessels. So to preserve the vessels, who are pricking the vessels? The phlebotomist who collect blood. CKD patient, diabetic, hypertensive, every month, every 2 monthly test. Oh, यहाँ कर देने नहीं बार इस बार मत करो यहाँ कर दो आज फिर कल यहाँ कर दो यहाँ कर. By that time 10-20 pricks every alternate month, very bad. And God forbid sometimes comes to casualty or ward, some admission, every vein is pricked. So that is by nursing officers. When we get patients from casualty to ward, by that time already 2 cannula. यहाँ पे cannula, यहाँ पे cannula. तो कहाँ पे बनाओगे आप? Where will bring it? Both sides there are cannulas in the middle of the hand. So that's why Save the Vein project, it is again brought in by American Nephrology Nurses Association. So because they are the people, they have to be educated. Nurses, residents, and then technicians, everybody has to be educated that to save nurse. So save vein, no IV, no lab draw. So it is very clearly displayed in different areas. So they started putting the nameplates and they educate the people. Also the patients, we tell them no, don't allow only one hand, not the other hand, if possible. And when to do timing of AV access, I told now whenever GFR drops below 30, that means CKD stage 4, creatinine is 3, CKD 4. That time itself you have to tell. Now I'll tell you, in our hospital, we sent people with 4 creatine to surgeons. They told, abhi se bhej diya. No need, you go. Jab dialysis hoga tab aana hai. But that's wrong. Whenever somebody is having CKD, diagnosed CKD, what you have to remember, it has to be CKD. It's not AKI. It's not acute kidney injury. Now creatinine has gone up to 4-5 and there is a hope that it will improve. No need of fistula creation. So CKD, we understand that 3 months will wait. Creatinine is not improving. We diagnose it is a CKD. Now it is stage 4. GFR is below 30 and going down. We have to send them to surgeons. So you also understand that once CKD stage 4, it is the time to educate, to tell, and those whoever will opt for hemodialysis in future, we should create fistula. But I will tell, for every patient we should create fistula. May them opt for peritoneal dialysis, may them opt for transplant, we should create a fistula. Only exception is, like previous case we saw, Somebody is CKD, but life survival is only hardly 1 year, 1.5 year. So no need, we can wait. No need to create. And somebody is already ready with a donor. Somebody is going to have transplant within few months, 2, 3, 4 months. Then it's okay. We can manage with a tunnel catheter. And apart, but transplant is a different ball game. If you think, 3 mahine mein ho jayega, but it will take 3 years also. You never know. So always we tell better to create a fistula, because with fistula you can perform all your day-to-day activities. So this is the time. So those who choose hemodialysis, AV fistula should be created at least 6 months prior to the planned initiation of dialysis. Now this is a very optimistic sentence, not a practical. You never know, say 6 months, we don't know. But if you go by the studies, GFR drop by 5 to 6 per year. In that way you can plan. So how to work? So very shortly, the pre of evaluation, we take history of prick, history of central line, history of injury, history of any pick line also, long lines, pick line. We put it, those medicine people, they put very in anesthesia. Then physical examination by looking at Allen test, by looking at this fist cleanse test, all these simple tests we can do. And imaging, vascular mapping for not all patients. Believe me, 30% only patient they need vascular mapping. Clinical 70%. And minimal vessel size, the ideal optimistic vein 2.5, artery 2 millimeter, KDIGO tells 2 millimeter for both vein and artery, but 1.5 is the minimum range, and again depend on expertise of surgeons. Some surgeons they do fantastic fistulas with 1.5, 1.2 millimeter also, but good to have 2 or more size, the diameter of artery and vein. Then sometimes our radiology friends, they very easily tell about the quality of vein and artery. So what did the vein dilatation test? One, while doing Doppler, you can put a tourniquet proximally. So after in few minutes you say that you can see that 50% increase in the diameter and flow of the vein. That means vein is doing well. Now just sir was checking, was doing something with the forceps and checking, yeah, it's good. So there are different maneuvers, and it's a validated test, that a vein dilatation test. Similarly, arterial dilation test, that is also easy. You can tell them to clench your fist 2-3 minutes, then leave it. So the triphagic flow, arterial pulse is triphagic. So that changed to biphagic. That means they are dynamic. They are not stiff. Still the vessels are dynamic. So that is one way. It is not the only way, that is one way. Then when to do vascular mapping is useful. Just I was telling, only 30 to 40%, not all. Somebody is having fistula failure previously, fistula failed, old age, peripheral vascular disease, iatrogenic vessel damage, that what we are doing. And patient related, somebody is an IV drug abuser, somebody is having vasculitis, somebody is having Takayasu, central vein stenosis, somebody is having multiple times temporary catheter placement or central line, and limitations of physical exam, comorbid condition, dehydration. You don't know that. So in that case, whenever there is a doubt, please go ahead. There is no plan. I'm not telling that don't do, but not for every patient. Not for every patient. So mature AV fistula ideal. So fistula is done. Then what to do? How will you know that when to cannulate? So that again onus is on nephrologists, technicians and all. So it should be accessible with the patient in a comfortable position. Patient को ऐसे लेटना नहीं है. Patient has to lie comfortably. Then only either sitting or supine or semi-recumbent. In the forearm it should be on the volar surface. In the upper arm it should be anterior or lateral surface, not in the medial preferably. And reliably, but normally what happens? Before starting dialysis we cannulate them. Trial cannulation, that is known as. And successful trial cannulation has happened. Then rule of 6, we all know that it should be fistula mature, so it should be 6 millimeter in diameter, 6 millimeter below the skin, not very deep into the skin, and less than 6 millimeter skin. I told you, then the flow should be around 600 ml per minute, but 300, more than 400 is acceptable, but ideally 600. Then straight segment. Now, like we saw that we always try a straight segment of 6 millimeter, but always good to have 10 to 12 millimeter of centimeter, 12 to 10, 12 to 10 to 12 centimeter long straight segment. And generally it takes 6 weeks. Sometimes young patients 4 weeks also we cannulated. Sometimes it takes 2-3 months. Then what to do? Once AV fistula is created by surgeon, they remove the suture and all, they leave. So now it is up to us to examine them properly at time to time, just by clinical examination, by seeing. Normally a fistula has a continuous thrill.
except at the anastomosis site, which is a systolo-diastolic thrill. It is discontinuous, systolo-diastolic. Otherwise, it is continuous. So, and you have to examine whether there is swelling, there is redness, there is any scar mark, any dilated vein, any edema, any collaterals, all these things you have to look. If it is there is some problem. Then pulse and thrill, you can just, it is a soft pulse and continuous thrill. Bruise, same, it is a counterpart of thrill. And some special test we do. This is what we tell 1 minute or 2 minutes fistula exam. You can see and examine 1 or 2 minutes and know. Arm elevation and pulse. If you elevate the arm, the fistula should collapse completely. If you elevate, if you elevate the arm, the fistula should collapse. It's not like to level. This one you see there is plumb. If there is, it tells about outflow obstruction. Outflow means that venous channel obstruction. If it is there, suppose there is a central vein stenosis, then it will, your fistula will be plumb. Whereas another is pulse augmentation. You go away from the downstream, away from the AV fistula. I mean, at the anastomosis 10 to 12 centimeter, you occlude that, the pulse will augment. So that is pulse augment. It's not augmenting, there is problem in inflow. There is arterial, some problem is there. So this is a way to find out how to examine in and outflow test. Then mostly last slide, monitoring and surveillance. We know that monitoring means normal physical examination, just what I showed you, clinical examination, and along with that, if you add certain, if you supplement other things like good dialysis, good Kt/B, good urea reduction ratio, venous pressure, you have to ask your technicians, what is the venous pressure? It should not be more than 100. Suppose it reaching 200, it's a problem. Then blood clot, aspiration mein blood clots are coming, then there is problem with fistula. And cannulation issues, till last week fine, now there is problem, so that fistula problem. And prolonged bleeding time. You remove the, normally what happens after dialysis, we remove the lines, I mean fistula cannula, and give pressure for 10 minutes. Sometimes you need to give it for half an hour, it's not stopping, then there is problem. So at that point you have to catch before the fistula completely fail. And surveillance is you use your gadget like most commonly ultrasound and different additional techniques to find out the flow, the diameter and all the things. But clinically major monitoring is best. And maturation failure, we know whatever you do, 20 to 60% is maturation failure, primary failure, what we tell, because of multiple things. So they may need, that's what I told, 20 to 30% patient, they might need multiple interventions before the fistula is usable. Okay. So to conclude, the AV fistula is the best and desirable access for all CKD patients on maintenance hemodialysis, the rightly known as the lifeline of hemodialysis patients. Fistula first policy and fistula first CBC last policy should be adopted in every dialysis unit. And the counseling of RRT and AV fistula creation plan must start when the GFR drops below 30. Vascular preservation and monitoring is the key to have a good quality fistula and to prolong the fistula lifespan. And it's always a teamwork. It's good crosstalk and good coordination between nephrologist, physician, vascular surgeon, I mean to tell access surgeon. All these things, they will improve the quality of fistula and by turn the quality of dialysis patients. Thank you so much.
Thank you, sir. That was truly valuable insights.
Question and suggestion I would happy to take.
Huge round of applause, please.
This is a 35-year-old gentleman with CKD stage 5 for the last 5 months and not on hemodialysis and no history of previous AV fistula creation. It's a known hypertensive and all the brachial, radial and ulnar pulses are palpable and with normal AIIMS test. The venous status is that all the veins are good, visible veins are present in the distal forearm. Creat is 7.9. So the plan for this patient has been decided as brachiocephalic fistula. So can you see on the screen?
Can you hear me? Hello?
Yes, sir. You're audible, sir.
Yeah, this patient basically we have planned for a brachiocephalic fistula. I have just taken a Legius incision and this is the cephalic vein. We have already reached cephalic vein. You can see this is the cephalic vein.
Yes, sir.
Dissected. But there is one finding which is interesting. Just leave here. So the brachial artery is down, but we have got a good sized artery. Why it's fogging this? There is a fogging in my. So you can see a good sized artery here. Looks like a ulnar recurrent branch, which is quite good sized. So we will do end to end of the artery or side of the artery to the end of the vein. We will not go to the brachial proper. See, brachial is down, I can do it, but when we have a nice sized vessel up, why go for the brachial artery? This is the brachial artery, you can see here. Do you have a right angle? This loop is getting fogging in the loop.
Good afternoon, sir. We are from the auditorium.
I don't know, fogging. Earlier it was not happening, now in the past. Right angle. Okay. Can you clean it? Do you think fogging will decrease? I think the temperature in the... Yeah. So this is the brachial artery. You can see this brachial artery. I have dissected. But on top is the... You can see this branch. Normally the artery is not that significant. This looks like a recurrent branch. You can see this? Okay. So what we'll do, again, we'll do to the side of this artery. Why unnecessarily sacrifice? Okay. We'll do this artery. Give me a look. Give me Ralphin forceps, Arson's forceps, Arson's forceps. Yeah, marking. See, this is the course of the cephalic vein, and brachial artery you can palpate. Okay. So normally a Legius incision you can have access to both very, very comfortably. So here we have got a very good access to. You can see this is the vein. Like a clip, 100. One more. Mike, Dolphin. So you want end to side anastomosis or side to side anastomosis? Here both can be done.
So we would want to see side to side anastomosis, sir.
Side to side?
Yes, sir.
Because side to side will be helpful in this particular case. Even the upper part of the forearm veins might open up.
Oh, yes, sir, sure.
And this is a branch, a significant branch. Normally you don't find I am seeing this finding for the first time, a recurrent artery so large in diameter. What is that artery? Yes, you can see this just above the... You dissected that artery? Here it is. Yes, you see this is the ulnar, recurrent ulnar. See how large it is. Normally you don't find such a large artery, and the brachial is below. I have dissected it. Okay, so why unnecessarily go to the brachial when we have this? Look. Artery.
Hello. Can you guys hear me?
Hello, yeah. You're audible. You're audible. You're audible.
Yeah. This is OT1. Moving on to our next case. A 57-year-old male diagnosed with a chronic kidney disease, stage 5, for the past 6 months, currently on hemodialysis for the past 1 month. He is a known case of type 2 diabetes mellitus, hypertension. His dominant hand is right and his plan on the left side. On examination, ulnar, radial and brachial pulses are palpable, and these are his Doppler findings. In him, we are planning for a proximal side-to-side brachio-anterior cubital with Sir's technique, which Sir has spoken about it in the morning. So over to you, sir, regarding the case.
It's okay. As long as they hear, are able to hear. Yeah.
अभी से और थोड़ा
इसको क्यों लगाएं? प्रॉब्लम हो जाएगी। इसको निकाल ही देना। इसको निकाल ही दे। हाँ, हटा दो। Get all markings off.
Hello, can you hear me? Hello?
Sir.
Can you hear me?
Yes, sir. Yes, sir.
So here we had changed the plan. The cephalic vein is nice and good. You can see this cephalic vein. But we found recurrent ulnar artery of very good caliber here.
Yes, sir.
So instead of doing the brachial, we are doing side to side the cephalic with the ulnar recurrent.
Yes, sir.
So this is I am doing for the first time. I haven't seen such a large sized artery just above the brachial. First time I am finding this loop, one more loop. Otherwise, we had planned for end to side brachiocephalic. If you want, we can convert it to end to side, but I don't think it's required in this case.
Yes, sir.
Okay. Background? Yeah, I'll not go under microscope.
Vibhuti sir will be shifting to OT1 for some time. We'll come back to you, sir.
This is the vein, this is the artery. Both are like side.
So am I audible?
Doing a side-to-side anastomosis.
Yes, sir.
Hello.
Yes, sir.
Am I audible? So this is the marking of the brachial artery. At the elbow, again, this is the elbow crease. So you flex the elbow.
Can we please adjust the camera in OT1? Yeah. Thank you.
Okay. So this is the elbow crease. Again, incision has to stay above. This is the median antecubital vein which is joining the basilic with the basic. This is the medial epicondyle. So the basilic will come from this side. This is your cephalic vein. So we are going to do a side-to-side anastomosis here. So as usual, we are going to take a gentle S-shaped incision like this, expose this vein, mobilize this vein, and do the anastomosis side-to-side with the brachial artery. That's the technique that we have described. Okay.
Yes, sir.
Why suddenly the lights have gone low? So local anesthesia. एक सुई लगेगी है? उनको बोलो.
सुई लगा रहे हैं.
So I'm giving local anesthesia right now. You have to be extremely careful because you're crossing the nerve. So better enter in between so that you don't damage either puncture the artery or vein. Thyroid plain 2%. No dilation. मेरे को माइक्रो इंस्ट्रूमेंट दिखाओ जरा. Okay, हाँ, this is good. This I'll want. ठीक है, sure.
Parag sir.
Yeah.
Sir, do you prefer to sit on the side of artery or vein, like?
No. So when I'm doing a radiocephalic fistula, I will sit on the arterial side.
Yes.
So that will be on the head end of the patient. When I'm doing a brachiobasilic transposition or brachio-antecubital fistula, I will sit on the ulnar side of the patient. For brachiocephalic also, I will sit here. Only for radiocephalic, I will sit at the other end.
Okay, thank you.
दर्द हो रहा है?
पता चल रहा है दादा दर्द हो रहा है नहीं
Jesus. करो 15. So you can see the vein here, it's sitting right under.
Yes, sir.
Those in the audience, please note that this is, sir is doing so fast, but it is not like sir has many years of experience. So many times we have to give adequate time and effort to find that vein.
So we'll ligate these side branches. I mean clip them, small ones, small ones. One more. Scissors. This branch we will clip after we do the anastomosis, because there is likely to be a valve here, no? So I want to dysfunction the valve. We'll show the valve first, and then we can. Yes. So this is the vein. Vein is in place. We have to dissect the artery now.
Yes, sir.
नहीं जरूरत. Plain forceptomy. थोड़ा हाथ ना ऐसा चाहिए बंदने के पास.
पल्सेशन दिख रहा था स्किन से.
So this is the part of the aponeurosis which we have to cut now here to get the artery up. So that's the brachial artery. बाइपोलर नहीं क्या अभी? ठीक है क्या बाइपोलर? हाँ
बाइपोलर 30 पे है, कम कर दीजिए।
फुट पैडल आई डोंट नो या okay, we have to see where the slope बिल्डिंग कहाँ से है? यहाँ से ना
Right side.
Okay, slope. So here what you do is you have the artery and vein next to each other. Leave this. Okay. The vein is here. So I'm just going to put the slope together so that automatically they'll come. Another one. Bipolar. Don't pull on that side.
Vibhuti sir.
Clip.
See, I am doing side-to-side anastomosis between the cephalic vein and the ulnar recurrent branch.
Sir,
this is the first time I am doing it in a workshop because this kind of branch, so the prominent branch just over the brain. This is very clinical experience I am finding it. So could have end to side, but I am doing side to side because the upper part of the cephalic vein is intact, so we can also use that segment for dialysis.
Sir, what is the approximate size of your arteriotomy, and do you always excise the wall, like you have excised a part of?
In artery, I used to excise a part of the wall, but in the vein, I just do a venotomy.
Okay, thank you.
You can clearly see the arteriotomy and the venotomy. You can see very clearly.
Yes.
Are you able to see it?
Yes, very clearly, sir.
Just a moment. I think this you hold, otherwise it's getting locked there. This one. Just hold it away from the anastomosis. Yeah. So I think Dr. Parag will know. He might have done this earlier, I don't know, but this is the first time I have got a decent artery just above the brachial artery, which is being done in the cubital fossa. Focus, focus change. So,
sir, it was visible very clearly before.
Yes, that is what
now
you were
also
saying.
It is visible. Yes, sir.
No, for me there is little bit of problem. I am not able to.
Sir, are you doing under microscope?
Yeah, I always do under microscope. I don't use loop for the anastomosis. See, there is not much difference as far as results are concerned, but the kind of illumination, precision, the clarity you get with microscope, you will not get with loop. And if there is a microscope available, why not use it? Suppose there was no microscope here, yes, I would have done under loop. So if there's a Mercedes to drive, why go in a Maruti?
Sir, Thatte sir is a big fan of your work.
Who?
RL Thatte sir. RLT sir.
See, AB fistula in the plastic domain is has become common in the last decade, and I think this is something which all interested microvascular surgeons, they must grasp to and not let it go. This is something Dr. Parag was saying that this is something which will keep you busy in your microsurgery skill. Even if you might not have a free flap in a week, you might have 4 or 5 AB fistula. So your microsurgical skills improve. That's an advantage. And secondly, especially in the Caesar.
Sir, we'll go to Parag sir's theatre.
Yeah, you can go. But this is going to side only. Nothing must to be done now.
Thank you.
God force.
Wait.
Parag sir, we are with you.
Yeah. Okay. So I have made an arteriotomy here. This is your brachial artery. Arteriotomy is done. I've done the venotomy also. I'm trying to find out where was the venotomy done. Where is the completing video? Wait. So I'm just separating the adventitia on the vein.
Yes, sir.
Okay, 11 number. No, I think I made a puncture, no? Or I didn't. Let me check. This was the puncture? No. Anyway, we have to make a new one.
You can open clamp and see, sir.
Nothing is coming. No, why नहीं? Flush. Yeah, now we are bleeding well. So can you see here, this is the antecubital vein and this is the basilic vein.
Yes, sir.
You can see the basilic vein coming from the forearm.
Yes, sir.
Yeah. Give me another clamp if you will put it to that vein so that it doesn't come in between. Yeah, thank you. Okay, so now again same thing. Put gauze on the clamps. Background. क्यों चाहिए background चाहिए? Suture 70 proline. Now here the thing is whether we want to, I said before you start the anastomosis you have to check whether there is a distal flow. Now that's the main step I am going to show now.
Yes, sir.
I am releasing this. Okay, you take a retractor here on the inferior side, sorry. See this? Can you appreciate this? I'm going to insert a vessel dilator. This is a long arm vessel dilator. Can you see this?
Please refocus the camera, please. Yes, sir. Yes, sir. We can see.
Leave it. Release. Okay. So I'm going to introduce this inferiorly into the vein. Okay.
Yes, sir.
I'm releasing this clamp. Yes. Hold the vein and you try to push it down as under vision as much as possible. You can see the increase in flow now.
Yes, sir.
You can see the increase in flow.
Yes, sir.
It was not there previously before I introduced it.
Yes, sir.
Yeah. So and then now we'll flush the hyperealized saline, release the tension a little bit. Still I enter the I hold it here like this, okay. You feel for the thrill on the forearm here, okay. So he's feeling for the thrill. You will tell me if there is a thrill or not. Wait. No, this intracath is kinked. Yeah, okay, it's gone in. You can see the vein dilating.
Yes, sir.
And it's feeling very free flow into this thing. Can you feel the thrill? You can feel the thrill. Okay, so he is able to feel the thrill. So then this vein is good to go for side-to-side anastomosis.
Okay, sir.
Clamp, please. And now you can ligate this vein. Give me a clip. Why I kept this vein is sometimes if this vein is blocked, you think you can utilize this vein also.
Yes, sir.
Normally you find two communications here. Okay, sure, leave it now.
Parag sir, we'll quickly switch to OT3 and come back to you.
Yeah, sure. Hold on.
Yeah, now.
Vibhuti sir, we are with you.
Yeah, we have completed the anastomosis. There's a little leak in the corner. I'm taking a last bite there. So, as I said, this we had planned for end to side anastomosis. But because we had a branch just above the brachial artery, ulnar recurrent branch, we chose to do side to side.
Yes, sir.
Without sacrificing that artery. Some plus. You see where there's a leak there. I think the leak is here. Yes. Yes. Okay, cut. Platform. Okay. Just hold this hand like this. Let me see. Bas. Relax. Eti rakhantu. Stitch cutting. Next, give me micro scissors stitch cutting. Okay. Position take a bit. Don't change the position much. I just want to see how it settles down. Okay. Go ahead, cause please. Yeah. Yes. Because we are taking continuous suture. If you don't lock, then what will happen is when we tighten it, we can have posturing effect. So if you do polar stitches, the chances of locking, the pulsing effect is less. But here, we have not got classical thrill. I am getting the pulsation, but thrill.
Vibhuti sir. Sir, can we... Vibhuti sir?
Yes.
Sir, can we divide the vein, distal
Yeah,
vein?
you can divide, but here what has happened is majority of the vein is thrombosed in the mid forearm. So the flow is not going to get very distally. It will not cause any venous edema, so not required actually.
No, to improve the lie, improve the thrill.
Yeah, that is what I am working on actually. I am not very happy with the, we are getting the pulsation, but classical thrill I have not got because I am releasing it a bit to improve the, maybe this branch might. Okay, give me a clamp that will give us a fairer idea how the bleeding is. Like a clip. Give me, okay, 100 will do. There. Micro forceps. Micro scissor. And get a Laya clip ready. So in case this bleed is... So if I cut, what will happen here? The bleeding will be... So the bleeding is not very... So what does it imply? If the flow was good, there is some problem. Give me some floss, Didi. Venus. What can you do now if you are not getting good bleeding? What the options are? I can convert it to end-to-end because this artery, I'll do end-to-end here. Yeah, I'll convert it if required. I just want to see why it's not coming.
Vibhuti sir will quickly shift to Parag sir and come back to you.
Yeah.
Parag sir, we are with you from the mini auditorium. Hello Parag sir, can you hear us?
Yeah, I can hear you. Yeah, what was the question? I didn't get it.
No question sir, we've come back to you from the other OT.
Okay, fine. We have to wait here because come back early because I'm going to release the clamps and we'll see that the distal flow is going well distally. Okay? They've already gone.
Yes sir.
You suggest dilating it that far, sir, like you did.
Yeah, to here.
In all of the pictures.
Sir, you are taking
Yes.
70 or 80 proline. So what suture material you are using?
Sir, they are asking questions.
Achha, I am using 70 proline, double end needle.
Okay, so you use both the needles?
Yes, posterior wall one needle, anterior wall one needle.
Okay. Sir, you prefer this needle holder with lock or without lock?
Without lock. So you can see both threads here.
Yes.
Can you see both threads in my hand?
Yes sir.
And I'm trying a knot here now. So needles are there at both the ends. Oh shit, this is broken. Hold this. Good. One of the needle thread has broken, so we'll have to find out where it has broken and maybe take a stitch because your anterior wall otherwise will just open up.
Okay.
Can't find a... कहाँ ब्रेक हुआ हूँ? Everything looks fine here. Okay, so probably with one stitch, I'll take one more stitch and ligate it on itself.
Okay sir.
Don't flush, don't flush. I can't see anything. लॉन्ग रखो थोड़ा नहीं नहीं
और नीचे 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 हाँ बस hold this. Okay, so now what we are going to do is release the clamps, get a retractor.
Yes, sir.
Yeah, okay. So this is, I am releasing the distal vein. You can already see the vein being filled.
Yes, sir.
There is a leak here. We will have to check. That was the problem, I think. Okay, give me a stitch. Give me the clamp again. Yeah, let me check. Yeah. One stitch. कहाँ से लिखा रहा है? वॉल थोड़ा ये हो गया क्या? मैंने वेन खोलेंगे तो और हो जाएगा ना? वेट आई टेक अ फिगर ऑफ इट देयर. वो वॉल में से हो रहा है. अभी खोलो उसको. ठीक है चलो निकाल दो. डोंट पुल. सब होने के बाद विल शो. Okay. I'm releasing the proximal vein clamps also.
Huh?
Wait, we'll release the arterial clamps now. First the distal artery, then the proximal artery. Now you can see, I'll show you the, give me the retractors now. Okay. Keep some pressure here to stop. Okay. छोड़ो इसको. You can see the nicely filled vein here.
Yes, sir, we can appreciate it.
Okay. And you can appreciate the thrill right up to here. Where my finger is, you can feel the thrill here.
Okay, sir.
We'll show you on Doppler also.
Yes, sir.
See, I can feel the thrill here, right up to the mid forearm on that same vein. See, feel here. So we'll show a Doppler in, you can go to the other theater and come back. By that time I'll close this and then we'll show you the Doppler where till retrograde till what area the thrill is felt.
Sure, sir. We'll come back to you in some time.
Sure.
Hello.
Hello, OT2, Vibhuti sir, we're with you.
Yes, we had little problem here. We were not getting the thrill.
Yes, sir.
So I cannot leave fistula without a thrill. So I am just opening up the anastomosis and seeing what went wrong. Maybe the lie was not very good.
Yes, sir.
So maybe I'll try again. Doesn't succeed, then I'll do end to end.
Okay, sir.
Because this artery can be expanded. No, this is one branch from the
Yes, sir.
artery. So I've just opened up here. You can see everything looks clean here. But still, maybe because of the lie, I think the flow is not happening the way we want.
Okay, sir.
Okay. So what I'll do is I'll start from here. Once more we'll try. It doesn't happen, then we'll convert it. Bas dun Didi. But what went wrong? Why it's such a big vessel? There should be no problem. And the lie, especially the angulation is something I think is giving rise to this problem. Let us see how is the flow from this side. The flow is, what is the flow from this side?
Can we please adjust the camera a little bit?
I think the other side is bleeding faster, no? Better, this side. So we'll do end to end there. So I'm converting into end to end anastomosis, like sorry.
Okay, sir.
Good khosla ude. This side. Which side it's slipped? This side. Okay. 200. Okay. So now leave it now. Okay. Mic procedure. So this will come. I cut it a little obliquely, you mark it, no? Because the lumen of this will be, leave it now.
Can we please adjust the camera a bit in OT3?
Okay. But easy flow, really, yeah. Okay. So I converted to end. You saw that, no? We had problem. I think the lie was a problem. So
yes, sir.
After, the traction we gave, we probably misses this thing. The clamp applicator, Didi. This is the flow rate. I think this is okay.
Sir, which side is proximal, which side is distal?
So I saw both the ends, and this end is bleeding better. So this is the artery, the left. This side is the artery, this side, and yes, this is the vena side.
Okay, sir.
And it's a recurrent artery. The bleeding from this end is better. I think the distal is, this one is bleeding better than the other one. I checked. Okay,
sir,
then leave this. Okay.
To flush the vein.
Now I'll take 80, not 70. This is, Kunsa? Yeah, that's what I have to see. Why it had problem. Let us see. That also can be issue. But irrigation there. So ultrasound actually it looked okay. Therefore I didn't check. Alright. Backflow is there. So we can do it, no problem. See, it's a good sized vein. Artery size also is good. Flow is good. So there is no reason background. So in one case, I think you saw two, side to side and end to end. All other cases were end to side.
Yes, sir.
I think it happened for the benefit of the audience.
Double the learning experience, sir.
over distal, the vein I had bed end to side. So that I'll put a clip and release it. Why unnecessarily keep it now? Okay, give me a light clip, Didi. 200, 200. Take this off.
Yeah. So we're just closing the skin and we'll just do Doppler in a second to show you how far distally the thrill is felt. Clinically we can feel the thrill, but we'll just check on Doppler so that you people can get an idea. See, you will agree with me that this is a very simple procedure done under local anesthesia. Side-to-side anastomosis is distal wall dysfunction. And rather than doing a big incision like we saw in the previous case, this is definitely easier to do and faster to do as compared to brachiobasilic transposition where it required long incision, axillary block. Here we have done it under local anesthesia.
Yes, sir.
Another thing I would like to say is you don't close the skin very tightly. If there is a oozing in between suture, let it ooze a little bit because you don't want hematoma and collection under the skin, because external hematoma outside the fistula can cause compression of the fistula.
Yes, sir.
So even if there is a little bit of leak, let it be. Let the gauze absorb everything.
Okay, sir.
Okay. So I will now do the Doppler and show you. Okay. Give me a small gauze on the to be put on the anastomosis here. Okay. So we'll get a Doppler. So this is the Doppler. Yeah.
When do you do first check test, sir?
Yeah, 80.
That's okay, but
Hold it with your hand. Half will take the hand. Hold it with your hand. Sir, please press the button.
no, battery is gone. Battery, yeah, I think the battery has come off of the Doppler. They are changing the battery.
Sir, when do you do the first?
Press the button.
Doppler is shit यार, ये क्या आवाज है? Get a new Doppler. This is not a. क्या आवाज ही नहीं आ रहा है उसमें से? क्या Kumal, you were asking something?
And then reverse the.
दिखाना है ना Doppler दिखाना है ना
I
क्यों?
do interrupted switches.
Sir, when do you call reassess? Do first check test?
First check dressing?
Yes, sir. Like now we have done the
If the
dressing.
patient, if the patient comes the next day, I will see if there is soakage. Then I will change the gauze. Otherwise, I will keep the dressing for 4 or 5 days.
Okay, sir. Sir, if patient is coming from other city, how many days you want to keep the patient in the town?
If his patient is coming from other city, then it is better that patient is admitted at least for a day. You see next day that there is no extra oozing, no local hematoma, and this thing. And elbow exercises you can start right now because we are again all against. So there is no problem.
Okay, thank you, sir.
नीचे रखिए, हाँ रखिए नीचे हाथ, हाँ है डॉपलर के नहीं है. हाँ same last what we did. So we just show them that thing, Doppler.
Sir, any restriction on how much, like patients keep asking, okay, how much weight can they lift? Any restriction on how much weight they can lift?
See, dietary restriction best left to the nephrologist.
Sir,
weight lifting.
Yes.
I don't advise any weight lifting. Maximum what you can say, I tell you can take half a liter अपना Bisleri bottle and that weight, and you can just do elbow flexion extension. That is more than enough.
Yes. Like
So half kg.
Bucket of water and all they cannot lift.
Bucket is too big. Bucket is too much. How much bucket you are going to fill? That is also thing, no?
Yes. So these are the questions asked by patients. That's why I asked.
Doppler long. Doppler long.
They are getting another Doppler, so we are waiting.
Okay, sir.
Just want to show you how far we can get the bruit and thrill.
Yes, sir.
See, this is the cephalic vein, so I expect this vein to develop down up to here,
Yes, sir.
so that these 2 points can be pricked for. Yeah, they've got. No, you can remove it now. It's procedure is done. Remove it from the plastic. Yeah. Okay. Okay. Jelly. Can you hear that?
Yes, sir. Yes, sir, we can.
Okay, I'm going down.
We can hear it, sir.
Going down further.
Yes, sir.
It has softened, but you can listen to it now.
Yes, sir.
Okay, down further. I'm almost at the mid forearm now.
Yes, sir. We can hear it.
Still it is there.
Yes, sir.
So you can see I am almost beyond the midline.
Yes,
So this
sir.
is the vein that will develop. This is the median antebrachial vein. This is not the cephalic vein. You can see this is mainly going into the middle of the forearm.
Yes, sir.
Yeah. So that is what I wanted to show.
Thank you,
Yeah,
sir.
it's already started developing. Thank you.
Thank you, sir. We'll now be shifting to Vibhuti, sir.
Yeah. So we are now we converted it to end-to-end anastomosis, which part
Yes,
of
sir.
that was bleeding well. So we are now doing end of the recurrent ulnar artery with the end of the cephalic vein. So this
Yes,
is
sir.
the anterior wall we are doing. Just hold this.
End to end.
With traction there. Precision, not that much it will here, yeah, just little bit traction. So you have to be very delicate. Now leave now. So I took 2 bites at a time. You can take 3 or 4 bites at a time to conserve time.
Okay, sir.
So by taking 2 multiple sutures also, you ensure that you have more space to look at the posterior wall and you are not taking any bite of the posterior wall.
Yes, sir.
Cut, stitch, cutting, cutter. Cut. You're not able to see? No. Okay. Cut this also. No. Okay. Cut. Okay. No. So now we have flipped. This is the posterior wall. Irrigation, please. Yeah, Madhav. Micro seizure. So what is the other lump? Did we cut this suture? What is the other suture here? Yeah. Fine. Then give me the need suture. No, I'll hold it. I'll hold it. Give me some plus. Now we can see the lumen clearly. There is there. 80. Suta. Where is it? I placed it here only. Yeah, it's okay. Forgot. Okay. Cut. You're having some problem in microscope. I can understand because normally. Oh, okay. So therefore you're having. So I'll cut, no problem. Otherwise, what is happening is. Do you have concentrated heparin? Give me the stitch cutting. I think you are having a little difficulty seeing the. Because of the change in the position, you are having difficulty, I suppose. Okay, oh. And the position changed because we changed the anastomosis. Needle holder, sorry, scissor, micro scissor. Give me heparin, Didi. Needle holder. Take this. Heparin, Didi. Concentrated. Very good. There. The position again is changing a bit. Now you can get the thrill. Here, put your finger here, gently. Okay. So the learning from this, there are a few learnings for me as well. First, I had a prominent branch above the brachial artery, which I saw for the first time. I have a huge number of fistula I have done so far, but this was a new finding for me. And then I changed my plan. I went for a side-to-side anastomosis. The mistake I did is I used the loop, and the angulation was not favorable. But most importantly, on table we detected the problem that there is no thrill, only pulsation is there. So you should not leave the fistula if you are not getting the thrill. So even though you spend some more time, there is no harm because the patient again will suffer. So now we got palpable thrill, then only we are closing the incision. So whenever you are doing a fistula, you can land up into problem, not that everything will go very smooth. Sometimes planning might go wrong, sometimes the steps you are doing might go wrong. But at the end, the patient should have a thrill and you should not be satisfied with just a pulsation.
Thank you, sir.
The Department of Plastic Surgery for this beautiful conference, and I would like to thank for the invitation also. So in the next 10 to 15 minutes we will discuss about what are the different management of failing fistula in terms of interventional radiology. Why radiological interventions? All of us know that if we compare the POMA catheter, tunneled catheter, graft and fistula are the one who have a longevity more than that of the graft and the tunneled catheter. And despite a good long-term patency, they still have a chances of recurrent thrombosis or stenosis or occlusion. So they need repeated interventions, and in some cases surgical intervention or surgical re-intervention remains the choice, but again doing a repeated surgical intervention is cumbersome and not possible always. So in that cases percutaneous radiological intervention comes into play. These are very minimally invasive and repeatability is a major advantage. So what are the complications? All of us know that infection can happen due to the repeated usage at the local site. They can develop thrombosis either because of the faulty procedure during the hemodialysis or due to the patient-related hypercoagulability factor. They can develop stenosis because of the very high flow across the fistula leading to neointimal hyperplasia and stenosis. Repeated usage also can lead to pseudoaneurysm formation. Because of a large fistula, some patient can develop steel in the distal hand. And because of the very large fistula, some patient can develop high output cardiac failure, and because of the shunting of the flow across the vein into the central circulation can again develop pseudointimal hyperplasia and lead to central vein stenosis. So the first thing that whether the fistula is failing, whether it is functioning well or not, first we have to diagnose clinically. Then the role of ultrasound comes into play. It's the key investigation tool to confirm whether the fistula has any stenosis, thrombosis, narrowing whether the flow is adequate or not. Apart from the area where visualization is very limited, like in the central area in the thorax, ultrasound may not suffice, and in such cases you may need to have a CT scan to confirm or identify the site of the occlusion. But whenever you are considering a CT in such patients, you also have to take in consideration of the risk of contrast induced pulmonary edema. So you have to plan the CT just before the hemodialysis or do a CT and then plan for a hemodialysis. So what are the indications for interventions? Primary failure, that means whether the fistula fails to mature or it fails within 3 months of the usage, then that is called as the primary failure. Secondary failure means failure after the 3 months of usage. That can be thrombosis or that can be stenosis. Whenever there will be a thrombosis of the fistula, it's almost an emergent procedure, because if you delay the re-intervention in case of thrombosis, then there will be a less chance of recanalization. So if you have a fistula in the arterial arm or in the venous arm, you have to act a little bit early. And the other indications could be central vein stenosis or AVF Still syndrome. So what are the procedures that we can offer? That can be simple balloon angioplasty. Even in some cases with a normal balloon, if there will be a very firm stricture that may not open, so in such cases you can use a high pressure balloon, and in so rarely you can use a cutting balloon also. And when there will be thrombosis, you have to do a thrombolysis or thrombectomy. And in some cases, in a very limited setting, if there will be residual stenosis or if there will be immediate recoil after the balloon angioplasty, then you have to stent that site also. So what are the most common site of stenosis? Mostly the stenosis occur in the juxtavenous area, that means just in the vicinity of the fistula. So the most common, that is radiocephalic or brachiocephalic fistula, you will find a stenosis just within the 2 to 5 centimeter of the AV fistula site. And as you go off, you may find stenosis in the excess vein also. And one most common site of stenosis is the cephalic arch, because there will be angulation in the vein, there will be a extrinsic compression by the clavipectoral fascia. These all factors additionally add to the concept of narrowing, and you may find commonly a stenosis at the cephalic arch. And in case of a brachiobasilic transposition fistula, you will find a stenosis in the venous end. So in terms of primary failure, again either a surgical redo or surgical revision may be attempted, or you can go for an endovascular recanalization. So if you have a stenosis at the anastomotic site, you can offer an percutaneous transluminal balloon angioplasty just for the juxta-anastomotic stenosis. And in some cases, even if there won't be enough stenosis at the juxta-anastomotic site, the fistula fails to mature because there will be a lot of competing veins. So not a single vein will mature, rather the flow will be diverted along the different veins. So in such cases, you have to either ligate the other accessory vein, or you have to embolize those small veins so that a single dominant vein will mature over a period of time. So this is an example. You can see this patient had a primary failure. So we entered through the radial artery, we took the run. This is the radial artery run that is marked, and you can find a stenosis in the distal radial artery. That is one of the cause for failing in this case. Then we crossed the fistula site, we took a venogram. You can see there is opacification of the vein in the second image. Again, initially after crossing into the venous site, we did balloon angioplasty of the venous segment. Still you can find a narrowing in the venous area also, a narrowing in the arterial area also in the juxta-anastomotic site. But at least you can say in the third image there is opacification of the vein. Then again we did a balloon angioplasty both for the venous and arterial side. And this is the end angiogram. You can see there is good opening of the arterial site also, and there is recanalization of the fistula and venous site also. So this is one of the salvage in primary failure. This second is the salvage in secondary failure. This is a case where you can see we have taken the excess from the radial artery. You can see only opacification of the artery with no opacification of the vein. Again we crossed the anastomotic site. We did balloon at the anastomotic in the juxtavenous site. And this is the end angiogram. You can see while we took an arteriogram from the arterial artery, there will be flow into the outflow vein rather than in the artery. Whereas in the first image only artery was opacifying. In the last image after the balloon angioplasty, the flow is entirely diverted towards the venous side. AV graft balloon angioplasty. In case of graft, usually stenosis happens at the venous anastomotic site. So in such cases also you can go and do a balloon angioplasty. Like in this case, there is a stenosis at the near the venous end, and we entered into the venous arm and we did a balloon angioplasty. So there are certain complications that can happen with angioplasty, and one of the most dreaded complication on table is the rupture when you are doing a ballooning. So you have to be prepared. First of all, if you have a rupture in situ, then first of all you have to give the compression, you have to elevate the limb. You can call your surgeon friend just to open and close the fistula or repair it. Or if you have a stent graft or covered stent in hand, then you can place a covered stent across the rupture to seal it. So this is one of the example. You can see there was stenosis in the axillary vein, in the outflow vein. When the balloon angioplasty was done, in that time there was a rupture and there is leakage of the contrast. So immediately on table there was placement of a stent graft to salvage the vein and to prevent the hematoma. Cephalic arch stenosis, this is a difficult area to treat. Basically, even if you do repeated angioplasty, the patency rate are very less. So in such cases, either you can do a surgical transposition or you can do a upfront stenting. If you compare the bare stent and covered stent have a good long-term patency than the bare metallic stent. Hemodialysis excess pseudoaneurysm, because of the repeated usage there will be damage to the venous wall, and because of the high flow along with the wall damage, patient may develop multiple large variable sized pseudoaneurysm in the outflow vein. So in such cases again the management will be either a surgical open, cut it and put a graft, or you can put a stent graft through an endovascular approach to exclude the pseudoaneurysm. Thrombosed dialysis vascular unit, this is basically a kind of emergency, you have to act early. And whenever there is a thrombosis, in most of the patients you will find an underlying stenosis. Isolated thrombosis is very uncommon. Most of the patients usually have a partial or very significant stenosis and on the top of that patient usually develop thrombosis after the dialysis. So whenever you have a thrombosis, either first you do a thrombolysis or thrombectomy. We have different devices. We used either streptokinase, euro or altiplage, and using you can do a thrombolysis. You can use different mechanical devices. You can suck it out the thrombus, that is called pharmacomechanical thrombolysis, using a mechanical device along with the drug. And once you are done with the thrombolysis or thrombectomy, then if there will be a underlying stenosis, and that will be unmasked. So after the thrombolysis or thrombectomy, when you do a fistulogram, you can find a stenosis and accordingly you have to act. If there will be a significant stenosis, either you can go ahead with a balloon angioplasty and you may add a stenting if there will be inadequate opening even after balloon angioplasty. This is an example of the AV graft thrombosis. So initially there was complete thrombosis of the graft. We did the thrombolysis and thrombectomy, and after the thrombectomy only we found a significant stenosis at the venous end. Then the stenting was done, and this is the post stenting image. You can see there is good flow across the stenosis. There are certain contraindication to the thrombectomy or thrombolysis. So if a patient has a right to left intracardiac shunt, then if you attempt thrombolysis or thrombectomy, and if there will be chances of migration of the thrombus from the right side of the heart to the left side of the heart, and there will be chances of paradoxical embolism. So in such cases you should not attempt thrombectomy or thrombolysis. If patient has a very severe pulmonary hypertension, again if you open up the fistula, that will again aggravate the pulmonary hypertension, and obviously if there will be local site infection, then that may precipitate septicemia and sepsis. So central vein occlusion is again an important clinical issue if patient has a very long-term patency in the fistula. So this patient usually developed edema in the face, arm. There will be engorged vein. There will be prolonged bleeding during the hemodialysis. And if you palpate at the arteriovenous, there will be increased pulsatility in the arteriovenous fistula or graft. because of the increased back pressure in the vein because of the central stenosis. So in such cases, again, you can access those site of occlusion and you can do a balloon angioplasty. And if you are not satisfied with the balloon angioplasty result, then you can add a stent. But in venous system, usually in the central vein stenosis, it's always better to avoid a stent, because stent rethrombosis is a major issue, and if you have a stent rethrombosis, then again recanalizing a stent is very, very difficult. So what we do, we try to manage with the balloon angioplasty initially. We also do repeated balloon angioplasty, and even after 2-3 attempts of balloon angioplasty, still patient has recoiling or restenosis, then we consider for stenting. So this is one of the example. You can see the first CT image. There are a lot of collaterals in the chest wall because of the central vein occlusion. Then we went through a transfemoral route. We crossed the stricture and we did a venogram. You can see there is occlusion of the IJB SBC junction. There is no flow into the right heart, and there is also collateral formation. So we did balloon angioplasty, and this is the post angioplasty run. You can see there is good flow across the stenotic site. This patient also had left brachiocephalic vein occlusion. You can see there is complete occlusion of the left brachiocephalic vein. We did balloon angioplasty. Even after balloon angioplasty, there is again complete recoiling. So in such cases, we have to stent it. Then we had to stent it, and after stenting, there was a good flow across the stenosis. So AV-Still syndrome. This is basically a rare complications after the AV fistula. Patient may present with cold, numbness and tingling during the dialysis, and in severe cases patient may develop frank gangrene in the fingertip also. So mostly the management is surgical, because different kind of surgical options are there which can maintain the AV access, means AV fistula remains patent, and you can avoid or you can minimize the ischemia due to still. But in some cases where surgery are not feasible or patient doesn't want a surgery, we have certain option, like you can use a covered stent in the fistula site just to narrow down the fistula, or you can put a balloon in the outflow vein, and you can ligate the vein under the ultrasound guidance. So this will be a graded, means a calibrated reduction of the outflow vein, balloon assisted ligation. And in rare cases, you can coil the distal radial artery, that means radial artery distal to the fistula site, so that there won't be retrograde flow during the dialysis. So these are the 3 options that we have for the AV-Still syndrome, but mostly this is dealt with surgical therapies. So to conclude, the most important thing, once you feel that the fistula is not properly working, you have to confirm it. Ultrasound is the investigation of choice, except for the central vein stenosis, where you may need a CT scan. IR guided fistuloplasty, again, this can offer repeated interventions, and it helps in prolonging the function of the AV fistula. And stenting, basically we try to avoid it, and it has a very limited role, like there will be a venous rupture during the interventions, or patient have a very immediate recoil or restenosis in case of central vein stenosis. Thank you.
Thank you, sir. That was truly informative. I would now like to invite Dr. Bishwajit Misra, sir, to talk about...
Also listening to some of the talks by the nephrologist and the intervention radiologist. Some of the theoretical part may be repetitive, but it is maybe useful for those who have missed the talk. So AV fistula, my experience. So my experience, what I will be telling, my experience will be basically divided into 2 parts. Because right now I am working in SC Medical College, Cuttack, but before that I have worked in a place which was 200 km away from there, and there I was the alone person. So my talk will be divided into 2 parts, so it may be useful for those people who are working alone or who are starting the practice, and what they may do in the later on. So my topics will be covered under certain headings, like what is short introduction to the type of fistula, which has been told very nicely by the nephrologist. Then what are the traditional recommendations, what are the initial hurdles or challenges you may face, and what are my techniques and my experience. So all of us we know that vascular access in hemodialysis can be, there are three options like AV graft, AV catheter or AV fistula. Out of this, AV fistula is the preferred method for vascular access for hemodialysis. Now why AV fistula is the preferred method? Because compared to AV graft and central catheter, AV fistula after maturation are associated with lowest complication rate, lower rate of infection and better long-term survival, and less intervention are required to maintain the long-term patency once successfully cannulated for dialysis. Now what are the sites of AV fistula? According to the traditional guideline by Canadian guideline or European guideline, or whatever the common concept or traditional teaching is that always the radiocephalic fistula at the wrist, that is brachiocemino fistula, it is the first option. Then it is followed by brachiocephalic and brachiobasilic fistula. So what are the advantages of doing a distal radiocephalic fistula? Advantage is that it provides a long segment of vessel for access. It is a comfortable means of dialysis, require less superficialization and dilates more proximal veins, which enables for a easier fistula creation. But the disadvantage is that the distal radiocephalic fistula are placed at the wrist has a higher rate of non-maturation than the brachiocephalic fistula created at the upper arm. What are the risk factors for poor maturation? Poor maturation risk factors are usually the female patients, elderly patients, obese patients, and there is a controversy regarding the role of diabetes mellitus in the non-maturation of the fistula. However, if the radial artery size is less than 2 mm, the flow rate is less than 40, if the artery is calcified and the cephalic vein diameter at the wrist is less than 2.5 mm, these are the risk factors for poor maturation. Now brachiocephalic fistula, all of us know, it is created at the elbow. The advantage is that it is easy to cannulate because of the superficial localization of the cephalic vein, long segment of vessel for cannulation, but the disadvantage is that brachiocephalic fistula is more prone for Steele syndrome, high output cardiac failure and the hand edema. So what are the initial hurdles or challenges I faced when I joined in a place where the AV fistula was not commonly done? Initially, always I used to get failure cases. So your chances of success depends whether you get primary cases or a failure cases. That decides what site you will be doing the anastomosis. Then what is the trend of surgery there? Like in some of the places when you start practicing, it is done by the cardiovascular surgeon or the urologist, not frequently by the plastic surgeons. Now how that differs or matters? Because they usually do 60 or 70 prolin. They can do, usually they prefer brachiocephalic anastomosis, which is created most commonly at the elbow. But because we are commonly used to, plastic surgeons are commonly used to be doing with loops or microscopes or using the finer suture materials like 80, we prefer that we will do at the distal radiocephalic fistula. But sometimes when you counsel the patients start on telling that, sir, I have seen the people doing anastomosis higher up. And if you say that I will do distally, then they ask what is the percentage chance that, what is the percentage of success? And initial practice usually, definitely the maturation of the distal radiocephalic fistula is less. Then second thing, whether you are working as a team or you are alone. Suppose you are busy doing an emergency or you are busy doing a long free flap or some busy otherwise, you may not attend the patient. Suppose the patient bleeds or suppose the patient doesn't have a thrill or some complication, you may be the alone person. And main thing is that sometimes the patient came when they are dyspneic, when they have very high raised urea creatinine, they may come and tell that, sir, do a fistula so that my dialysis will be on the next day. In all the cases, you have to explain to the patient that it takes some time to maturation. And though the dictum is that once the patient is diagnosed as a CKD, it should always be creation of the AV fistula fast in clinical practice or in peripheral practice it may not occur. The scenario is little bit difficult. And always you should have a good micro instrument, surgical loop and suture material according to your expertise or preference, anticoagulant, papaverine. These are the basic things for any microvascular anastomosis. So what I thought, when I get more and more number of failure cases or secondary cases, or when there are poor vessels and you try to avoid a Steele syndrome or a high output failure, so I try to search the articles. What can be the answer to the problem? And sometimes what happens when you think that I will do some new things, to the utter surprise it is already published. And it has always been done by some other people. Thing is that we are ignorant, we don't know. So if you go to the article, review of the article, from 1977 up to 2006, there are so many articles which suggest that proximal radial artery can be used for AV fistula creation rather than a brachiocephalic. And another thing is that we, being the plastic surgeons, we are always used to be habituated with harvesting a radial artery forearm flap, or in the emergency we do a lot of cases where we repair the radial artery. So why unnecessarily to go to the higher brachial elbow level? Because in my experience I have seen whenever the patients are being done brachiocephalic fistula by some other surgeon or other specialty doctors, they come with massive edema of the upper arm, because usually the patients flex the elbow because the incision is very close to the elbow. This is the practical problem. Even I have seen massive edema of the limbs leading to necrotizing fasciitis. This happens. And the most common another problem is there will be lot of seroma or lymphoria. There will be lot of swelling if you do the brachiocephalic anastomosis. So I thought that I will be doing the proximal radiocephalic fistula. And the literature shows that the proximal radiocephalic fistula has a good patency rate. 91% patency rate in proximal radiocephalic fistula compared with the distal radiocephalic fistula. And as it was being told by our intervention radiologist, the symptomatic ischemia, it is 10 to 20% case in case of brachiocephalic and brachiobasilic fistula, whereas the rate is only 4.3 to 6% in case of forearm AV fistula, and it is still lesser than the radiocephalic fistula. And the incidence of dialysis associated Steele syndrome is extremely rare following proximal radiocephalic fistula. So after I decided I will do the radiocephalic fistula, you have to go and read the anatomy. You have to be thorough regarding what is the venous system present, superficial vein and deep vein, and what are the communicating veins. Then we all know brachial artery divides into radial and ulnar, and since ulnar artery is the dominant artery and it is available, we can easily go for the radial artery anastomosis, and we are doing the end to end or the side to side. So this is the normal routine procedure how I do. You can use the vascular loops as being used. You can use the clamps, soft clamps, or if you are alone also, you can use bulldog clamps. There is no harm in doing anything. It depends if you have a good assistant or if you are doing alone. You can, for the proximal part that is near the elbow, even if you use the bulldog clamp, I don't find any difference in the anastomosis. And your quality of the clamp should be good, because if it slips, then there will be lot of oozing or bleeding, and if you are alone it is difficult to control. So that is how the end to side anastomosis. So after I did many things, I tried to publish it, and I compared my outcome of proximal radiocephalic fistula with distal radiocephalic fistula. And what I did, because I was getting lot of failure cases and I wanted to publish, I wanted to select which cases I will be doing the distal radiocephalic fistula and which cases I will be doing the proximal radiocephalic fistula. So if in the ultrasound I will do radial artery size is more than 2 mm at the wrist, flow rate is more than 40, cephalic vein diameter is more than 2.5, there is no thrombosis, I will go for the distal, otherwise I will go for the proximal. Another thing I have found that I will be also showing, sometimes a good ultrasonologist can say whether the vessel is calcific or not. That is also an important factor for any microvascular anastomosis, because these patients are diabetic, these patients are hypertensive, there is usually also associated with calcification of the walls, and calcification of the walls, the anastomotic technique is little bit different from the normal anastomosis. So these are my results. So coming to the results, the early failure in proximal group was 6.06, distal it was more. The late failure was, in my hand, it was mostly due to pseudoaneurysm, and the rate is 6.06% in proximal radiocephalic fistula, and distally it is 10%. Steele syndrome, none of the patients had any Steele syndrome. The hand edema, it is more in case of proximal radiocephalic fistula. There is no case of any wound infection or dehiscence. But the primary patency rate in proximal radiocephalic fistula was 87.87%, whereas in the distally it is 70%. This is how you should always talk with the radiologist. Sometimes we send for the Doppler ultrasound of the right upper arm or left upper arm, but the radiologist may not give the detail. You can write in the requisition, kindly specify what is the diameter of the radial artery, what is the diameter of the ulnar artery, what is the flow rate, and whether there is any calcification or thrombosis. As you can see in the report, he has specifically mentioned the arterial wall is calcified with thrombosis seen. So it was a case of failure case where the distally the radiocephalic anastomosis was done. So if the ultrasonographist, if the radiologist give this information, it makes your life easier. So these are my studies. Our results were mostly comparable to other studies, and it is already been cited also. So some of the points which I want to highlight, that in our experience, what I have found, the pseudoaneurysm was the most common cause of lead failure. You have to remember that when if you are talking with your dialysis technician, you have to tell them or you have to guide them how they should prick. What happens after pricking the catheter, as some sir was telling, you have to press the point of needle insertion. Otherwise what happens, leads to a formation of a pseudoaneurysm, and that pseudoaneurysm can also get infected or it may rupture, and the patient may come to you after one dialysis has been done by some other, and he may think that it is the fault of your surgery, but actually it is not the fault of our surgery. After he is getting dialysis is being done, because of the formation of the pseudoaneurysm, that may rupture and that may get infected. So be careful of this situation and know, so that you can tell the patient it is not our problem, it may be due to other problem. You don't blame others, but you know what is the science behind it. So this is the example of one case. So he came late, it was infected and it ruptured, but again you have to ligate so that bleeding will be controlled. Then incision. There are two types of incision you can use. One, you can use the longitudinal incision or the transverse or curvilinear incision. But if you do the transverse incision, if you know, the lymphatic vessels run longitudinally. So if you cut all the lymphatic vessels by giving a transverse incision, so the chances of lymphoria is more. So I use longitudinal incision, and if I don't get the proper exposure, I make it into a S-shaped incision. So this depends on your practice. So this is my experience. Now what is between side to side and end to side? Theoretically, why we should prefer the end to side anastomosis? Because end to side anastomosis has less chance of spasm, and the much studies in systemic review and meta-analysis have shown that end to side anastomosis has similar rate of maturation and the patency rate as compared to the side to side anastomosis, but it is technically little bit difficult. But once you master it, end to side anastomosis is equally effective. And the end to side anastomosis has proximal venous flow and low risk of venous hypertension than the side-to-side anastomosis. So then theoretically it has been described that there can be carpal tunnel syndrome or medial nerve compression because of the brachiocephalic fistula, but in my experience I have not encountered till date. So my results, what I have already described, it is quite similar to the studies done by others who do proximal radiocephalic anastomosis. The only difference in my study was that it was surprising that all of the other studies showed they were doing the side-to-side anastomosis. But since I was doing end-to-side anastomosis, it was published. So it is already cited and it has been also been included in one of the systematic review and meta-analysis done by the nephrologist in seminars of nephrology. So regarding one of the techniques, what I can say that in end-to-side anastomosis you can use interrupted suture or you can use continuous suture. But when you are alone and your assistant doesn't know how to cut, so you can use the backward fast technique, do the continuous suturing so that it will save the time, as well as theoretically they say it will cause a posting effect, but actually it doesn't cause, because proximal radial artery and the brachial artery, they are very high flow vessels. So you have to prevent the leak and do the continuous suture backward fast technique. Then you can see the anterior wall, and anterior wall also I take the anterior continuous suturing. You can stop and do the anterior wall interrupted technique, but that hardly makes any difference. So the take home message from my experience is that use the proximal radial artery if the distal artery is not suitable or it is a case of failure case, because even if the proximal radial artery fails, you have another option of going higher and do the brachiocephalic. It has less chance of steal phenomena, it has least chance of lymphoria, it has least chance of edema. So I do longitudinal incision or a curvilinear incision. And for proximal you can also use 7-0 suture, because distally we usually use the 8-0 suture, but the proximally the vessel flow is very high. So if you take a little bit higher suture like 7-0 suture, there is no harm. And many 7-0 suture used by the CTVA surgeon with double arm needle is also very good. Thank you.
Thank you so much, sir. Now, yes. Now we'll continue with the live OT demonstration. Rest two cases are still left. One is Greg's fistula, which sir was explaining about in the earlier sessions. So we will go there. But meanwhile, I would request Ranjit Sahu sir to kindly just felicitate Ranjan sir.
After that, we will come and tell about one talk, and the next talk will be tomorrow. Is it okay for us on the last two cases we are going on? You want to see those two cases?
Hello, can you hear me?
Wait, kindly wait, Nikhil. Kindly wait. Now I will request Sanjay Kumar sir to kindly felicitate our Tara sir.
In a minute, we can take it.
Yes. Now I would request Biswajit sir to kindly come on to the dais.
Then go to the OT. Yeah?
Thank you so much, sir. Now we'll be continuing with our next two cases in the live OT demonstrations. Kindly OT1 take over.
Am I audible? Hello?
Yes, you are audible, Dr. Vidush. You can continue.
Yeah. This is the next case in our OT1. So this is a 55-year-old male with a case of chronic kidney disease of stage 5 since 6 months duration, who has been on hemodialysis since the past 1 month. He is a known case of hypertension. He is a right hand dominant person, and we have planned a surgery on the left upper limb. All the three arteries, the brachial, radial, and ulnar arteries, pulsations are good. Allen's test is positive. Visible veins are prominent, and he has a hemoglobin of 8.7. This is his Doppler report. We have planned him for a proximal AV fistula, the Graax procedure, or a brachiocephalic fistula proximal, based on the intraoperative findings.
Just wait.
We will quickly listen to the case details of the OT3 case, which is going to start now. Kindly OT3 take over and explain the details.
Yeah, okay.
Here we come to a last case.
So good evening everyone. So this is a grass fistula that we are trying to show here. I have taken and I'll show you the incision. This is the cubital fossa. So the incision is again S-shaped below the cubital fossa line. This is the aponeurosis of the flexor, common flexor origin, the FCU. And once you reflect the skin flap here, this is the cephalic vein. Can you see the cephalic vein? I can't see anything. Where is the skin? Oh, that's there. Am I audible? No, it's not working.
Yes, sir, you are audible. You can continue.
Okay. So this is the cephalic vein here, just below the elbow. And the Graax fistula was described basically by Graax in I think 1977, if I'm correct. And it was a proximal fistula. So the next fistula that was described, the Brassica semino fistula, was described in 1966. Following which, this was the next proximal fistula that was described by Dr. Graax. And you can see here, this is the cephalic vein. Now this fistula, either Graax fistula is basically a radiocephalic fistula at a proximal foramen, or you can go slightly below and do a proximal foramen fistula like Dr. Vibhuti showed you, I think, in other theatre. The whole idea here is, if you have a brachial artery and if you do a brachiocephalic fistula in a patient who has got very narrow radial and ulnar arteries underneath, towards the wrist, there are very high chances that steal phenomenon will develop. Now to reduce that steal phenomenon, what we need to do is lower down the fistula and join the cephalic vein with the brachial artery. Now if your cephalic vein is thrombosed in the entire forearm, still you can do this fistula because, I will show you a perforating vein from the branch, it's a branch of, see this is a cephalic vein. Can you see this branch which is going down? See, this is the cephalic vein, and this is the branch of the cephalic vein which is going down to the vena comitans of the radial artery. So you trace this vein, and you can see this is the vena comitant, it is joining with the vena comitant. Can you appreciate that? I don't know whether camera is seeing that.
Yes, sir.
See, this is the cephalic vein which is joining with the vena comitant of the radial artery, and this is the radial artery here. So now we are going to do the anastomosis of this perforating branch to the cephalic, to the radial artery end to side, and then ligate this cephalic vein which is going towards the wrist side. Okay, so that's a Graax fistula.
Okay, sir.
Very technically little more demanding because the dissection is deep inside. मस्त दिख रहा है. It's going and communicating with the vena comitant of the radial artery. एकदम परफेक्ट है.
OT3, are we audible?
Yes, yes. Just can you see the case capsule?
Yes, it's visible.
Can you see the case details?
Yes.
Yeah. Okay. So we are here to wind up with our last case of OT2 for today. This is a case of 20-year-old girl with rapidly proliferative glomerulonephritis for the last 4 months on hemodialysis, and she is immunosuppressed. Allen's test is normal. She has good visible veins, and her creat is 4.4. Her elbow cephalic vein is 2.5 centimeters, and brachial artery is 3. So now we are going to we are exploring. We have started exploration in the cubital fossa region. Screen. So plan is to do perform a proximal AV fistula, brachiocephalic or radiocephalic proximal fistula. So the exploration is going on. Cephalic vein is being dissected.
फील दिख रहा है ये सर ठीक है इसलिए लूप आया हाँ लूप पापा भी yeah, all of it was quite Scrub out. What the?
ప్లేస్ లేదు అవుదామన్నా కూడా చేయడానికి. Yeah, bro.
This is not very commonly done.
Yes, so we already have a, pull this up. Yeah. Just give a gentle traction, yeah, that's good enough. Yeah, okay. So this is a perforator from the cephalic vein. And this is what we are going to do end to side with the, so give me a clip. Open the perforator and see if it bleeds, yes.
This cap, that cap is all in the picture.
My cap? Okay. Scissors, micro scissors. That's good. Flush. क्या है निकाल लेना हाँ to feel for the thrill on the arm. Yeah, okay, clamp. The clamps are coming off. Huh? This radial artery clamp has already come off. Okay. Give me this separate clamp. Okay.
ये मत सर हो जाता है बस हो रहा है ये मत ये नीचे नहीं
So I'm trying to see if this comes directly up, little bit of mobilization, if it is possible. If we gain additional length of about 1 centimeter, then we will be able to take out all these branches here. छोड़ो इसको मत छोड़ो because this is the main thing. Yes. So you can see the ulnar artery.
Yes, sir.
दिख रहा है?
Yes, sir.
So the ulnar artery is going down. This is the radial artery. Yes. Yeah, this is good. Hold it like this.
Sir is taking so much effort to reduce the tension on the vein.
Yes, Kumar, you are absolutely right.
Yes.
I am trying to, cut the vein slightly shorter, way beyond, way above these two clamps, so that I get a. And I think I can do that. Give me scissors.
if there is any tension on the vein, the configuration of the anastomosis changes.
It will be difficult to do with the two clips there.
Yes.
So for sir, can I continue some conversation with the here? Yeah. So most important thing is that AV fistula is OPD procedure. Patient comes walking for the surgery, so patient should not die. Okay. Patient has come walking for the surgery, so patient should not die. How can patient die? If dialysis is inadequate, patient is breathless. As Parag sir told in the morning, patient should not be breathless in supine position. Okay. We specifically ask, can you lie down for an hour?
Sure.
Okay.
One this clamp, one that
Hospital,
side. So that
hospital should have
my way.
in-house dialysis facility.
Sure.
It has happened to me that that hospital was not having dialysis facility and patient became breathless. So I had to arrange numbers and shift the patient to a government hospital. Okay.
Micro scissors.
I am not, everyone is not as fast as sir. Okay. So I prefer to use lignocaine with anavin, bupivacaine. Okay. Time does not matter. We should have best results. Okay. After how many days can we use the fistula for dialysis? It is absolutely clinical decision, usually taken by nephrologists and the dialysis technicians. Initially, they use only one pressure. Later, they put. Okay.
वही बोल रहा था सुबह से एक भी एथेरोस्क्लेरोटिक आर्टरी कैसे नहीं मिला.
What is the significance of color pens? Why?
अरे हीरो मत भाई.
Why do I carry these pens?
ये खराब हो गया. दूसरा फोर से है.
It is important. It is important to, after the surgery, I write OT notes myself. I draw a diagram exactly depicting how the anastomosis has been done. It is end to end, side to side, whatever it is.
Okay, give me
which artery has been attached to which vein.
Suture.
So it is important to carry pens and write our own notes. Copy paste computer notes are good, but if we need to re-explore the patient aneurysm or any complication occurs, we should know exactly what we have anastomosed. Okay. Many seniors follow this, that if there is on table thrill is not there, they'll do a proximal fistula. Before an hour also we saw. If thrill is not there, because it is very cumbersome for the patient to come again for another surgery. Government hospital does not matter much, but private hospital, patient will have to pay again for the surgery. And it brings lot of disrepute to us. Okay. Many other people are doing AV fistula surgery. One of my senior teachers told me that he is not doing because patients are hemodynamically not stable. Their healing is not good. Okay. then why? That is one of the reasons that plastic surgeons should do it, because we are usually able to handle such patients, even if the skin is not good, even if other, because we put lot of effort, we put lot of time, we are not in a hurry. Okay, so this should not be compromised. Even now, after around 8-9 years of completing MCH, I am doing complete surgery myself, from anesthesia to dressing to suture removal, even skin sutures. Sometimes while taking skin sutures, the needle can pass in the vein, so we cannot leave. This is not a minor surgery. This is not a minor surgery. This is someone's lifeline. Okay. Don't consider AV fistula as minor surgery. How much patient is paying is immaterial. One patient giving 5,000 today can bring a 50,000 private hospital deluxe room patient later. We are investing in building reputation for our fraternity. All our brothers, like it, AV fistula मतलब प्लास्टिक सर्जन सबसे अच्छा करते हैं, ऐसा होना चाहिए. ठीक है. माइनर सर्जरी नहीं है, असिस्टेंट ने करना आधा नहीं है. ठीक है, क्योंकि उस it is very important for that patient.
See, when you have atherosclerotic vessels, try and take slightly bigger bites, okay, away from the edge. कट थ्रू होने का चांस थोड़ा कम रहता है, और प्लाक भी सेपरेट होने का चांस कम रहता है.
These small vascular clamps, sometimes blood clot collects in between the prongs, so we have to remove them with hydrogen and periodically replace.
So if you can see here, what I've done,
yes sir,
is I've converted the backhand into forehand, even for the posterior wall, because it is not possible. It's better that we do it. Yeah. Am I audible?
Yes sir.
Yeah. See here, so first time in a day we have found an atherosclerotic vessel, and as you can see the anastomosis is deeper. I hope you are able to appreciate the atherosclerotic vessel. I don't know whether you have a clarity here.
We can see that.
Yes sir.
Yeah.
The vein
So
is quite
when I take a bite, normally we take bite very near to the vein wall. I mean the edge of the wall, right?
Yes sir.
This edge, vein edge. Whenever you have an atherosclerotic vessel, try to take slightly bigger bites, so that you don't separate the intima from the adventitia, because otherwise the flakes will start coming out, and then it will be impossible for you to get a good flow across the anastomosis. The fistula is very likely to thrombose. So don't allow separation of intima. See where I am coming, can you see it?
Yes sir.
Okay, because you can see here is all intima plaque.
Yes sir.
If I take bite very near to this, it will cut through and it will start separating. And then you have more chances of pseudoaneurysm formation.
Yes sir. Sir, we reduced doing proximal radial because of difficulty in taking control of that small segment. Sir, in brachial artery, what is the size of arteriotomy you usually take?
5 to 6 mm.
Okay, sir. Do you measure it or eyeball it?
No, now eyeball it. Initially I used to measure it, but I have got a rough idea now. So normally it is 5 mm.
Okay, thank you, sir.
But if you have a vernier caliper, you can actually measure it. It will be good that you measure it.
Sir, I have started measuring. how to find a patient for AV fistula. You have just passed out. You go to your city or any XYZ city. Then why would people send patients to you? Yes. And go and meet in all the dialysis centers. Meet technicians. Meet nephrologists. Try to do few cases under any state government scheme or central government scheme where you can show your skills. If people see your results in free cases, then they'll send you the paid cases. First, they need to see your skills, positive results. Okay. Start. What helped us a lot was doing it as a teamwork. Two of us started doing this together. Even in free flaps, now people are doing joint practice. 2-3 people join and do free flaps. One person harvests, another does anastomosis. If someone is caught up somewhere, re-exploration is needed, one person can go in. So it reduces financial stress. That is more important. We cannot fool the patients. So try to spend time explaining all the possible complications to the patient. Even if patients run away. All the patients I'll tell about Steele syndrome. Your hand might turn black. Your fistula might fail. We might need to do a proximal fistula. Tell all these things. Even if they don't get the surgery with you, they go somewhere, get operated. In case they'll end up with complication, they'll come back to you. Because you were honest with that. If you get any complication, what to do? If your patient gets an aneurysm and patient is not having money, so we should manage our own complications. But make patient pay at least some part of the fees. Some part. Don't make it free. Otherwise, they'll feel that it was your mistake. You are getting my point. If for aneurysm the hospital is charging 25,000 rupees, try to convince them to pay. Tell them that 15,000 will arrange through a trust.
Atherosclerotic vessels, and forearm vessels are to sing, then this is a good fistula to do. Cephalic venous thrombus in the forearm. So what will you do? And you cannot do a brachiocephalic here because chances of Steele are high. Then this is the best procedure.
In an artery, it can happen that a small part is atherosclerotic, then there is a patch of normal artery, then there is another atherosclerotic part. Getting my point? So we can increase the incision and look for an in between normal looking artery. Okay. As we go proximally, calcifications tend to reduce. Usually, not always. Where we are doing arteriotomy is also important.
Oh, and there only. Take.
You're getting my point. Vein is on one side. Okay. We are doing arteriotomy on the other side. It won't work. We need to side the arteriotomy properly. There should not be any tension. Where to sit while doing fistula? Where to sit is personal choice.
Okay. Leave the thread to me.
While doing distal fistula, we can sit we can sit on the side of artery. It depends on where we are taking the incision. If we are taking incision near the artery, we need to raise a flap to find the vein. So we need to sit on the side of artery. You are getting my point? If we are doing radiocephalic AV fistula, hand is like this. So if we are taking incision on the near the radial artery, we need to sit on the ulnar side.
अरे भैया 2 मिनट हो गया भैया हिलो मत आप क्यों हिल रहे हो
Clear or not? We sit on the ulnar side. We take incision near the radial artery and we raise the flap and dissect the cephalic vein. Okay. Here it is very important that there is some accessory vein many times, which is ulnar to the main cephalic vein, and main cephalic vein is
we'll need to take one stitch there.
Posteriorly. So we should not take that vein.
Stitch है क्रैम नहीं चाहिए stitch दे दो खाली
Every time before the surgery.
अरे यार तुम बहुत ही हिलने लगे अभी पहले तो थोड़ा तो शांत बैठे थे
We should palpate that.
Keep here.
We should not take the smaller vein. We should try to find the nerve, and the vein is usually lateral to the nerve. Clear? Okay. So while doing proximal, if I want to attach brachial artery with the cephalic vein, where would I sit? I would still sit on the ulnar side.
That's better.
If I want to find the basilic vein, I might sit on the other side. If we are operating on the right side, similar. Okay. If we take incision near the artery,
From the last right side.
lot of time is spent on the artery.
नहीं पूरा मॉप करो ना उसका अच्छा अंदर
That is why it is easier to
रुको कुछ
manage.
टाइम
Less retraction.
Now I want to see. Flush करो अभी. Yeah. Okay.
Many people use mastoid retractors, self-retaining, to reduce the work of assistant. But we usually don't use. It is equally important to train our nursing staff, because our skilled friend might not be available. If we are doing the same procedure again and again, our nursing staff becomes very much trained. So in case of emergency, they can help us. Anything else you want to ask? All cases we should touch. It does not matter. At least proximal and distal, we should. All the procedures done here can be done by any MCH plastic surgery person.
See there?
Why I asked about steel, the size of arteriotomy in brachial artery was because of the steel phenomenon.
One clamp here. Okay. Take the thread.
If patient, our rapport with the patient should be such, if patient is having any problem, they should come to us. They should not go to someone else. Because of one, I have done dressing for 50 rupees, I have done dressing for 100, 300, 500 rupees. But my patient's dressing I do.
You're pulling the vein. You're pulling the vein.
If they have any problem, they should inform us, not go and inform in the whole world. Okay?
I'm trying to see if there is any branch which
For
here,
that, we need to spend time.
which is likely to, which can develop into accessory, no? यहाँ से भी जा सकती है ना कुछ branch. Incision में से
Steel is a very
जितना
bad
explore
thing to
करके देख
happen.
सकते हो
Aneurysm
उतना
is a bad
देखो.
thing to happen.
That should be it. आए? थ्रिल? करो करो मेरे को ये दे मिल करने के लिए दे देखना साइज का वेन देखना आएगा यहाँ तक आएगा आया ऊपर नहीं नहीं ये वन मोर फोर्स से आएगा so you can see here we have done this is the medial edge of the aponeurosis and this is an intraside radio perforating vein fistula. This is the main cephalic was going down like this, which we have clipped, and this is the perforating vein which is we have anastomosed with the radial artery.
Yes, sir.
So get a Doppler. You can see the Doppler. I think you can already see the cephalic vein here. Let's get a Doppler done and see. So you can do it from outside. Do Doppler here on the vein. Move proximally. More proximal. Lateral. Yes. Yeah. So can get almost up to the upper arm. ठीक है, क्लोज कर दो. Thank you.
Thank you, sir.
बंद किया है?
We will now move
Technically
on
more
to
difficult to
OT3. OT3, are we audible?
Muscle mass is less at wrist and cubital fossa, so it is easier to dissect the artery. Vein is superficial anyways, but mid forearm it is very difficult to dissect because of the intramuscular dissection. Okay, but still we have to do sometimes. In like, can you see it here? If there is a vein, cephalic vein, which is good from mid forearm, but it is draining into basilic vein, and in the arm cephalic vein is not good. So in such cases we would still do in mid forearm, because if we do proximally then we will have to do a basilic transposition. Okay. There are many times multiple branches, like instead of a single cephalic vein in forearm there are multiple branches, so we have to take the dominant one, or otherwise we'll do directly proximally, because patients get irritated with additional surgery. But on the contrary, if there is a single vein, one very important point was mentioned here, all the data of 2 mm, sir has done a study. So if the vein is less than 2 mm, chances of success are less. So discuss with your nephrologist and patient. Patient has come to us only for a month till the fistula starts working, but he is nephrologist patient for whole life. So it is very important to involve nephrologist in each and every decision making. If the nephrologist, as sir said, exercise doesn't help much, but if nephrologist is asking to do exercise, ask patient to do exercise. Don't cross what they are telling. Don't negate what advice they are giving. If they are asking not to lift weight, everything is yes sir, because they are the one who would decide who is going to do the AV fistula. Okay. Now even nephrologists have started doing AV fistula.
Hello.
At many places.
Are you audible at the auditorium? This is from
Yes sir.
Yeah. So Dr. Sandra has performed side-to-side.
Yes, Dr. Surya, you are audible.
Yeah. So we had done a side-to-side brachiocephalic anastomosis. So as we can see, this and this is the hello. Am I audible?
Yes, Dr. Surya, please continue. You are audible.
Hello, am I audible?
Yes.
I'm Dr. Shantanu.
Yes, sir, you are audible.
So we did we mobilized. This is our. Can you see?
Yes, sir. Both audio and video are clear, sir.
This one is cephalic vein, okay?
Okay, sir.
And this is the cephalic vein terminal end, which
did a side-to-side brachial artery to cephalic vein fistula. Okay.
Right, sir.
Can you see?
Yes, sir.
So we did a continuous suture anterior posterior both layer. This is the brachial deep vein, brachial vein. And this is the
Yes, sir.
brachial
We are
artery.
able to
We
appreciate.
did an side and we can able to feel the thrill.
Right.
Okay.
Yes, sir.
Distally as well as the proximally. So this lady didn't had any good vein in the distal forearm. So we went ahead to explore the cephalic vein proximally, and then we got good caliber of cephalic vein.
Okay,
and
sir.
we performed side to side to the brachial artery to cephalic vein so that it works and later on all these veins are going to get prominent as well.
Yes, sir.
And it is going to help for this dialysis. Thank you.
Yes, sir. Sure, sir. Thank you. Thank you so much for the demonstration, sir.
So, is this visible? So, many times there is one vein, median cubital, and one branch is going to the cephalic, one is going into the basilic. If we are able to get an adequate length of common vein, we anastomose that with the brachial artery. Getting my point? So the benefit here is that lower 1/3 of arm, even basilic vein is superficial, as sir explained. So both cephalic and basilic veins can be used for dialysis. Both limbs can be used for dialysis. One situation. Other situation is if in future cephalic vein thrombosis for some reason, we have already dilated basilic vein that can be transposed easily. Understood? Okay. If a patient is having, I am just giving some clinical scenarios. If a patient had distal AV fistula, it was working and it thrombosis for some XYZ reason, then we can do, and the thrombosis is around 3 to 4 centimeter only. Then around at the junction of distal and middle 1/3 of the forearm, still muscle mass is not much. In a thin patient, we can do AV fistula there. And 3 or 4 of my patients refused to get the central catheter. They restricted water intake, and they could do the dialysis again from the same, because the vein was already mature. They could do the dialysis in 4 days, 3 to 4 days only. But it is usually not recommended. Usually at least we should wait for 8 to 10 days or 15 days before starting the fistula again. You got the point? Distal thrombosis, 3-4 centimeters. Ideally what we should do? We should get a central catheter and do a proximal, do dialysis from there and do a proximal fistula. But these patients were stable, hemodynamically stable. They restricted their fluid intake. They refused. It was on patients, and within a week's time, less than a week's time, they could use the fistula again. But usually we ask to wait for 1 to 2 weeks time, because it is already dilated vein. It matures fast. No. It is a patient who had a distal fistula that was working for 1 year, 2 years, 3 years. It was already working. He had recent acute onset thrombus. Okay. We ask, okay, if our patient has acute onset thrombus, he calls that doctor sahab, fistula 2 घंटे से काम नहीं कर रहा है. Then what would you do? Call him to our clinic, get a Doppler done. If it is acute thrombosis, then we can ask our VIR friends to open it. This is theory. In practice, fistula in a trust hospital costs 14,000-15,000 rupees. Any VIR intervention would cost more than 1.5 lakh. Any online intervention would cost more than 1.5, 2 lakh rupees in private. So many patients electively opt not to go for that, instead go for a proximal fistula because of financial reasons. Otherwise, we can refer them to a government hospital if we have our friend. But here time is very important. Like, we should not delay it much. So earlier the better. I have seen fistulas getting recanalized and again working for many years. But they should reach the hospital. It should not happen. चिट्ठी पे लिख दिया भेज दिया से काम नहीं होता है. If we want the fistula to survive, we should call a friend. We should talk to someone and then send the patient. Patient should not roam around here and there.
Thank you, sir.
Thank you.
Thank you for your insights, sir. Now we are done with our OT Live workshop. Moving on with the lectures. I would now like to invite Dr. Unmesh Jena for his talk, From Thrill to Emotional Grill, AVF Complications and Management. Sir.
Thank you very much for the invitation. Actually, probably it is towards the end of the session, and this is the complications of management of fistula is almost kind of repetitive, and that's why I have to change many of the slides catering to the need of the hour. And I know I'm standing as a barrier to the dinner as well. So this is AV fistula thrill to emotional grill. How is it important to us? So this is a marriage between a artery and a vein, where I have shown this as Mr. Arjun artery and Miss Veena vein. And the priest is the plastic surgeon, of course. And from high pressure to low resistance, from pulsatile ego to compliant love, a lifelong anastomosis begins. So the chief priest and matchmaker, obviously, we should be pleased enough that we, respected plastic surgeon Ji, venue is the operation theatre, and the Kanyadan is the donor vessel, and the Saath Phere is our 7 interrupted sutures, maybe 7-0 as well, and Sindurdan is by heparin flush, and Mangal Sutra is the final knot securing the anastomosis. So the dress code is OT scrubs, sterile gown as well, reception is tea and biscuits in the recovery room, which we have all taken in the snacks, and obviously kindly bless the couple for a patient, lifelong complication free circulation. So Department of Plastic Surgery, and extension is 108. Thank you. Then the grill part comes. I have put this as an acronym. Grill is nothing but what we eat as a chicken, but this is a different grill, where the G is for growth of aneurysm, there is venous dilatation, pseudoaneurysm and risk of rupture. R is for reduced flow, thrombosis, which you have seen before. The radiologist and nephrologist have shown you. This is stenosis, clot formation and access failure. And I is infection, where the local cellulitis, abscess and septicemia happens. And L is limb ischemia, Steele syndrome. And L is load on heart and high output cardiac failure. So the overview, importance of AV fistula in hemodialysis, high flow vascular access and gold standard is incisions. Usually we have normal size, more than 2 centimeter size incision is a normal. Small size we use 1.5 to 2 centimeter size incision, and very small is 0.5 to 1.5 centimeter size incision when the other areas are not much accessible. So this is a small incision which I had tried before. I had a incision, complete incision marking here to have a full access to the brachiobasilic, of course, but it has to be, it was within 2 centimeter size, and the objectives is understand the complications, recognize the early signs and management strategies. So AV fistula scenario in corporates, I want to, because I am in the corporate, first objective, recently here Kumel sir was telling about what are your main objective? First, to get patients, and how? That is, of course, to please the nephrologist. Third is to convince the patient. Once the patient comes to you, you have to convince the patient that how to work out and how well you can explain your complications to the patient. As already Kumel sir already told many of the things to you, I was listening over there, and how well you explain your complications will solve half of the purpose and make the patient yours. And fourth is to prevent the patient going to other specialty as well, because if you haven't explained properly, that is going to definitely to urologist or CTVS surgeons. And AV fistula rule of 6, I have put it in a pic. Flow more than 600 ml per minute. It's a repetition, I know. Diameter more than 6 mm. Depth is less than 6 mm from the surface. Palpable thrill and is usable in 6 to 8 weeks. But still, once clinically you can see, then only you can clinically use the AV fistula. So clinical assessment, this is the best music which the plastic surgeon can hear in his life. That is the thrill and bruit. So you have to look, feel and listen the AV fistula thrill. And what is the normal thrill? That is the palpable continuous vibration, and it indicates patency. So when the thrill changes, well, reduced or absent thrill can bring you emotional grill, whatever mentioned before, suggests thrombosis or stenosis. So complications of AV fistula in a PIC can be mentioned here. Early AV fistula, the infection, hematoma, stenosis. Then late complications may be thrombosis, Steele syndrome, which is already mentioned before, reduced blood flow to hand, heart failure, and aneurysmal rupture. So bleeding post-op or dialysis related. Management can be compression and surgical control. Hematoma due to leakage or puncture may compress fistula. So this is all the complete concatenation of everything whichever are being already discussed before. Infection can happen, local redness, discharge, requires antibiotics. Thrombosis, common cause of failure due to stenosis. And we do thrombectomy, anticoagulation and revision if thrombosis happens. And stenosis, narrowing of the vessel leads to decreased flow. Doppler ultrasound angiography can be done to diagnose. Angioplasty we can refer, and surgical revision. So this is a AV fistula complication and clinical syndrome. Common issues which already shown by previous authors as well. Steele syndromes, we know. High output cardiac syndrome, morphological and structural syndromes, and also neurological compression syndromes, which is carpal tunnel syndrome and cubital tunnel syndromes are the rare complications that can happen as of we have seen. And venous hypertension syndrome as well. So aneurysm formation, another repeated puncture sites, weakening of the wall. Clinical features of aneurysm, there is bulging, thinning skin, risk of rupture. Steele syndrome, already discussed before. Distal ischemia, pain, pallor. And management of the Steele. What is Steele syndrome? As we know, there is increased fistula flow over here and increased fistula flow in the hand. And urgent warning is numbness, extreme coldness, or blue tint is a medical emergency, and nerve damage can be permanent within hours. And surgical options, that is plication, banding, and surgical management options as well. Plication, Rudy, drill, everything is already discussed. So it is just for the completion of the slides. And high output cardiac failure, that is increased preload and heart strain. Management of cardiac issues, flow reduction, closure if severe. Venous hypertension, management of venous hypertension is relief, obstruction, and compression. So pseudoaneurysm, it is a pulsatile swelling, ultrasound guided compression can be the treatment of choice, and surgery as well. So this is a pseudoaneurysm. Conservative treatment can be ultrasound compression sometimes and thrombin injection, and surgical intervention can be aneurysm, resection and repair, and fistula ligation. So what are the skin complications of AV fistula? That is dermatitis and itching, scarring and buttonholes can be, aneurysm and pseudoaneurysm. It can then infection, cellulitis and abscess can happen. And Steele syndrome, fingertips, that is a reduced blood flow to the hand, can cause cyanosis, and venous hypertension, which will have a brawny induration over the. So management of skin issues like wound care and plastic surgery involvement. A role of plastic surgeon is soft tissue coverage, salvage procedures. Prevention is proper site selection, aseptic technique. And dialysis care, we have to rotate the puncture sites, avoid trauma. So what are the patient education, arteriovenous AV fistula surgery do's and don'ts? We need to keep the arm elevated, check the thrill, listen for bruit, do finger exercises, and keep the incision dry. So what are the don'ts? No constrictive jewelry, no heavy lifting. This actually we have to explain on the bedside after doing the surgery. We cannot tell them, we cannot hand over a do's and don'ts file or a do's and don'ts paper to them because they are not going to read that. So you have to explain it, you have to properly educate them before leaving from the OT table, and also you have to explain them to the patient's attendant as well. So no constrictive jewelry, no heavy weight lift, and no blood pressure readings. Avoid smoking and don't sleep on the arm prescribed. So conclusion, early detection saves the fistula, multidisciplinary approach. And of course, nephrologist is our king, radiologist as well. Nephrology JRs also sometimes they play a vital role. So we have to please every one of them, and hope plastic surgeons are in the center and they will obviously be leading to do the AV fistulas apart from CTVS and urologist. Thank you.
Dr. Parag and Dr. Giri sir are on their way. We are expecting them, and Dr. Parag will be delivering a talk after that. Meanwhile, if anyone has any questions.
So what are the signs of ischemia of the upper limb? What are the sign symptoms you will inform your patient? पेशेंट को उसकी भाषा में समझाना है कि उसको कब मालूम पड़ेगा कि तकलीफ हुई है. सूजन इस्चेमिया में क्या क्या होगा? स्टील हो रहा है पेशेंट को कैसे समझ में आएगा? पेन होगा और नमनेस होगा और पैलर होगा और पल्सनेस तो अपने को समझेगा. और हाथ पैर ठंडे पड़ रहे हैं, हाथ पैर सफ़ेद हो रहे हैं, हाथ में दर्द हो रहा है जो दवा से कम नहीं हो रहा है. ये कब बताना है? ये पहले दिन पेशेंट आता है तब बताना है कि ये कॉम्प्लिकेशंस हो सकते हैं. सिंपल टर्म्स में हम ऐसे बताते हैं कि अगर हमने जॉइंट छोटा कर दिया तो फिस्टुला फेल हो जाएगा. हमने होल छोटा किया, घर के सामने पानी की पाइपलाइन होती है, उसमें होल करके अपना पाइप डालते हैं, वैसा हम फास्ट लाइन में होल करके स्लो लाइन जुड़ा रहे हैं. ठीक है, होल छोटा हुआ तो फिस्टुला चलेगा नहीं, और होल बड़ा हो गया तो ज़्यादा खून उसमें चला गया तो फिस्टुला में नहीं है, तो हाथ में खून नहीं पहुंचेगा. तो ये समझ जाता है पेशेंट.
Thank you, Parag sir. Thank you, Vibhuti. Now, I would like everyone to give a huge round of applause for a wonderful live operative workshop. And thank you so much, sir, for your time and your skill be demonstrated here. Thank you.
We have completed all the 8 cases. So please, all 8 cases, 4 by Vibhuti sir and 4 by Parag sir. And all the types, I think, sir has shown, Parag sir has shown everything. And whatever has left, sir has told tomorrow he will demonstrate in the video clips.
Yes. So we had the opportunity of getting to see the side to side as well as end to end and end to side obviously, and even the Greg's fistula. So we are very fortunate, sir. Thank you so much. Thank you so much, sir.
Thank you, sir. I would now like to invite Dr. Giri, sir, to felicitate Dr. Unmesh, sir. Yes, sir. Sir, the stage पे आ जाइए.
वो वहाँ से आ रहे.
Thank you for coming and giving your talk. अभी वो शुरू कर दिया है उनमें.
I would also request Dr. Giri to kindly felicitate Dr. Kumil Syed, sir.
He has come from a long distance and today he is also leaving. So tomorrow is Eid. Thank you for giving your time and coordinating.
It's okay, sir. I'll put it down.
I think your flight is at 9 o'clock. 9:30. Thank you very much. All the talks will be done tomorrow. All the talks, whatever I've left, like complications, everything and all, tomorrow we'll along with the quiz and parameters and all the demos. Tomorrow now we can move for the dinner.
Okay. So we would like to conclude today's session at this point so that we can have a dinner together. And all the sessions today of the talks which are left, the panel discussion, quiz and the workshops will be done tomorrow. All the delegate list will be provided to you, like regarding the workshop.
He has put it 21 groups in the
21 pairs.
21 pairs.
Yes, sir.
Because 42 people are there. We have 20 tables are there.
So in
There's another one. So 21 tables are there and we can simultaneously do all this.
So everyone will be doing it simultaneously in a single session. So we have good amount of time tomorrow also. Yes. Thank you so much.
We can move for dinner. I think the dinner menu is given in your WhatsApp group. It's a good place. You can enjoy.
Thank you so much.
होगा ना कल पूरा अच्छा सब लोग होंगे ले चुके अभी क्या सीखा कम अभी आज सीख बच्चे
Ready, sir?